Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, everybody. First of all, I would like to welcome you in our 21st annual neonatology meetings, day 2. I would like to congratulate you and all of us for the winning of our Saudi soccer. Alhamdulillah, it was an achievement. Inshallah, kaman, the World Cup, inshallah, يكون من نصيب المنتخب. So without our further delay, there will be some modification in the program. So we'll start the second session, which is the neonatology quality improvement initiatives in the morning. And then the first session will be in the second one. So without any further delay, the NICU quality improvement is very important topics. And it has a very measurable outcome in the care of the neonatal ICUs. I have really a word. Maybe I remember it and I would like everybody to remember it. So in ICU without quality, like اللي يصوم وما يصلي. So it's really important. It's not only how to take care of the baby, just the quality of care you give it to that baby. So our first speaker is Dr. Nisreen Al-Kafi. Dr. Nisreen is a consultant neonatologist at King Fahd Armed Forces Hospital, and she is the head section of the NICU. She will talk to us about the NICU quality improvement initiative in the NICU. Dr. Nisreen.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Jabara, for the introduction. And I would like to thank the organizing committee for the invitation and give me the chance to present today about the quality improvement initiative in the NICU and the effect of the quality in the NICU outcome. First, I have nothing to disclose. And here is my talk objective, concept of quality improvement in the neonatal care, understand the variation in the extreme preterm infant survival and morbidity worldwide. Why do we need to collect data and where we are? What are the most important domains in the quality improvement of NICU? And what are the evidence of quality improvement initiative that having a positive effect on NICU outcome? Let's start with a bit of history, because we cannot talk about the quality improvement without acknowledging the guru in this field, starting from the Walter Shewhart. He's the one who developed the statistical process and run chart. In the extreme right, Edward Deming. He's the one who introduced the concept of quality improvement from the industry into the healthcare. And Don Berwick, he is a pediatrician from the Boston, and he is one of the leader in the quality improvement. As well, Professor Paul Batalden, he is from UK, and he has many contributions in the quality and patient safety. In the bottom of the slide, you can see a statement that's come from those leaders that pop up always in different slides, time again. Every system is perfectly designed to get the result it gets. We need to try or to work to improve. Otherwise, we'll not get the result change, and we'll get the same result, and things not will be changed. What is quality improvement in the healthcare? There is many definitions about the quality improvement. I find this one the simplest one. It is a systematic data-guided activity designed to bring immediate improvement in healthcare delivery in particular setting. Everyone comes to work and would like to see an improvement. So it is a deliberate defined process, which is focused on activity that are responsive to the local needs and improve health. It has to be continuous. It has to be an ongoing effort to improve. But at the same time, it should be result in a measurable improvement in the efficiency or effectiveness or performance or accountability or equity, and ultimately good outcome. Everyone thinks about the quality improvement, and there is a lot of idea come across the mind once we think about it. And different question also will rise: how to begin, how to start, where to start. There is many articles done by different people can help to initiate and to guide in the process of the quality improvement. Why do we need to improve quality? It's very important to see that the science progress so fast and the patient care does not follow. And here is the quality gap. So, there is pointer. And here is the quality gap that we need to fill and working toward move this curve toward the science. But as well, doesn't mean that we need to adapt every randomized control trial. We need to know what's the best to our center and try to do it and achieve it. What happened from 1970 to 2020 in the neonatal care? In 1970, we started the ventilation, CPAP. In 1980, we got the steroid. 1990, we started the surfactant. And in 2000, nitric oxide and ECMO. After that, since that, we are trying to apply what we know gently, avoid mechanical ventilation, integrate family into the care. And in the last decade, how to do it better, what we know, and how we can do it in consistent. There is humble of randomized trial in the neonatal care, but in the last 10 years, what we are doing is applying what we know to the clinical setting gently, and this is an quality improvement. Although there is always an effort to provide the best care, but still it is unclear how often we achieve this goal. Current literature demonstrates that there is a variation in the outcome and survival mainly of the extreme preterm infants. And they did this study over the 10 years, comparing the survival rate of extreme preterm infants, 29 weeks and less, in 10 different international networks. 10 countries involved, 10 international networks collaborate with the INO, the International Network for Improving Outcome of Neonates. And they compare the result over the 10 years. And as we can see, those variation. And here was the result. The Japanese neonatal network has a great survival, around 83% of extreme preterm infants. And in the Israel, 34, around 35%. Spain is around 36%. And there is a huge, this is a very huge difference. And as well, it affects on the total of the average of the international network survival. And this study, the key points from this study, that the survival and the morbidity were significantly high, the variation. And this variation was reduced over the period within the Canadian neonatal network. And over the 10 years period, some other networks, they have the same variation and they didn't change anything in the variation and in the outcome. It is very important to know where the reason of there is no improvement of the outcome and the variability, and what's the causes of the this variation. At the level of the organization system and the manager, improving extreme preterm outcome require concerted effort from clinician, manager, policymakers, and admin. Identification of facilitator and barrier to the system level that for the adverse outcome of the neonate is needed to meet the overall goal of improvement of the outcome and quality of care of neonates. It is nice to see some Saudi data, neonatal data from different single best centers. Here, Al-Qurashi et al., he showed the survival rate of the extreme preterm infants according to the gestational age. And Abu Fatouh et al., he showed the mortality rate according to the gestational age as well to the birth weight. Al-Hazani et al. As well, he showed the survival rate according to the gestational age and compared with the international neonatal network. Al-Tarqawi et al. As well, he showed the survival rate according to the gestational age in 2 different periods. Here is unpublished data in my center, the survival rate of extreme preterm infants less than 30 weeks. And still, with all these studies, we are seeing even in the neonatals, different center and Saudi centers, there is a variation in the outcome and as well in the survival. And I believe that the collaboration between centers at different level is a key feature for many system or network that aiming for improve the quality, safety, and outcome in the NICU. Because the principle behind the collaboration is the benchmarking, sharing knowledge, and as well the promoting evidence-based practice. And hope we can see this collaboration to improve and to learn from each other. For the quality improvement initiative, I will use the Canadian Neonatal Network as an example because they have a very nice and beautiful journey over years. It was in phases. They initially they collect the data from different centers of the Canadian Neonatal Network, and they found there is a variation in the outcome between the Canadian center at the national level and the international level. So they implement the EPIC program, which stands for evidence-based practice for improving quality. And this program was it's an evidence-based with the targeting intervention on variation of outcome with the collaboration of all Canadian centers and the expertise leading this program. And as well aiming for creating a culture of continuous improvement. So they have the phase 1. The phase 1, they involve only 12 centers of Canadian center. 6 centers, they was concentrated on the bronchopulmonary dysplasia, and the other center was concentrated to improve the outcome on the hospital-acquired infection. And after they saw the reduction in the morbidity and improving in outcome, they launched the phase 2. Which is this published in this study, the Association of Quality Improvement Program with Neonatal Outcome in Extreme Preterm Infants. It was the phase 2 over 3 years, and they targeting the survival as well 5 major domains: the IVH, bronchopulmonary dysplasia, neck, hospital-acquired infection, and ROP. And they found reduction after implementing the EPIC program, generalized to all neonatal Canadian in ICU, they found a reduction in the odd from the baseline to year 3, as we saw in the last column. The reduction around 37%, and they found the most of the improvement was in the group between 26 and 28 weeks, with a little improvement, and there is an area to work more in the group between 22 and 25 weeks. After the success in the phase 2, they started the phase 3, and the aim was to see how this program, the EPIC program, is sustainable. And they did this study over 5 years. After they finished, they found there is still improve in the survival to discharge without major morbidity, and the program was very sustainable, and the result was sustainable. Sustainability is difficult and challenging to maintain the result, and they are able to do it. Quality improvement is a continuous process, and here is another Canadian study. They saw the outcome of the preterm infants less than 33 weeks over 14 years after implementing the EPIC program. And they found the results from that survival to discharge without major morbidity. They have 4 groups according to the gestational age. The result was very impressive. That's the improving was going toward, and it was sustainable over the 14 years. So they conclude that the EPIC program has an increase in the survival and decrease in morbidity. And the key lesson, patient outcome can be improved by doing better with what we know. And this is another big initiative from the pediatrics collaborative from US. Usually in the quality improvement, they are targeting one outcome, but in this study, they aimed to target many domains and morbidities. The purpose was to initiate large-scale stimulants in multiple domains of care in large neonatal network. And they target multiple processes and outcomes that were thought to be a key driver of morbidity and mortality in the NICU. And the key driver was chosen based on the literature: nutrition, medication, central line care, respiratory care, delivery room care. And they used the SMART aim, and they start to do the process of the changes. And they adapt the quarter 8-step model of changes. It is a process to help leaders in changing implement the changes. And it's focused on creating the urgency in order to make the change. As well, the process it takes through the initiating, managing, sustaining through the 8 steps. And the result was there was a significant improvement in the survival and in some of the domains of the morbidities. And I would like to pay an attention about one of the important factors to facilitate the quality improvement projects is the work environment. This study was done to investigate the association between the work environment and the quality of care, safety, and patient outcome. They found the improving in the work environment may be promising strategy to achieve better and safer practice, especially for the nurses, the nurse quality report, and the NICU relevant outcome related to infection and patient readiness to discharge. As well, one of the things that can help in the quality improvement, the culture of the organization. The organization culture, they found it improved the patient outcome and decreased the mortality in neonatal intensive care and higher performance on safety. And in this study, they found the higher hierarchy culture score was associated with higher survival without major morbidity. Just to mention some of the quality improvement projects initiative in the my center, and would like to highlight that the data is very important. You need first to have your data and to see where is your unit, and then translate this data into the information and compare it to other centers as well to the other network. You cannot manage what you don't measure. Start simple and get your team. And then in this initiative, we use the model for improvement, and it has an aim, measure of change. And there is tools to assess the changes in the quality improvement. We use the BDS cycle, and the rate of the ROP was significantly high in our centers in 2015, and we had all the process, and we are able to get down to 5%. As well, we found a problem with the hypothermia and extreme preterm infants on the admission, and we start the quality improvement and we decreased it to 2% in 2021. Hospital-acquired infection start to decrease. Still, we didn't reach the target, but still we are on the way of improvement, inshallah. Home message. Neonatal survival and sequelae of NICU graduate are variable worldwide. The collecting data is the first step, is a crucial step when starting the quality improvement project. Quality improvement projects matter and has a huge difference in the outcome of the NICU that no other scientific research has done. NICU teamwork and collaborative work environment are essential aspects of successful quality improvement. Quality initiative and neonatology service are applicable locally and improve outcome and the NICU care. Thank you.
Thank you, Dr. Nisreen, for this excellent start. As I said, we'll keep the question at the end, but reminder you, NICU without quality, زي اللي يصوم وما يصلي. Okay, so it's very, very, really important. So we'll go to the second topic, will be retinopathy of prematurity. Retinopathy of prematurity will be presented by Dr. Maali. Dr. Maali Abdel Fattah. She's a consultant ophthalmologist and retinal surgeon and at King Faisal Specialist Hospital in Riyadh. Dr. Maali could not make it physically, so she will be as a virtual. So can we connect, please, Dr. Abdel Hakim?
Assalamu alaikum.
Alaikum assalam.
I am Dr. Maali from ophthalmology, talking about the retinopathy of prematurity.
Dr. Maali, share your slide, please.
And I am trying to share my slide, but it appears for me a message: host disabled participant screen sharing.
Can you make her the host, please? Okay.
Okay.
So you can now share your slides, please.
Yeah, I will try now. So now I am sharing my screen. So it's clear now or not yet?
Go ahead, Doctora.
Okay. So good morning, everyone. I am honored to be with you today in Saudi Neonatal Society conference. I will thank everyone for all this arrangement, and it will be a simple presentation about retinopathy of prematurity. So retinopathy of prematurity is a major causes of childhood visual disability which is largely preventable. Many extremely preterm infants will develop some degree of ROP. Although in the majority of the cases, this never progresses beyond mild diseases, which resolves spontaneously without treatment. A small proportion develop potentially severe ROP, which can be detected through the retinal screening. If untreated, severe disease can result in a visual impairment, and consequently, all infants at risk of sight-threatening ROP should be screened. So we'll talk about a small figure showing normal retinal vessel developments here in the figure in the left side, showing the normal retinal vessels when grow starting from the optic disc and going centrifugal toward the retinal periphery. This is the normal retinal vessel developments which normally developed in the utero. What happened if the baby or the infant born preterm? As a result of the low oxygen tension in the utero, this is a main stimulus for the normal retinal vascular development, and this will be interrupted if the baby born premature. So the ROP pathogenesis develops in two phases. The first retinal phase, it consists of stoppage of the retinal vessels growth in the utero and regress. Why? Because of the high oxygen level, which it is necessary to maintain adequate level of circulating oxygen for the survival of the preterm infants, which inhibits retinal vascularization. And the phase 2 starts when the newborn grows and the metabolic requirements of the retina increase. The retina becomes more hypoxic, inducing a more compensatory, devastating, and apparent new vascularization. As you see here in the ROP phase 1, there is an interruption and regression of the normal retinal vessels developments. And here in ROP phase 2, starting the developments of new vascularization, which is derived as a result of decrease of the oxygen with resulting increase in the vascular endothelial growth factors and erythropoietin factor and the insulin growth factor. And those factors promote developments of retinal new vascularization. Again, this is another figure also showing the retinal developments, the normal retinal developments here in the utero with the normal level of insulin growth factor and the normal level of the vascular endothelial growth factor. If the baby...
Dr. Maali, we lost the sound.
Factors.
Dr. Maali, we cannot hear you.
Can I continue, Doctor?
Yeah, share your slide and continue, please.
Yeah, okay.
Okay, go ahead.
Yeah. So we reach here that there is a new vascularization which developed as a result of increase in the level of the insulin growth factors and the vascular endothelial growth factors. And that the baby can pass or the infants can pass in one of two ways, either normal vessels growth in the retina with decreasing in the vascular endothelial growth factors and the complete resolution of retinopathy of prematurity. Or the other way is increase the vascular endothelial growth factors, leading to a proliferative retinopathy and leading to a retinal detachment. So prematurity in a study done in 2019, retinopathy of prematurity, discussing the incidence and the risk factor of retinopathy of prematurity in a tertiary hospital, they found that there is a 38.6% of the infants have a retinopathy of prematurity. In another study also discussing or investigating the incidence of retinopathy of prematurity in a tertiary center in Jeddah, they found also that there is an incidence of retinopathy of prematurity, which is just 1 second, but I will answer my pager. Sorry for this interruption. So they found in Jeddah. In another center also done in Tabuk, they found that there is an incidence.
Dr. Maali, we lost the sound. Shakil, connection, please. We'll go to the next representation. Dr. Khalid. Gives.
لا ده الواي فاي اللي هو حاطط اوكي.
Doctora, due to connection problem, we will proceed with the next presentation.
So now it returned back or not yet?
Dr. Maali.
Yeah. Yes.
We will proceed with the next presentation because of the
I am
connection
here.
issue.
I am here. Is it okay?
Okay, go ahead.
Yes. So UK screening of retinopathy or prematurity, mentioning that published in March 2022, mentioning that all infants less than 31 weeks gestational age up to and including 30 weeks and 6 days or less than 1,501 gram birth weight should be examined to screen the presence of retinopathy of prematurity. What are the risk factors for retinopathy of prematurity? Low birth weight, low gestational age, or prolonged oxygen treatment, blood transfusion, and sepsis, or all are statistically significant risk factor for the development of ROP. When to examine a baby first time? For the infant born before 31 plus 0 weeks gestational age, the first ROP examination should be performed between 31 and 31 plus 6 weeks post-menstrual age, or at 4 completed weeks postnatal age 28 to 34 days or later. For the infant born from 31 weeks, the first ROP examination should be performed at 36 weeks post-menstrual age, or 4 completed weeks 28 to 34 days, whenever is sooner. And this is a very nice table showing exactly when to screen the baby for retinopathy of prematurity. Yani, for example, if I have a baby born at 24 weeks, so wait 7 weeks and start the screening at 31 weeks post-menstrual age. In preparation for the eye examination, as usual, as we are doing in the neonatal ICU, use a mydriatic combination of phenylephrine 2.5% and the cyclopentolate 0.5%, and still 1 drop of each drug in 3 doses, 5 minutes apart, and then 1 hour prior to the examination to achieve effective mydriasis in preparation for the ROP. We can use local anesthesia just prior to the examination when an eyelid speculum is to be used. Consider using a combination of care techniques to comfort the infants during the eye examination. For example, we can use a nesting or a swaddling or non-nutritive sucking or administration of expressed breast milk. Parents and the carers should be offered the opportunity to be present during examination and facilitate comfort care. Consideration during the examination, keep ROP screening as short as possible. For the examination undertaking as an outpatient, ensure appropriate neonatal resuscitation equipments and a health professional trained pediatric basic life support are available in the examination area. If the infants are unstable during an outpatient examination, a period of observation is necessary before discharging the infant home. Discuss with the parents and the carers the results of the screening, the next steps, and their baby may be unsettled after the examination. And here is the methods of examination of our baby in the neonatal ICU. What are the stages and the zones of the ROP? Here we have a retinal image showing stage 1, which is considered as a demarcation line between the avascular area of the retina and the normal vessels, normal retinal vessels. And here is a stage 2, which is showing elevated tuft separation between the avascular area and the vascular area. And the stage 3, it is considered as an elevated vascular tuft. And the stage 4, it is a development of subtotal retinal detachment. Stage 5 ROP, it is considered as a 3 sub-categorization in the form of 5A open funnel retinal detachment, 5B closed funnel retinal detachment, and 5C, which is a 5B plus anterior segmented changes like marked anterior chamber shadowing, iridocorneal lenticular adhesions, and the corneal opacification. And here are zones for retinopathy of prematurity. Zone 1, it is considered as a circle with a center over the optic disc, and the radius, it is considered as a double the distance between the optic disc and the macula. And then zone 2, it is considered as another circle with a boundary from zone 1 to or nasal serrata in the nasal area up to the temporal quadrants in the temporal area in the equator. And then zone 3, it is considered as a sector, the remaining sector which is present between the periphery of zone 2 up to the oral serrata at the temporal area. This is a hand drawing to choose which clock hours. So we are talking about the right eye here for this baby, and his 12 clock hours is here, and then 6 clock hours is here, and then 3 clock hours is in the nasal of the left, the right eye, and then 9 o'clock in the temporal part of his right eye. And again, this is zone 1, which is twice the radius from the optic nerve to the fovea and with macular involvement. And this is another picture also showing the zones of the retina and clock hours also, including the right and the left eye. What about the plus disease? The plus disease is considered as an increased venous dilatation and arteriolar tortuosity of the posterior retinal vessels, which can increase in severity to include the iris vascular engorgement, poor pupillary dilatation, and the vitreous haze. Actually, plus disease for the ophthalmology is very essential because it determines the treatment. Shall we proceed for the treatment or no? And we'll discuss it in the treatment. And here is the plus disease, fundus photos showing the plus disease in the form of arteriolar tortuosity and venous dilation, which is considered as a plus disease. What about babies who developed aggressive posterior ROP? Risk factors for the aggressive ROP are extremely premature, birth weight less than 1 kilo, or gestational age less than or equal to 28 weeks, dysregulated oxygen supplementation, intrauterine growth retardation, sepsis, and thrombocytopenia. Characteristically, aggressive retinopathy of prematurity has a zone 1 or posterior zone 2 involvement with prominent plus disease, large vascular loops, and the flat extraretinal fibrovascular proliferation. This is denoting aggressive posterior retinopathy of prematurity. The international classification of retinopathy of prematurity 3, it determines that we cannot depend on only posterior, the name posterior, but if we see these changes present in zone 1 or zone 2, so we'll consider for the treatment. بس
Dr. Maali, we cannot hear you.
Yes, Assalamu alaikum. Did you hear me now?
Yes, now we can hear you.
Okay, so aggressive posterior retinopathy or premature disease is photos also showing stage 3 in zone 1 and the posterior disease zone 1 or posterior zone 2 and the prominent plus disease, which is considered as an aggressive posterior retinopathy or prematurity. A pre-plus disease is defined as a vascular abnormalities of the posterior pole that are insufficient for the diagnosis of plus disease, but that demonstrate more arterial atrociosity or more venous dilatation than normal. What about type 1 ROP? It is a stage zone 1, any stage ROP with plus disease, zone 1, stage 3 ROP without plus disease, or zone 2, stage 2 or 3 ROP with plus disease. Actually, it is very important because it will affect our, decide our further management. International classification of retinopathy of prematurity, also report 3, defines the presence of a notch may lead to a more posterior staging of the ROP. It describes it is an incursion of the ROP by the ROP lesion of 1 or 2 clock hours along the horizontal meridian into a more posterior zone than the remainder of the retinopathy. Here is a baby with a stage 3 ROP in zone 2, but he has this notch which it is incurred inside the zone 1. What about the telemedicine for the ROP? Actually, in 2006, American Academy of Ophthalmology survey found that only 54% of the retinal specialists and the pediatric ophthalmologists are not willing to manage an ROP. And over 20% plan to stop because of the concern that, such as poor reimbursement, logistic difficulty, and the medical legal liability. So what is the solution to screen those babies? They invent this wide field ophthalmic imaging camera, which captures all color images for the baby in the rural area especially. And then the images will be reflected to an expert who discuss the stages of the disease and further management, either for a follow-up or for treatment. Also, artificial intelligence in the ROP take a very robust, intelligent role in screening of the ROP and the detection of the severity of the ROP. As we see here, images will be artificially interpreted, and then it will also determine which stage for the ROP. So we talk about the screening of the ROP, suitable time for the first examination, and the stages and the ROP and stages and the zones of ROP. What about the treatment of retinopathy of prematurity? Referral infant for treatment when criteria have been met. Zone 1 with plus disease and with any stage of the ROP, or zone 1 without plus disease but with a stage 3 ROP, or zone 2 with plus disease and with a stage 3 ROP, zone 2 stage 2 with plus disease is borderline for the treatments, as we'll discuss later. So this is a very nice table also to choose to show us when exactly you can proceed for the treatment. Yani, for example, here, if the baby has a type 1, any stage in zone 1 with plus disease, so we have to treat. If the baby has a type 1, stage 3, zone 1 without plus disease, so we have to treat. If the baby has a stage 2 or 3, but zone 2 with plus disease, so we have to treat. What about the subsequent examination for the ROP screening? After the first ROP screening, if the treatment is not required, re-examine at least weekly when the vessels end in zone 1 or posterior zone 2 with or without any stage of ROP, or if there is any plus or pre-plus disease, or if there is a stage 3 ROP in zone 2 or zone 3, until the criteria for the treatment or 2 weekly examination or termination have been reached. When to terminate the screening for the ROP. For the infant without ROP, continue examination until complete vascularization extending into zone 3. For the infant with any stage of ROP, consider discontinuing the screening examination when the following characteristics are detected: partial resolution progressing toward the complete resolution, or change in the color of the ridge from the salmon pink to white, or growth of the vessels through the demarcation line. And here is a very nice also algorithm for ophthalmic observation. Yani, for example, if I have a baby with ROP stage, there is no stage for the ROP, so we can observe the baby. But if the baby has stage 1 or 2, يبقى in this area we have to look for the plus disease. If there is a plus disease, يبقى if there is no plus disease, يبقى every 2 weeks. But if there is a pre-plus disease, it will be every week. But if there is no plus disease, it will be also every week, and will no need for the treatment now. What are the treatment options? In the past, they were using cryotherapy to treat a baby with ROP. And sometimes also it needs to paraplanar vitrectomy to treat the baby with retinal detachment. But nowadays, with the further ROP screening and with the program of the ROP screening, so no baby reaching to up the stage
Dr.
of...
Maali, 3 minutes.
Okay, طيب. This is the machine which is used to deliver a laser treatment for the baby, which is called the diode indirect laser photocoagulation. And here is a fundus image showing laser marks. But unfortunately, with the laser surgery, I found a lot of complications like macular dragging and high myopia. So they started to proceed for another lines of treatment, which is an intravitreal injection of antivascular endothelial growth factors. And they started to develop multiple studies like bevacizumab eliminates the angiogenic threat of retinopathy of prematurity. They're conducting a prospective controlled randomized study to assess the intravitreal bevacizumab monotherapy for zone 1 or zone 2 posterior stage 3 versus conventional laser therapy. And they found that intravitreal bevacizumab, as compared with conventional laser therapy in the infant with stage 3, has a significant benefit for zone 1, but not in zone 2 disease. Another study, which is called the Rainbow study, and we were lucky in our center in King Faisal Specialist Hospital to perform this study and the chair in this Rainbow study, which is a 2 years outcome of another antivascular endothelial growth factor. It's called the ranibizumab versus laser treatment for the treatment of the very low birth weight infants. And they found that 80% of the infant achieved treatment success with ranibizumab 0.2 milligram versus 66.2% with laser treatment. Another study which is assessing the efficacy and the safety of intravitreal aflibercept compared to laser photocoagulation, and they found also that there is a great successful treatment with injection of aflibercept in the retinopathy of prematurity. So this is a study with a great results. And also our take-home messages as the telemedicine alleviates the burden of the ROP screening by implementing the remote interpretation of the digital fundus images by an ophthalmologist, and intravitreal antivascular endothelial growth factor became the promising treatment for ROP. However, the studies are now investigating the systemic absorption of those medication with the resulting systemic side effect like cardiac hypertrophy and pulmonary hypertension. Thank you so much for listening to me.
Thank you very much, Dr. Maali, for your presentation. We'll take the session at the end. We'll take the question at the end of the session. Thank you very much.
Thank
so
you.
Now it's my pleasure to present another important topic about the medication safety in the NICU. As we know, medication error is very common, and it's happened really in NICU more than 8 times more than adult ward. And the study has been reported that many medication error happen in the NICU is preventable. So it's my pleasure to introduce Dr. Khalid Tahir. Dr. Khalid Tahir is a pediatric clinical pharmacist at King Faisal Specialist Hospital in Riyadh. And he's a doctor of pharmacy to 2020 Western University of Health Science, Pomona, USA. And he will talk about medication safety in ICU. Dr. Khalid. Just put on. this one. Two.
Thank you for the introduction. Assalamu alaikum. Good morning, everyone. Today, I'll be talking about medication safety in pediatric floors, focusing in critical care pediatrics and NICU as well. Now I'm back from my scholarship for over a year practicing King Faisal in the pediatric intensive care unit. Nothing to disclose with regards to this activity. Upon completion of this topic, we should be able to achieve several objectives, including identifying areas for improvement to minimize medication errors in pediatrics, recognizing the reasons for medication errors, as we see maybe in daily practice, daily basis, some medication errors and challenges in treating those special population or vulnerable population, particularly the NICU patients, indicating the factors that affecting the drug pharmacokinetics principles like absorption, distribution, metabolism, and excretion for those patients, listing contraindicated drugs. We know there are some cutoff for using certain medications and what's the reason behind these cutoff for those patients. And also distinguishing specific dosing consideration for those population when we compare it to the adult population. I would like to start my talk with a question. So thinking out loud, what do you think about when you compare it to adults about the rate of medication errors that might result in harm or death in pediatric patients in general? Do you think it's going to be 2.5 times less likely compared to adults, more likely compared to adults, or it's going to be almost similar? Maybe more likely, right? We have maybe seen some ADRs, medication errors, incident reports related to those population. Practicing in some institutions, you will get these reports or presented in some meetings showing several ADRs or medication errors happened for those populations. And the rate of medication error resulting in harm and death for those patients, pediatrics versus adults, was reported as 31% in adults versus the 13% in peds. And imagine as many as 1 in 10 hospitalized children that are impacted with those medication errors. And up to 35% of these errors are serious or life-threatening. And as introduced earlier, a lot of medication errors could be preventable. So this was a survey from the Institute of Safe Practice or Safe Medication Practice that published in 2015, online survey of pediatric medication safety that included 1,463 respondents, mostly pharmacists and physicians and nurses. And they were asked to select the frequency they employed, key error prevention strategies, and they published the part 1 summarizing findings and compared to similar survey completed in 2000. So these are the responses that got the least percentage as always or almost always. So we can consider those as areas for improvement. You think about them if we have implementing this in our institution or not. The first one would be prescribers including both dosing, weight-based or body surface area-based, like milligram per kg, in addition to the calculated total amount of the drug that might prevent medication error. Prescribers orders pediatric liquid mids in metric doses, like we do in mLs, milligrams, but not in ounces or pounds or other non-metric doses. Dose range check. Have you seen the DRC maybe in your electronic medical health system that you use in your institution? The dose range check software that's available in the enabled in the computerized physician or prescriber order entry that gives you the pop-up message alert when you order a medication for those patients if you are out of range, if you are underdosing or overdosing those patients. And these DRC list of medications are reviewed, supposed to be reviewed by clinical pharmacists. Adults, pediatric, and unit meds are not stored near each other. This is mostly for pharmacy practice or medication rooms in the floor. The bedside barcoding scanning also, this is another automation solution, and involving clinical pharmacists by actively participating in patient care rounds and providing their input as well. All right, so we can summarize some reasons for the medication errors that we see in our daily practice, such as the pediatrics are at risk of harm due to the errors. Several reasons could be the size of those patients. Maybe you could imagine what was the smallest baby you've ever seen, right? I don't know, in Oklahoma, I have seen, doing my residency, like 0.45 grams, like less than half kilo. Maybe somebody saw less than that? Maybe, or closer to that weight, right? Again, could be challenging with dosing those population, right? Weight-based dosing, a lot of calculation compared to adults, not fixed dosing, immature renal hepatic function that might affect or make an unpredictable absorption or unpredictable clearance of medications. Inability to communicate complaints and serious adverse drug events for those babies, especially like younger than 6 or 5 years old. And children are particularly vulnerable to errors if they are less than 2 years old. Right. So what about the challenges in treating peds in general, including the NICUs? Small fraction of all marketed drugs have any labeling pediatrics. You know, I think I remember one of the statistics previously published that maybe over 50–60% of medication is using in the NICU or pediatric hospitals could be off-label use, right? Maybe submission, some hospitals call it Form B, or for submission of form for off-label medications. Like you can remember acetaminophen IV when it was marketed initially for over 2 years old. However, recently, now we're using it safely for neonates. Lack of information exposes children to risk, like lack of reported maybe ADRs or under overdosing references. Children denied new therapeutic advances. Like we sometimes go with what we have, old medications or old drugs available in the market because we don't have enough data and not published for the, not studied for those population. Challenges to measure, dispense, and administer, again, wide variety of sizes and dilutions. How many encountered, for example, small babies want to administer subcut medications like, for let's say, desmopressin, insulin, and the dose is beneath or less than what you can measure, and you have to dilute it, trying to find out dilution data, trying to extrapolate, ask for different institutions' practice to see if we can dilute these medications and administer. Need for calculation of individualized doses and lack of available pediatric formulations, dosage forms, and concentrations appropriate for administration, again, might be unmeasurable volumes to be administered. Oral drug concentrations is another issue in the market. You can see there are some medications that may have different drug concentrations, not only one. This is a problem mainly when we do sometimes medication reconciliation, taking medication history. The family won't tell us like how many milligrams. Most of the time they say how many ml they're giving their babies, right? Every dose, every day. And then we need to figure out what is the concentration of the medication and to try to calculate ratio proportion or do our quick math, find out how many milligrams, because our drug concentration in our institution might be different than what they purchase commercially or what they have at home. For example, here, like you can see, amoxicillin has 2 different concentrations. If they tell me they're taking 5 ml, I really can't tell without knowing the concentration. Is it the 250 milligram or the 125 milligram? So would like to share discussion with you for a KT is a 20-day-old girl, 4 kilogram, full term, came to the ED with cellulitis. The team wanted to start vancomycin empirically for this patient. What do you think the appropriate dosing strategy, knowing that the patient has normal kidney function? Would you go with the 15 milligram per kg, but what frequency? Is it once daily, Q12, Q8, or Q6 hours? Maybe by show of hands, who says A, once daily? All right. Q12 hours. All right. Q8 hours. Okay, see now majority. And then Q6 hours. This. So I would agree with the Q8 hours. Again, each population, age group will have different frequency for some medications. That's based on, you think about the clearance, the maturity of some of the organs, mainly the kidney, right? At birth, maybe it needs few months for the kidney to be matured, and then I can feel safe over 2 months, for example, 3 months, giving Q6 hours, again, as a starting dose. We'll monitor and adjust, right? But as a starting dose. Now we correlate it back to the PK, to the absorption, distribution, metabolism, and excretion for those patients. This is a full 10-20 day, but if it's younger than that, I might go even to less frequent dosing, Q12, or if it's the patient became like 6 months, 8 months, maybe I feel safe to start with the Q6 hours dosing for those patients. All right, so we always say this, kids are not small adults. That's mainly because they're so different in some of the components when you compare it to adults, such as the drugs dosing. Again, it might be per dose, per kg, higher than the adult or lower sometimes, right? It depends on the drug. Like, for example, if I give gentamicin for the neonate, usually for adults or for older kids, I just go with the conventional dosing 2.5 per kg Q8 hours. However, for those neonates, I might go 4 or 5 milligram per kg and give it once daily. So I'm giving now higher dose per kg. However, I'm giving it less frequently. Again, bring it back to that thought of the kidney development. Vital signs, and we talked about ADME as well principles, which I will highlight in the next few slides. So let's take it one at a time, like start with the absorption. Okay. Again, these are all factors might affect your drug concentration, drug dosing for those children. For the GI tract, for example, we know that gastric pH for term infants is around 6 and 8, again, higher, and premature infants also is even higher. That might affect or delay or incomplete drug absorption for some medications, like a phenobarb, phenytoin. In addition, the increased gastric emptying time stays longer in the gut, right? And then that might affect your bioavailability, making your bioavailability of the drug is higher. IM absorption. Neonates have decreased rate and extent of absorption. Several factors, such as the decreased muscle blood flow, right? Higher percent of water in the muscles and decreased extent of muscular contractions. All of that, all these factors affect your IM absorption. In addition to the percutaneous absorption, subcut, they might be unpredictable. How many of us give desmopressin, very small dose, and you see like a huge change in sodium levels? So the factors for the percutaneous absorption would be the epidermis barely present by the 34 weeks gestational age. Straightened cornea and the skin underdeveloped for those patients might affect absorption. Also, that increased skin hydration. Distribution, infants shouldn't have a higher amount of water to lipid ratio in their extracellular compartments. This medication that poses a greater degree of lipophilicity, like the lipids, right, might not be affected, but however, the hydrophilic drugs might be affected, such as, let's say, aminoglycosides and others. Protein binding, this is a big factor. This is a big factor that also leads to contraindication for some of the drugs, giving us the cutoff of those agents. So decreased plasma protein binding and binding capacity of proteins. You know, some of the medications are maybe 50, 60, right? Bound to protein, 60%. That increase in the volume distribution and the amount of free drug circulating in the body will be higher, giving you more of side effects. You think about ceftriaxone, Bactrim, these agents when they are also displacing bilirubin from albumin and causing kernicterus. Metabolism, some examples like oxidation, term infants activity of cytochrome P450 enzymes is about 50%, and then by 1 year old postnatal age activity increases up to 5 times. So we see them as rapid metabolizers sometimes. Some of the drugs will be converted fast either to active or inactive metabolite, depends on the drug. And we have examples like phenobarb and theophylline. So question would be, why acetaminophen is not toxic in neonates? What do you think? All goes back to metabolism here, because when we think about adults, we have the sulfation methylation to metabolize it. However, it's depleted. So what's the alternative for neonates? They're using the glucuronide and glycine conjugation, which is, the opposite, sorry. At birth, they're using the sulfation and methylation pathway. which is developed to metabolize acetaminophen. However, in adults, the glucuronide glycine conjugation, which is immature and reduced at birth. All right, the last part of the ADME is the excretion. We talk about glomerular filtration rate, calculating the creatinine clearance, estimating kidney function. Again, to dose and adjust medications might be challenging sometimes for those specific populations, especially at the first few days, few weeks of life. Serum creatinine concentration, we might all know that when you check it for a neonate in the first few days of life might be elevated, right? Which is reflecting the maternal concentration of the mother, right? And at 6 months might reach the adult value. And the preterm infants have diminished GFR due to immature glomeruli, proximal tubules, and reduced blood flow. Therefore, medications can be affected by this decreased GFR, like aminoglycosides, ampicillin, indomethacin. All of these agents affected by the patient's serum creatinine. That's why the dosing reference for those patients will be different in terms of frequency, when we see genomycin given once daily instead of Q8 hours. Also, tubular secretion reabsorption, also another factor that might affect excretion of medications. All right, just maybe refreshment. We're using bedside Schwartz for calculating, estimating kidney functions. However, for young kiddos or those are infants, premature, we need to use different factors for calculating GFR. That's why we go with Schwartz equation. However, what do we do with the neonates in the first few days of life? How can I estimate kidney function? Can I rely on those equations to estimate kidney function and adjust medications? Might be challenging, right? Because again, as I mentioned earlier, the first few days of life might be elevated, but reflecting maternal, and then might be decreased, but how would I calculate it? 5 days old, for example. So usually the trend of serum creatinine is very important, plus is calculating or measuring the urine output, what might give you a clue if there is a kidney injury or not for those patients. All right, so listing some of the medications that they have cutoff to use for pediatrics, starting with aspirin. We all hear maybe family members say baby aspirin, maybe marketed for kids. However, no, it's just the name, right? Misconception, misunderstanding. However, we still use it in pediatric, right? Maybe you have seen multi-system inflammatory syndrome or COVID-related. We might add high dose aspirin, higher than adults per kg per day, right? Reaching 100. However, there is a cutoff less than 12 years old if due to the risk of Ray's syndrome when there is a concomitant viral illness like chickenpox. Tetracyclines, tigecycline, I think we all here learned about this early. It's an old contraindication for less than 8 years for the permanent discoloration of the teeth. Fluoroquinolones, less than 18, so it's all for all pediatrics. Again, defining pediatric cutoff here up to 18 once they hit 18 they're adults. I know some hospitals for admission criteria might only be up to 14 once they hit 14 admitted in the adult floors. However, I still consider those as pediatric by definition. Arthralgia, tendon rupture might be the warning. However, we might see these agents used for pediatric when we balance benefit risk ratio. It depends on the reason for using the medication. Sulfamethoxazole, trimethoprim, 2 months. We talked about displacing bilirubin. Also benzyl alcohol toxicity. There would be a maximum you can give for neonates 100 milligram per kg per day. If you're exceeding that, you're increasing risk of gasping syndrome in neonates. Ceftriaxone, same concept of Cronectras for displacing bilirubin. The cutoff is for all neonates. Also, there is another warning about it might bind to calcium, right? Affecting the absorption, forming insoluble precipitate. Again, when you think about calcium, is not only clearly added to IV fluid, you might see it
2 minutes.
hidden in some of the medications as like lactate drinkers, not be reported. Chloramphenicol 1 year for Gray syndrome, nitrofurantoin, neonate for anemia, and other opioids for risk of respiratory depression, and 12 years old, but less than 18 if they are post-adenidectomy or tonsillectomy. Again, some hidden electrolytes you need to be aware of, like calcium content in lactate ring or lentiplasmalide. There are also specific areas for errors when calculating for drips. You need to know the concentration, how to find out the concentration of these drips, calculating the titration rate, then dividing by the concentration. You need to know the minimum amount you can run in the smart pump infusions, 0.1. So in those who are having less than 0.1 ml per hour, you might need to decrease the concentration of the products to be able to measure it. For the sake of time, skipping question, we'll explain the concept in the next few slides. So in general, I have some considerations for weight-based dosing when I exceed sometimes adult dosing. So I put like in my back of my mind, in general, if they hit the 40 kilogram and above, I double check both pediatric and adult dosing and make sure I don't exceed the adult dosing. And some dosing might depend on other factors like the age or weight categories, like you see in dosing aminoglycosides in neonates in this table. Other areas for drug dosing consideration, milligram per kg per dose versus per day, using body surface area, GFR in calculating the doses in some drugs, combine drugs based on which component of the drug you're dosing, dosing units and administration. This is an area maybe to think of for which way to use for the babies when they're born. In general, just to make it brief, usually go with the birth weight. It depends on the institution, but in general, birth weight, and then until they reach the birth weight, I don't change it, but I measure it over a week and average. If it's more than 10%, I might adjust some of the medications for the new weight. These are for your reference, some references you can use for looking up some medication dosing. Again, some might not include everything you're looking for. Now moving to the end of the presentation, the tips and summary. Most drugs are made for adults, and if used in children, often are repackaged or diluted to be measurable at least 0.2 ml on a 1 ml syringe. Provide preservative-free product whenever possible. Provide exact doses whenever possible. Never use trailing zero, like don't say 5.0. Like we always should use preceding zero, like 0.5, 0.5. Dose in milligrams, not in mLs as possible. Provide liquids for those less than 10 years old. If no commercial liquid available, maybe other recipe can be developed in the institution. If no data, can tabs be crushed? Again, we can check resources for that. Can drug be mixed with food or applesauce or juice for taste palatability? All right, this takes me to the conclusion of my talk today. Pediatric pharmacokinetics are different than adults. More needs to be done to protect pediatric patients from harmful medication errors. Determining the appropriate dose of medications for a child requires an assessment of multi-factors. We talked about like the ADME, absorption, distribution, metabolism, excretion, patient age, weight. The appropriate dose for pediatrics is often listed as a range of weight-based doses. Again, this is a big area for error. Actually, this is the most reason for medication errors reported in the literature is the weight-based dosing for those patients. Standardization is the key and to reducing variability and decreasing risk of error. Thank you for listening and your attention.
Thank you very much, Dr. Khalid, for your informative presentation. The question will be at the end. And now we'll go to the next session, and a lecture, which about from medication safety to neonatal safety in the NICU, rule of quality in improving neonatal safety. The speaker will be Dr. Adnan Hadid. Dr. Adnan is a consultant neonatologist and clinical assistant professor at King Saud University Hospital. And he's an editor of the Al-Walid Journal under the Saudi Neonatal Society. Dr. Adnan.
I think I need 25 minutes. سلايد زي الاوفيس هو اللي بعدك. Accepted. Fine. The presenter working.
بس لما تحط سكين
نشتغل. السلام عليكم. Good morning, جميعا. I'm quite happy because my presentation on Wednesday, because special day for our Syrian from homes. Asking a person to talk about safety in general, as if you are asking a person to talk about neonatology in one lecture, exactly. So it's totally subspecialty from quality, which is very hard to cover it in one lecture or in 1, 2, 3 days or one course. And usually the argument will be always, who will give the lecture for neonatologists or any medical doctors? Is it the physician, the doctors, or the qualification? I don't know, it's not clear. So sorry for that. So I'll try to use laser. Okay. So is it the doctor will give the doctors or qualification will give to the doctors? I think if you leave the talk to the qualification, he will spend maybe 5 hours or 25 hours rather than 5 minutes or 25 minutes. So I'm trying to do a balance between my subspecialty in neonatology and my study in quality, as I'm working in as a qualification also rather than neonatologist. I think nobody is putting hat, isn't it, in the theater? Mafi. While indeed, I'm not going to go in deep too much. Regarding quality, I know that most of the people, they don't like quality. They are not involved in quality that much. And most of the people maybe hate quality because the way how it's presented to them. So most of the people putting the black hat. So arguing, resisting a lot of bad things regarding the quality. So please try to remove the black hat while we are dealing with something new, especially the quality, and try to use data hat or creative hat or whatsoever rather than black hat, please. At the end of my lecture or any lecture, it's well known that for the lecture will get 5 to 10% of the lecture. That's what's well known and well established. Unless you go and discuss with your colleague or your team later on, you can increase this 5% maybe to 30%. And we know that the best way to learn is to teach. So if you are teaching others, you can gain up to 90% of the topic you are talking about. My lecture, if I will name it in another name, I'll give it why lecture. So why I give it that name. Is there anybody of you using the quality tool during his daily presentation? I'm sorry, the daily round, when he's dealing with the doctor's cases, complicated cases, he's trying to lead the team. Is there any tool you are using daily, Dr. Yasser? Am I right? Or yeah, further. Anything you are using or?
Yeah, we have specific guidelines in Canada, which is EPIC. I'm not sure if you heard about that or not. And so we.
Okay, I get the course. I get it with Dr. Ayman.
Very good.
He's
Yeah.
my friend.
So the course is very specific about different areas.
So
and, yeah,
I'm sure, quite sure, that's all of you using one of the tools during your round, but I don't know that maybe the tool you are using. I'll go through all the slides. I'm just keeping your mind that I will keep repeating why always, because really this is a tool we are using during our daily round. But how to use it, I'm going to that in that slide. We are coming to our work daily for 2 reasons. And most of us coming to work, but not all of us coming to improve our work or our quality of care we are giving to our patient. Objectives, a lot of objectives. I'm going to go through it quickly. I'm not going to name it by name. Why quality? Quality is no, I'm not going to give you a lot of numbers, the cost things. It's well known for all the people that if you not apply quality is very costly. So no need to go for the numbers because I'm sure within 2 to 3 minutes, maybe before you leave the theater, you will forget all the numbers. but it's there. Safety or quality, honestly, when it started. So I'm trying to give the talk to the qualification. So as a physician or doctors, I'm not that aware really. I don't like to go in depth regarding the history of the things. 1999, exactly in November, Institute of Medicine, they get their report and they call it "To Err is a Human." And I found that the best translation of "To Err is a Human," that's كل ابن آدم خطاء. And it's part of our humanity to make mistakes. So you cannot eliminate, it's no way. 2001, 2 years later on, they gave another report. What they name it, to cross the quality chasm. So it's not only gap. So we have what we call in Arabic, huwa. We have huwa sahiqa. Very big problem between the system we are using and the system we are hoping to reach it. So it seems to be very simple issues, to err is human things, but it's what the reflection of that on the quality on the practice. So honestly, quality or safety started very long once we start with the Hippocrates, first do no harm. This is the most important principle of safety. After that, they put 6 dimensions of quality. The most important one of them, honestly, the safety. So always when Sibahi will come to you, they will use the safety. You should match it, or the standard should be met 100%, or close to that. International patient safety goal, I'm going to through it quickly. There's 6 goals. I think most of you heard about it. Identify the patient, communication, medication, washing your hands, and all. I think it's well known for you. I'm not going to go through it in details because it's need every one goal of them really need more than one lecture. And NHS, they put 7 steps of patient safety. I'm going to put some or to talk about some of them in very brief. Like building a safety culture is very important. If you don't have safety culture in your institute, it's just you are wasting your time, honestly. Whatsoever your knowledge, you go very deep in inequality, it will be useless. Leading, I think something is very difficult. Promote reporting, which I think the most important problem we are facing, and we're trying to convince the people to report, and because they are looking at it as if you are punishing some person. Involving and communicate with the patients and public. That's, I think we'll go to this one in the next slide, because we decide in Saudi Neonatal Society for better communication, because we know that most of us, even Arab people, is not talking in Arabic with the parents, medical terms. We are facing a lot of problems. We don't have, honestly, maybe in the Arab world, even trusted source for information for the parents. So we decide to have like magazine or journal talking about neonatology in very simple way, in a language that could be understood by the parents. This is its first number. We start by November. That's why we focus on topics which is related to November, as you know that it's prematurity day. Even the colors, we try to give it purple. A lot of type of cultures, inequality, blaming and blaming, just culture. I hope that you hear about what is the just culture. I'm not going to talk about it because it's really need a lot of things. You can go to the Saudi Safety Center, you find a lot of application things and manual for how to apply, how to do the just culture. But I'm going to talk about what is our culture, how we are practicing safety culture. This is in brief, a report from one of the nurses. She, by mistake, she gave the vaccine to the baby, and it was given before. It's hepatitis B. So because I'm keeping repeating, Dr. Dassem, encouraging the people in the hospital to report that it's healthy, reporting more healthy system. So she report herself that I give them medication, and she came to me asking me what is the way to prevent it in the future. The problem, this report, the OVR reached the nursing office. Really, can you imagine what their decision that time? It's termination. So finally, they accept to give her final warning letter. And if it's repeated again by any mistake, she'll be kicked out of the hospital. To your knowledge, as we are a just culture in our hospital. And we believe that we are doing good inequality. But if you come to the reality, really, we still right now, and most of us, I think, we are practicing blaming culture. Why culture is very important. So this flower will not be able to survive in the desert. So this is the environment. If you don't change your environment, the quality will not work at all. And that's what's happening in most of our hospitals. So again, Institute of Medicine to Err is a Human, what is the reflection on the quality of our care in practice? IHI, I think all of you hear about it. 2006, they start their project. Just imagine, not only it's 14th of June, 9 o'clock, it's very specific. This is what we call smartification of the goals. They start their campaign to prevent 100,000 deaths, preventable deaths. And within 18 months, they were able to save the life of 124,000 persons could be killed by mistake or by medication error or whatsoever. I cannot imagine really how they were able to involve, it's their goal to involve 2,000 hospitals across the US. They were able to involve 3,100 hospitals in their campaign. It's something really magic. So sometimes it's difficult to involve the same consultant, the same unit. What about neonatology? Any reflection of equality or to err as a human or to crossing the chasm or whatsoever? So we know that we have surfactant, nasal CPAP, high frequency nitric oxide cooling, which is improving the outcome and decrease the mortality of our small babies. But we have like a plateau, 1998 till 2006, nothing is a change. So usually I'm keeping like a guess till the end, but because to shorten the time, I'll give you the answer. What happened there? 2006, same campaign in pediatrics. It was published later on. This is the key drivers. I'm not going to go there because not everything you can get it from outside. It's done in Canada or US. You cannot apply it here. Quality is not copy and paste at all. So you have your problem. You should discuss, and find the solution for it. So just look at the CLABSI when they start their campaign. And look at the mean, it's decreased always, most of the time, not always. That's where we're aiming to decrease any incidence, mortality, CLABSI, FAB, the major morbidity by 50%, but we were able to decrease it much, much less. And this is when they start to implement, and they were able to save lives of a lot of babies, more than what are expected. Again, I'm going to discuss some ideas or models of quality, so just please tolerate me. I'm talking about as a doctor, as a consultant in neonatology, not qualitation now. On Fridays, that's one of the consultants called me. It's very simple scenario. That's, can you teach your doctor how to calculate the calcium dose? So it's very simple. I mean, just open your fax and you'll find the dose there. It's very simple. No, doctor, we need special preparation to put, I don't know how many ml and how many 200 something infused. And I said, sorry, doctor, for myself, I don't know the dose, the way you are calculating that. So if I continue with her as a consultant or as a doctor neonatologist, I'm sure I will quarrel with her. Why you are blaming my fellow? Why you are doing like that? You don't give a clear order or whatsoever. But I prefer to go with her in a simple way. Doctor, how you write the order in the file? Sorry, we give it in verbal order. That's okay. Do you know, doctor, that it's high alert medication and a mistake in that things it can kill the baby even. I'm sorry, doctor, we were busy and it's okay. Doctor, do you have a protocol to give the medication the way you are giving to me, to dilute and to prepare? No. Sorry, did you come and discuss with the team? Did you talk with the doctors that you are missing the protocol, missing a lot of things? No. So it's then why you are blaming our doctor? So just you should blame whom? You should blame the system. We don't have protocol. We are giving verbal order for very serious issue. So honestly, the system itself, we have a critical problem in the system. First model as a qualitation, I'm going to tell you about what we call Swiss cheese model, that the event will not reach the person because of simple mistake. It's no way. You have a lot of barriers unless you have the holes. This is what we call the active problem. Unless you have it at the same level, the incidence or the error will not reach the patient. So, okay, I don't have protocol. I give verbal order. The nurse
5
will
minutes.
double check.
5 minutes.
We'll find another 2 slides. Okay, so in brief, if you have good system and you close the hole, so you'll be able to prevent. So just simply think in medication error or any problem that you have a system, you need to fix it, not blaming the person, not even blaming the system, just try to fix the system. This review, that's most of the medication errors coming from the doctors. Sorry, because I'm on call. So if you fix that, the personal experience, you'll be able to fix part of the problem. The other methodology, it's the iceberg. So the error which you see, there's fatal problem. But it's hiding down a lot of problems. It's the failure of the system here. All of these things, if you did not look for it, you did not search, you'll not be able to fix it. And you'll keep repeating the same problem. The doctor did mistake, he wrote the wrong medication, but you have a lot of things, you did not fix it. This is the iceberg, and you can do it at the same time. Swiss cheese with the iceberg. Root cause analysis is very important. I'm sure all of you doing root cause analysis from time to time. We are facing problem, you call qualitation, and you try to brainstorm and looking for the cause. I'm sorry to put it in this way, because just to show this is the effect and this is the root. If you did not get the root of the problem, you'll not be able to fix it at all. So if you treat this part, it's useless. 5 whys, I'm using it daily during my round with my fellows or doctors. Unless you ask 5 whys, this baby has this problem. Why? Because it's premature. Why? Because there is surfactant deficiency. Why? Because. So unless you ask that, you'll not reach what we call it pathophysiology of the exact cause of the disease. So just it's a premature baby. It's okay. There's a lot of things to think about it to reach the root cause of the problem. And by the way, this is not only quality, it's medical education tool that you can use it with your colleagues. Everything, if you give the answer, why? So that's why the doctor asks me, it's always asking why. It's to call you like why doctor. So try to make it simple. FEMIA, I don't know if you hear about it. So it's qualitation. I'm not going to talk about it. A lot of things. It's proactive way. This is from IHI. So there is a process, and I can sit with my colleagues to anticipate what could be the failure in this step or this step and this step. And I try to fix it before it's happened. So it's a proactive. This is much better than after the problem is there, then you can sit to discuss it. Patient safety days, a lot of things you can talk about it. The goals, you find always reporting, one of the most important goal in all the quality days or safety days. And why we are reporting, for one thing, I'm not going to near miss things. This is quality, I don't like to go in depth in. The future harm prevented. This is the reason why we are reporting. And if you call any person, just can you report that? No, I don't like to blame the others. I don't like to make a problem for him. Really, we still right now, we are facing this blaming culture. Reporting is healthy, more report is more healthy. This is our system in the hospital. Risk management, I think is very tough for doctors to go through it. Can I have 1-2 minutes extra, please?
Try, because it's restricted time. Go ahead.
Okay, so in your opinion, if you have, if you increase skin to skin care, what we are trying to reach in our hospital, even for critical babies, Without quality improvement projects, you would not be able to do that. So this was published in Perinatology. Perinatology was very, I think it's very difficult to go through it in details, but just put the process, you have it. Sit with your team. Don't borrow something it's invented outside and you try to apply it. It will not fit in your system at all. You have your mistake, you have your problems, you have a lot of things. It's not be fixed by Canadian or American system. So look for your problem, then try to fix it. And you can target the most important causes. This is with Pareto. The result of that one, they were able to increase more than 50%, 60, 70%. They redesign their process and test it again. This is the way how to do quality improvement project and see the benefit of that. It's helping the baby to shorten the time for skin to skin care and increase the time of the babies staying on the chest of their mother. They followed 6 Sigma green belt. It's not that difficult, while the black belt is more complicated. Honestly, that's take home message. يعني زي ما نقول الquality is not prestige anymore. So as if you need, as a doctor, you need to understand anatomy and physiology and biochemistry. You need to learn quality. There is a human, that's right, but please don't waste a good mistake. Learn from it. Quality is everyone's responsibility. It's not my responsibility as a qualification or the quality team or whatsoever. Unless all the people involved with quality, it will stay as a paperwork in the drawer, and that's what we are doing usually most of the time. If you did not build good quality culture in your hospital, you'll end by what we call, I hope that's all of you aware about, what we call sick and victim. It's going to affect you yourself later on. Very important system. Always look for the system. Try to fix the system. It will be fixed by systematic way, not by my opinion or your opinion or whatsoever. It's systematic way to fix the system, and always focus about S. S is system, systematic, and safety will be there if you work as a team, not like a group. So most of us putting 5, 6, 10%. They're not working as a team. That's group work just because they are sitting with each other. So responsibility for all of us, and the team together, everyone achieve more. Thank you very much.
Thank you, Dr. Adnan, for your presentation. And now we'll go to the last lecture in this morning session. Will be about SNS research plan. Our speaker will be Dr. Sajjad Al-Rahman. Dr. Sajjad is a professor of pediatric consultant neonatologist at Sulaiman Al-Habib Hospital, Qasim. He is an associate editor of the Journal of Clinical Neonatology, and he's now directing the medical research in the Saudi Neonatal Society. Dr. Sajjad.
Assalamu alaikum. Thank you very much, the chair and the organizing committee, for allowing me to present this very important subject. In fact, we started this with the initiative and the vision of Professor Abdurrahman Al-Nimri and Dr. Jasmine Abris. They started thinking about starting research from the platform of Saudi Neonatal Society. And they asked me to take the responsibility to initiate some plan, which I happily accepted. And today's presentation is only to present our thoughts with you. And we just want your opinion and your input, your guidance, and your leadership to come and participate in it and advise us, is this the right thing we are thinking about, or it can be made better than what we are already thinking. Research and development at the national level, which is what the SNS is thinking about, these research and development plans are a hallmark of developed world countries. And you all have worked in many developed world countries and done your fellowships and trainings and surveys. And the data which comes out of these research and development activities, it guides the growth and development of the nation as a whole at various levels in various fields and at various steps. So we decided to streamline the objectives. What SNS research and development plan should be aimed at? So we had three objectives in our mind. One is to develop a national neonatal perinatal research strategy and plan of action, which I'm just going to present to you. The second is to provide training in research methodology. And the third is to launch national neonatal perinatal research projects. Many of our colleagues are doing excellent job and excellent research at the institutional level, and some are doing it in a collaborative way as well. But we do not have something at the national level, as it happens in many developed world countries. So first thing we did is to start establishing an office for the research. And we did a little bit of setup in the Saudi Commission's setup with the existing resources, with some secretarial support and coordination and communication. The second thing which we are thinking to do is to establish a national neonatal perinatal database or a registry. And this is very important. We have been discussing this with our senior colleagues like Professor Saada Saidi and others who have done a lot of work in the past on this one. But this thought could not be materialized, and it has not reached a level where we can say that we do have a reliable national database which can form the basis of our research and planning for improving perinatal and neonatal care. So we need to have this database and registry. The second thing is that this kind of database registries exist everywhere. And we know all these famous registries in well-developed countries like the NICHD registry, Europaristat project, which is a 26 countries conglomerate in Europe with one registry, and the registries in Canada and the Australia. In the Middle East, we also have one very good registry in Lebanon. That's a National Collaborative Perinatal Neonatal Network by Dr. Khalid Yunus, and it's working very well and providing a lot of data and a lot of publications coming out of it. And when I was in Qatar, we established this Qatar's National Perinatal Registry, which we called Q-PeriReg. And that was my experience, which I wanted to share here and see how can we do that. Qatar basically is geographically a small country with small population, a very consolidated place. So we were very successful in establishing a national neonatal perinatal registry, which we did in 2010. It was a totally electronic database. And we prepared a custom-made software from a company in UK called Edendrite. And it was a huge registry because there were 600 data points for each patient, each mother baby pair. And the data was collected daily, and there was within the registry, there was an inbuilt statistical system which could help you analyze and give you the data in the analyzed form for publication. One of the big problems and a big challenge which we face with every registry is the safety of data. Though the registries are not supposed to be naming the patient individually, it is a collective data, but still the data has to be safe. So we made it safe through the electronic means, hosting the data, web server safety, and everything which would possibly be done, protecting it with the passwords, account control, system timeout, data audit, and all these things were built in the system. And then from this system, we started generating data and publishing it in various journals. And it was very easy. And we could publish the total number of deliveries in the country, in each hospital, total number of babies born, total number of stillbirths in the country, number of live birth babies and at various gestations, and the preterm babies and their profile. And then we were also able to do some historical work. We went back into the database of Qatar Statistical Authority, as well as the database of the Hamad Medical Corporation, back as 1975. And then we were able to generate the graphs as how there has been an improvement in that country in its neonatal mortality rate, early neonatal mortality rate, late neonatal mortality rate, and perinatal mortality rate. And this shows how the system has progressed successfully. And this was quite reliable data because the control was very good and it was doable. So what happened is that this QPARIRAGE became a reliable resource of national development, research containing both research and administrative data. And a lot of people could do their research, including the trainees and the fellows. We also published a number of papers, and we wrote 2 books on neonatal perinatal mortality. Most of the data was coming from Qatar. And this is one of the book which I published on neonatal and perinatal mortality in 2015 with global challenges, risk factors, and interventions, but with a number of contributions from colleagues from other countries as well. So can we go ahead and have a Saudi neonatal perinatal registry? That's a big challenge. And that's the thought I wanted to share with you. And that is where we need your advice, your input, and your leadership to come forward. Well, Saudi Arabia is geographically a very big country. It is a diverse type of place. It's not a small country like Qatar. And the population is widespread in many areas. And what we need is a reliable data collection. The data which we should have in the registry must be collected in a reliable way. And the big question is, who is going to fund this project? We do have a lot of good opportunities. MashaAllah, we have a large number of very good healthcare institutions in Saudi Arabia, very enviable and very well organized. And we have a large number of well-trained neonatologists. All of you are here and you have done a lot of work, very well established and well-known people here. So we don't have a deficiency of manpower resource as a researchers, and we don't have a deficiency of institutions. And then we have a number of good neonatal fellowship programs running throughout the country. So a lot of fellows are available and they are bound to do research as a part of their training. So there is an opportunity that we can utilize them and you can train them as well. And there is a very good communication system which needs more improvement to work together. So for a Saudi neonatal perinatal registry, our proposed plan is that let's take a small start. Instead of taking a big start and not achieving anything, it is better to take a small start. So instead of having a software, we can start from just Excel-based data collection. And instead of having 600 data points, which we had in Qatar, we can have a small number of database points, 30, 40, which are easily doable, collectible. And as we go forward and we become more confident, we can expand the database and we can have more and more data. We did ask for a part-time statistician, and many thanks to Saudi Neonatal Society. They did agree with it. And we will need country-wide data collection centers. So your suggestions, advice, and expert opinions are welcome. We are here to move forward and take everybody along. The second thing which we were thinking in the research plan was a half-day seminar on priorities in research in Middle East. Well, we want to do research, but what is our priority? Should it be perinatal epidemiology? Should we have some kind of multi-center research projects? MRCTs are what is better for us at this stage? Of course, we would like to do everything, but we have to prioritize. Let's post first thing first, doable thing first, and then we slowly, gradually go up and do everything. So we wanted to have a Zoom-based seminar, which we did organize, but we have not yet been able to implement it. Probably in 2023, we'll be able to do this. And we want to call international research experts. And I was talking to Dr. Yasser Sayed yesterday about it, and we need their advice and input as to how we should move forward on it. Then we wanted to have some training sessions at national level in research methodology, which most of our fellows and junior colleagues do need. And we can do that from the SNS platform. And our young colleagues must know how to write a research plan, how to apply for a research grant, how to do statistical analysis, how to publish the papers, and how to follow all kinds of research ethics and IRB code of conduct. We also thought that probably we should be able to launch at least 2 well-funded national multi-center research MRCTs. We don't have any specific idea with us, but of course, everybody has got his interest, and some colleagues are better in one field than the others. Some are more interested in ventilation, others are more interested in nutrition, and so on and so forth. So we want to welcome any ideas, anything which can be done at the national level and which we all can contribute to and do it easily within our resources, within our circumstances, and make it a success. And also funding ideas are also welcome. And I've been discussing with this Dr. Ali Al-Mudir, and we decided to go and contact the KCAST. It's one funding resource, but there could be many other funding resources. And we can work and collaborate with other colleagues in the region, and maybe we can find some research needs some funding and definite funding and a commitment. The one reason which we were successful in Qatar, because Qatar has got one very good research funding body, QNRF, Qatar National Research Fund, and that gives a lot of definite funds, and it promotes research, so that money makes the mayor go. So we need to have money to go ahead. I just also wanted to share that we do have our own experience of participating in international MRCTs, and as well as having our own MRCTs. And when I was in Qatar, we participated in 2 big projects, Twin Birth Study and NIPPV trial, which are the projects funded by the Canadian Health Research. And then we had our own MRCT MACUL study. This Twin Birth Study was international MRCT from Women's College Hospital in Canada. And we participated in it. And luckily, Qatar became one of the best recruitment center, because we had one big hospital with 12,000 deliveries a year. And we had a very big NICU, 105-bed NICU. And there are patients everywhere. So since we were dedicated to the work, so we could contribute that. So we became the best recruitment center.
Dr. Sajjad, 1 minute.
Yes, that's what, inshallah. Then NIPPV trial, we were the same, and we participated in it. And this was MACUL study, our own trial, which we initiated from Qatar. And for that, again, Qatar provided, the institution provided us 600 million riyals as a 3 years project to be done. And we recruited many centers from the region. We trained the staff, and this was the project where we're comparing hypothermia alone with hypothermia plus magnesium sulfate. And these are our recruitment centers. And the biggest number of patients came from Turkey, very good friends and colleagues there. And thanks to Dr. Jassim and Abaris, and we also had some patients from Saudi Arabia. He was one of our participating center. This is the paper we published on the feasibility of this study. So the plan is, let's take our first small steps. This is what I'm here to give the message. And we are here and we are open. There's a WhatsApp number. It's my personal WhatsApp number and mobile number. So please do send me the message or do send it to SNS. And we are open and welcoming to everyone for your suggestions. So the greatest player in life is doing what people say you can't do it. But inshallah, we will do it. Future is not a gift, it is an achievement. Thank you very much.
Thank you, Dr. Sajjad, very much for your initiative. Now we'll have 15 minutes for a question and answer. I would like to ask our respected speaker to be in the audience, please. Dr. Sajjad.
Size chairs.
Yeah, I thought I kept it on.
Small people, I guess.
Okay, so any question for the speaker of the first session today? Dr. Yasser.
Yeah, thank you for accepting my question. So I have a comment and a question to Dr. Adnan about the quality, which is actually the future on practice and improving our quality of daily practice in intensive care all over the world. So I would just like explain a little bit more about our experience in Canada and EPIC. For the last few years, we moved from considering quality as a science, as courses that you can attend and practice in our unit. And we created specific groups, and these specific groups, we got very successful models that can be reproducible in other countries, including Saudi Arabia. So we created the specific national groups in certain domains, including infection control, hemodynamics, brain health, lung health, and so on. And the key of success of that, the teamwork that should include not only physicians, nursing staff. They are very important to be included as a respiratory therapist. We meet actually in almost monthly basis as a national group, and also in the local group in each center. And we have a very clear report about our progress in each domain. And I'm actually a member in the 3 domains, specific domains in EPIC, and I'm a facilitator in the national EPIC courses. Last week, we had a meeting with Dr. Khalid Aziz and the team, and we discussed that we can have outreach program that we can communicate with other associations all over the world and proceed not only from educating quality as science to have specific projects specific to certain issues in certain countries, including Middle East countries. So we are like happy to collaborate with the Saudi society and progress forward for that.
Shukran jazeelan, Dr. Yasser. Thank you very much. I think Prof. Nimri, remember that we faced a problem before in doing this course in Saudi Arabia, the EPIC course. That's I tried to implement in the hospital, because in our hospital we are using focus PDSA, just because it's very simple and it's not that difficult. And to implement any methodology, I think it's not simple, as you mentioned, because all the people, once you have a team, let's say a team to decrease the FAB. So most of the people believe like a study or any, you are preparing for any research, just you have 3-4 doctors, they are working together. Quality is more difficult and more complicated and time consuming. It will take sometimes years to achieve what you need to achieve, really. So to have your team, you should educate the nurses, the RTs, doctors, all the people involved really in that problem, the stakeholders of the problem. So to be able to convince all the people to work at the same time together, I think we need time for that. It's not, I mean, that the change is not going to happen within day and night. It's going to take years. So we started in our hospital. Dr. Dassem also is part of the team. We are trying to make like a curriculum for mainly residents and fellows, and we are trying to spread it. Maybe consultant will find a lot of resistance, and this is for a lot of reasons. But at least we started not only to tell the people that the quality is good. So we are trying to to educate them, because I think the most important barrier, because they are not aware about the importance of the quality, how to do it. If you told them that the quality improvement project is very important, decrease IBS things whatsoever, but they don't know how to do it. This is a very big problem. If the doctor, they are aware about it, but the nurse is not aware, they don't know how to do it. So you should educate a lot of people. You should have support from the hospital or the institute you are working there. Then you will be able to do it. So, I mean, like a simple course we discussed with Dr. Ayman Abu Mahram. We were able to do it online in Syria, but we failed to do it in Saudi Arabia because of the cost. We did not find any person to support us, but Prof. Nimri, he promised to support me in that. Shukran jazeelan.
We have one more question before you. Go ahead, Victor. The mic, use the mic, please. On. In the middle. No. Yes. Okay.
Which one? Thank you very much. I'm Dr. Asim from the MCH Hail, consultant neonatologist at MCH. Simple question to Dr. Khalid about the flexibility of medications. For example, the water-soluble medications. If I just write the dose and to the nearest round figure. For example, this baby is 3.2 kg and 3.1 kg, and the dose is 50 milligram per kg. Ampicillin, for example. If I give 150, pharmacist will call me, doctor, your dose is wrong, it's so and so and so and so. And the nurse sometimes read the new facts and tell the doctor the correct dose is so and so and so. What do you think about this? Because sometimes the reference which you give, the new facts and the BNF, they give different doses. Great difference. I depend mainly on new facts, but sometimes I go to BNF, I find differences in the doses. What do you think?
Thank you, Dr. Hassan, for the question. Yeah, I totally agree with you. And I have faced this recently. For example, with dosing genomycin for babies, giving some reference give you 4 per kg once daily, the other give you 5 per kg Q24 hours. So this makes also a difference. So what I would highly recommend, we try to go with our formulary reference in the hospital or the institution they're relying on for checking the doses for pharmacy and physicians and nurses as well. And if it's not available, then I move it to the next step. And I try to have this, if it's not available in the formulary and check another reference that's not handy for other pharmacists in the front line of verifying orders, have a copy or provide it to them so they don't have to go back to the doctor questioning the dose, because they won't be able to access all the references at once. All that they check, they can check what they have as a formulary. But again, other doses, BNF, sick kids, new facts, if they don't have access to it, I will have to provide this reference to them so they can proceed with the dose. If that answers your question.
Thank you.
Yeah, but that's a common area for conflict between pharmacy and physician nurses when prescribing doses for those population. Thank you.
Okay, next, Dr. Namri.
شكرا للسبيكرز كلهم. أنا will be saying in Arabic. Quality research من المواضيع اللي تثير المواجع. أنا ما نبغى نثير مواجع الناس. لكن what I will get from this conference to recommend to start. And to start, you need to have a backbone. And unfortunately, we are at the end of our board directory. Maybe 1 month, you have to go to another institute. So get the backbone, continue with us. Adnan, Sajjad, continue with us. And once we get the backbone for you, we'll solve all this obstacle. My question for Nisreen, we agree with you. We agree with Adnan. Quality is good. It will improve, especially the immediate outcome. But is there any cost-effective study to tell me about the long-term outcomes? That if I apply all this quality, that will improve my preterm babies' quality of life as we improve the quality of care. Thank you.
Both of you. You can comment.
Okay, thank you, Prof. So as you know, that's what we call quality improvement projects. And every project, by definition, it has time to start and time to end. So once we are saying 18 months, that's mean 18 months is done. So after that, we monitor. That's during the quality improvement projects, we are not fixing a problem, we are fixing the system. So if you fix the system, that's mean if it's working toward improvement, that's improvement should persist. And this is a very big challenge for any project. to test the improvement after they stop the project. So it's still, there's improvement, it's great, it's part of the project. But if it's back to high rate of IBH things, they did nothing, just show that I did project and I improved the quality within 2 years, 3 years, then all the things is collapsed. So unless you fix the system, you'll not be able to achieve persistent improvement. Shukran.
You want to comment, Dr. Nisreen? Is it?
Okay, for the cost effective, I think yes, yani, the aim of the quality improvement is to improve the outcome as well, to achieve the create culture of the improvement, patient and as well the patient. Now that we are caring about the patient experience, and we achieve all these yani, with the least cost possible to the system. And if we're trying to do the see and we'll see the improvement, might we yani, will get yani, cost effective.
We have a question from the virtual group. Can you give us the question from the virtual? Dr. Heidi. Shakil, can you put the mic? She said she's still quick. The mic, please, for the one from the virtual. Got it. She want to say it. She want to comment. طيب, while that, we can take a question for Dr. Zahra first. Dr. Zahra.
Assalamu alaikum. Thank you for all the speakers for this session. My question is to Dr. Khalid Taher. Always, it's not always, but a lot of times we are facing that we are using medication that's out of label or even contraindicated. Like, for example, I have a baby who's having an organism that's only sensitive to trimethoprim. And my colleague in the ID consultant, she insists on using on that. And she sent me an article about a case report similar to my patients and how they use the trimethoprim. So my question is, what your recommendation in such a situation?
Thank you, Doctor, for the question. So these happen from time to time, and it depends on the medication. But going to your example, talking about Bactrim, I would think about the reason for the contraindication, right? So when you think about bilirubin displacement and having high bilirubin causing kernicterus, and I have no other options, I run out of options, what available in the institution, what I can use, susceptibility results. So I would balance benefit risk ratio, and I might go with using the medication, but thinking about the reason for contraindication, I know now what to monitor while using it. So I will keep an eye on the direct bilirubin level, keep an eye on the patient's symptoms of having kernicterus, and then I will proceed with using the medication. It might happen also with other medications, like, for example, using fluoroquinolones. I see it a lot in pediatric population. If you look into the contraindication, it's all pediatric population. But think about cystic fibrosis patient having Pseudomonas admitted to the intensive care unit with severe infection complications. So I would look into the benefit risk, and then I would use it with monitoring the patient.
But what about the dose?
I would go with the lowest dose possible in the range, if we have the range. And then I will keep monitoring the level I want to monitor to look for the side effects anticipated. But yeah, I mean, we have faced some, and I haven't seen it much in here in my practice in Saudi, but I have seen it in Oklahoma, where I did my residency, where we used it and we monitored for bilirubin. I remember it was Bactrim or ceftriaxone, but one of them, and then we monitored the patient for high bilirubin.
Okay, question for Dr. Saad first.
I would like to thank the speaker. I think it's a very important session. And, you know, the Saudi neonatal network, it's a dream for all of us. Unfortunately, there are briefest trials and started about 17 years back, and other trials after that. And unfortunately, there is a lot of obstacle, but I think it's the time now to cooperate together and to start. I remember in 2005 to 2008, you know, the Australian New Zealand network, which is free of charge. And we in the society start to adopt it. And with the help of one of our colleagues, a neonatologist, Dr. Fahd Al-Harbi, even he went by himself to different centers in Saudi Arabia to explain how to use it. It's a very strong one. But unfortunately, there was some obstacle in some center. For example, some center, they don't have somebody assigned to enter the data. You cannot leave it to the resident and the assistant and the specialist because they have other things to do. This is one. There is another trial also from the society itself, no, from Ministry of Health with CNN, Canadian United Network. And they are really very cooperative and it's not costly. They just request that you have assigned a person for each center to enter the data. And in the committee of advisory committee, neonatal for improvement neonatal care, Ministry of Health, we adopted it. We had a lot of help and support from some of our colleagues in Ministry of Health. We had a problem with the legal issue that if there is any dispute, you go to a Canadian system or you go to Saudi system. So the lawyer gave us a difficulty in this. Then there was a solution that, you know, intermediate party like company in the middle to take care of this, but this is also costly. So I think the time now to have our own, and we need some support, financial support. For example, if each center assign 1 or 2 persons to enter the data, we'll assign the database. And I think, I know in the start, it will be a lot of difficulty, but let us start. Thank you.
Yeah, thank you very much, Professor Saad. I think this is exactly what we are saying now. This is the time to start. And let's get together and move on. And we can have our own database, inshallah. Thank you very much.
So let me ask the question from Dr. Heidi. So she writes, thank you to all the speakers. Dr. Sajjad spoke to me 2 to 3 years ago about this, and I told him about the challenges. We are on the map soccer now, but we are not on the map when it's come to neonatology. The biggest problem is we have a different sector, and we cannot exclude private hospital from governmental hospital because that will reflect huge selection bias. The decision should come from Ministry of Health. Single center or 2 or 3 cooperating centers will never put the Saudi on the map. We have to have the order from Ministry of Health when it's come from there, every hospital will obey.
Yeah, I think, thank you very much. I did speak with Dr. Heidi quite a few times, and she has been very helpful and supportive, and I agree with her comments. I think this is the time to put Saudi Arabia on the world map of neonatology, as we have put it on the FIFA map as well. So this is the to do it, and inshallah we'll do it.
I totally really agree with the neonatology. I mean, starting Ministry of Health, we have a lot of program like life-saving program. It's an excellent, and the big bulk of the hospital, I mean, the organization for health sector is coming from Ministry of Health. So if the Saudi Neonatal Society approach like a big institute like Ministry of Health, and in such a project, and also involving the Saudi institution for health research too. So including these two big institutes will maybe get us back to the map, or starting us putting in the map.
Yeah, I think I did discuss this with Dr. Ali Al-Mudir, and hopefully with his presence in Riyadh, we'll be able to move forward with that.
The last question, Dr. Atullah.
We have some experience in Tabuk regarding using database. We start to use it at the beginning of this year, is 2022, in January. We establish an Excel database. This Excel database is a little bit advanced. We use Visual Basic for application as a program. We build, a sheet like, and we start with almost maybe 130 columns to be filled. We get to extract, some important information with little, actually, not much. Like, for example, neonatal deaths, like neonatal hypothermia on admission, and a lot of data through this Excel sheet. A little bit advanced, but we can share you with this Excel, and we can help you also in our experience.
Yeah, thank you very much. That will be great help. I look forward to that. Thank you very much. Appreciate it.
I know there is a lot of question, but because of the time, you can ask our respective speaker later. So we'll give you a 25 break, and we'll come for the next session. And for the moderator and the speaker, the lounge will be in the second floor, right from the hall. Thank you very much for you, and thank you for our speaker. Excellent session. Thank you very much.
نحن بأنتن كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو وتحسين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشائم بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين ما من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشائم بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين ما دور من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشائم بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين ما دور من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشائم بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين ما دور من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشائم بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين ما دام من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل
Ahmad, please project laptop. Be not here. Hello, doc. If you like use wireless, then you can use this.
I am the second one, somebody.
Okay. I put here.
Is there any, somebody can use the mic outside to tell them to come back to the lecture hall?
Yes, doc, in the
In that
paging area, yeah.
Let me
The
see. I will try to.
security area. Put it here, if you like.
كيف الحال؟ سجلت في التأمينات
الله في الوطن.
تبع التأمينات ايش البلوك تيرم بلان تجلس فيها؟
والله يعني في اكزت بلان زي ما يقولوا بزنس الان بديت اشتغل مستشار مع الشركات وزاره شركات
وعند تبع زميلنا هذا اسمه
اي ابراهيم لا انا مع شركه شركه ما هو شركه صحه القادره طبعا احنا مع شركه انا موقع عقد شركه صحه
تبع مين الشركه؟
شركه
تبع مين يعني المالك؟
الفوزان شركه اونر لا اسمها من شركات الفوزان
فوزان على
كل شيء
أجل الفوزان هذا ما شاء الله يعني يلبسك ويعالجك بعض الناس يا أخي يعني صحيح تحتاج يعني أحيانا أحس تتوفر بين الحياة ما تسوى
لا دائما
أنت تبغى تجمع طيب عندك مليار طيب بعدين يعني what you want أنا أفكر يعني بعض حتى التجار أنا تدرك مع بعض الناس تعرف أشياء بسيطة أصعب الناس يفهمون يعني تروح لواحد راتب 5000 يديك يعني أنا مرة ما بذكر الأسماء أنا والشيخ الله يرحمه تعب مسجدنا كان اللي 5 ما بذكر اسم آخر شيء حول 5 حولها لي اللجنة لا هذه واحدة إذا أنت هذه الأمور كلها الأمور رب المال هذا يعني نقول الحمد لله داعي لزمن القيامة إذا واحد أنا ما تدخل تخليكم فوق كذا عشان ما تحرجون أنا والله عندي بين ما أقدر جاء خويكم ولا لا؟ إلا إن كان تبوني أبدأ هو بعدين
لا هذا هو يقول وصل لا وصل
هل وصل؟
يقول وصل بس
انا بها
بس حضرت موجود
حضرت له
لا
حضرت على
بسيطة يعني حطها على طول
نرسلها
وبعدين حتترك المستشفى يعني ولا حد
يعني
ولا تمارس؟
لو قلت خلاص يصير ضغط
انت ماسك الإدارة صح؟
تعال على الليكشر.
قلت لي مرة انك شيخ مين ماسك؟
انا اسد واحد في
على طول.
احمد
ما يبغوا جينيتيسيس تساعد؟
لا
Speaker, let him come to the podium, please. Leave him alone. Don't shake hand with him, please.
شغلونه ايش هو ذا؟
يا محمد الهندي اترك السبيكر حقنا لو سمحت. ولا مين؟ Leave him alone.
Let's go.
عبد الله سيف
سيف هو سيف اللي ماسكه. ما انتبه. انا اسف يا طويل العمر. سيف ماسك.
يلا عشان نبدا. الله يحفظك. بارك الله فيك. الحمد على السلامه يا دكتوره ولياس.
السلام عليكم. انا المحاضره الثانيه والثالثه.
يا ابو عبد الله عذرا غلطت فيك. اشوفك بعد السيشن. متاخرين يسجل 17.
لا يقولوا تعطي بريك.
ايه انا
لازم تحط اليو اس بي. انا احطه في المحفظه. في المحفظه.
ليش؟ طلعوا من الايميل ارسلوا لي على الواتساب. انا
وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشام بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين ما من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل أجل الآتي اليوم للكل يد في التغيير. نحن بأنتن وأنتم، نحن بأنتن وأنتم، كلنا بكبير وصغير.
And welcome back. And we need to start the session. In this session, we have 3 presentations, all related to the newborn screening and genetics issues in neonatology. We have 2 speakers. The first speaker will be introduced to you by my colleague, Dr. Fahd Al-Aqel, well known to you, and he will present the first speaker. Go ahead, Dr. Fahd.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody, and welcome for this session, which is really part of our preventive health, which is part of the Vision 2030. And an important component is the screening in the preventive medicine. So the screening of neonates is well established now, and we are starting as a country on screening babies for metabolic screening, for the critical congenital heart disease screening, and for the hearing screening. Plus, of course, other screening like high-risk neonate for retinopathy of prematurity, and the other preventive screening and approaches. So we will start at this session with a presentation about the critical congenital heart disease screening in Saudi Arabia. The presenter is our colleague, Dr. Ali Al-Mudir. He's a consultant neonatologist in King Khalid University Hospital in Riyadh. He is also the director of a neonatal development program in Ministry of Health, and he is leading the transformation and the neonatal services in Saudi Arabia and Ministry of Health. So, Dr. Ali.
Thank you very much, Dr. Fahad, and thanks for my colleagues in the organizing and scientific committee. And I'm happy to share some of our knowledge and experience in Ministry of Health. How is the journey of CCHD screening and hearing loss later on this day? And I hope after those session also with Dr. Zuhair and lately we'll get some of the feedback of our colleagues in the other health sector, how they are doing their journey and how we can make it national in all health sector, which can help our newborn in this country and probably in the Middle East. So nothing to disclose, and this is one of the talk, and say that the success is not is a journey. It's not a destination. In our screening, always we are improving ourselves with the time, and we try our best to make a new methodology to reach the success with all the team in those journey. So in any disease or in anything, we need always to treat that or to mitigate those problems. We need a lot of steps to do it, and screening is just one step of that. And before and after, always we need a lot of things to do it to reach our goals and aims in those things. So what we did, probably everyone know that our colleague Dr. Fahad, he started those journey early in 2015 in hearing and screening, and probably earlier than that in metabolic disease with the other teams. we put the screening for those newborn as one of the goals and aims in this country to make and attain the safety of those newborn and to protect them from some of the disability and some of the morbidity and even death. So safety is a concern always in our work and inside the environment of the neonatology field. So going back to 1437, this is the memorandum which was sent to the people in the regions in hospital in Ministry of Health when they decided, the ministry decided to nationalize those screening to all the hospital who's delivering the maternity service. So this program starts by phases. We reached the third phase completely like 2 to 3 years back. So the first phase, if you can see that at 2015, we have around 31 to 32 hospitals join this program. And the huge work started here to show the people how this program will run and what we need to do. And when we start this program, we start by the NICU level 3. And then with the time in 2016, we extend this screening to another 69 hospital. And the final step was reaching all the hospital who's delivering the maternity service. So we end with 170 hospital joining this program, as you can see in the map of Saudi Arabia. So today we have 170 hospital joining this program distributed to all the regions. You can see the variation between one region and the others. And I think still we have a few hospitals. Soon they will join this program. And as you know, some of the scope of services of hospital change with time. So some hospital will go out and others can go in. So what we are doing in this program, so a lot of steps to achieve such a huge program from screening to the end of intervention or follow-up. So in cardiac, we start by screening babies, referring those baby if they didn't pass the screen to the cardiologist, and at the end we do echo if they discharge from echo as normal echo or refer to the cardiologist for intervention or follow-up. So this is the step we are doing to the program. So we screen the baby. If the nurse who's doing the screening will enter the data in a website and the result will be pass or refer. And those data will be gathered by one of the company called Lean. So they will analyze those data and they will send the report to the Neonatal Improvement Program Administration. Will validate the data. Then we distribute the reports for the stakeholders and the leaders in the region. So this is the phase 1. And through those journey, it's not a simple one. We go through a lot of workshop, orientation and workshop and challenges. So I just want to share with you today some of the challenges and how we solve it. Hopefully, if somebody interested in such program, it will make easier for their life. So for the screening steps, we do the screening according to the protocol. We nationalize to our hospital. Then, as I told you, we will have a result, either referral or pass, and then we'll enter to the website, and then we discharge those baby home safely, or we refer them to the next phase. In these steps, we have a couple of challenges like accuracy of data, the nurses entering to those websites, and as you know, everyone, we don't have registry yet in the kingdom, so we don't know how many percentage of the whole newborn get screening, and number of hospital, as I show you, doing the test. So the other sectors, we are not sure today who's implementing such program. And again, we have some gap in the private sector. They are not implementing this thing. So we start a lot of workshop and exercise and some of the communication networking to come with some solution. So we link those testing with the parent experience. So any parent, there's like their newborn receive this screening, they will receive a message So we just guarantee that the other people ask later on if they didn't receive those messages. So we try ourselves by help of our minister and leaders in the ministry to start those and activate those programs in the private sector and implement and monitor it. And soon, hopefully, the Saudi Neonatal Registry will get activated and help us in those. Phase 2, so it's the referral steps. So referral from the screener. If those baby didn't pass, they will refer it to the echo specialist, and the parent will receive also a point for echo either in the same hospital or the hospital who's doing those echo in the region. So this is the challenges in the phase 2. So till recently, we was doing the referral manually, and there was no monitoring for this phase. So what we did, we integrate those screening steps with Lean company to make it electronic. And today we can monitor those babies who didn't pass, how they receive the follow-up for referral, and how we follow up with them for compliance. So we have something called referral link. So the nurses, if those baby didn't pass, they will just click that link and put that information, and we will receive it as a monitoring team. So we have also KPI monthly for the referral, and we follow those baby. And as I told you, we have parent texting. So this is the link. Our teams, we have over like 250 nurses working with us in those program. They just fill it easily. It will take like 30 seconds, and we will follow it. So this is example of the texting receiving by the parents. Just to let them know, we found it as a part of awareness and follow-up, and how they can know that this is very important, and how they can follow the next step if it's needed. So phase 3, it's the echo appointment or echo centering. So we have a couple of our in ICUs, we have somebody expertise in those echoing. And when we assess this step, we found some of area have some gaps and challenges, as you can see, and either by the machine or by the centers, nobody is expert. So we did some of the improvement projects with our colleagues in the cardiology. We did assessment. So we have almost around like 15 or 16 centers, level 3 in ICUs in the kingdom doing those one, while the others have either issue in the specialist or in the machine. So we start a project with our colleagues in cardiology teams, how we can improve these things. So we start training for the centers who have huge number of babies need echo. And we start training them how they can echo and integrate with the cardiology team. And we have echo KPIs in those centers just to reach quickly if they don't have machine or somebody can do the echo. So phase 4, it's referral to the cardiology team. If this baby didn't pass the first step, and refer for echo specialist, and they did echo and they need help of cardiologists. So it's just a referral way and how we can follow those baby. So earlier on in those steps years, we didn't have anything to follow those baby. So we integrate the system with our cardiology through a Halati system in Ministry of Health. Again, we extend the parent texting for the second step, and we try to network with our colleagues in National Guard, King Faisal, and other sectors. So this is the second text we received by the parent. If their babies didn't pass a screen and he did echo and he need to follow with the cardiology specialist. And at the end of the month, we have unified reporting system for all the hospital. We can see how many completeness of the delivered baby in those centers receive the screening, and how many of them failed to pass those screen or pass the screen. So this is what we saw in our system. As you can see, this is just a screenshot for the last probably September. You can see like we have 19,000 plus newborn in the hospital of Ministry of Health. Almost 15,000 receive the screening, around like 77%, and the pass of rate of them around 98, and 1.86 didn't pass. So we have some gaps, like we couldn't reach the target. We have target every year to reach how many percent. And we would continuous improving this program, looking after why we didn't reach those gaps. So this is one of the example, like we have some cases after delivery, they will be transferred to, because of their sickness, to other centers. So they will not receive their screening at the time. And we look at one time frame period, 1 month. So they will, sometimes they miss that month. Maybe they will do it later. Some of babies, unfortunate, they will die. So they will not receive that screening. So quickly, 2021 reports, screening for the cardiac. So 76% overall completed in our 170 hospital, 24 almost not completed because a lot of examples. And this is example for the area which we receive higher referral rate. And quickly, you can see this is the high altitude area. You can see starting from Al-Baha, Al-Taif, Abha is the first 3 area which they have higher referral rate. And this is, I think, worldwide well known that the high altitude area have some higher referral rate. So 2021, we have almost 175,000 babies screened, 3,225 referred, and 977 of them have normal echo, 2,275 abnormal echo, and the critical cardiac disease, which they need a lot of our cardiologists' attention, 487. So a lot of appreciation and thanks to our colleagues in Ministry of Health for their support, and our central team in the ministry. Thanks for the company who is supporting us with a lot of workshop and training, Massimo, and a lot of thanks to my colleagues. The success which we have today is for the members who's delivering this screening in the locations, and a lot of help and support by our cardiologists and echo specialists in the region. And again, also lean the IT integrated system, and also for the families. With time, we saw a lot of asking and awareness by the parents looking for those screening to be happen. So probably my advice for my colleague today, feel free to ask us about this screen, and stress on family in a nice way to their baby should receive those screening, because it's a major concern for their safety. And we feel proud today in Saudi Arabia to have such program, and we feel very supported by the whole team. We communicate, if you have any question later on, we can communicate. And again, success is not a destination, and it's a journey. Thank you very much.
Thank you, Dr. Ali, and being on time also excellent. And the next presentation for Dr. Ali Al-Mudir will be after Dr. Rahbini. He will talk to you about the hearing screening program. But now our second speaker in this session, Dr. Zuhair Rahbini, he is a consultant genetist at King Faisal Specialist Hospital. He did his medical school at King Saud University, and he did his Arab board program and finished in 1992. So he's quite old in this. And then also he did his fellowship in Yale University in USA in genetic and metabolic. Dr. Zuhair Rahbini, he will talk to you about the screening program, the current and the future. And welcome, Dr. Zuhair, and thank you for being with us.
Assalamu alaikum. Thank you very much, Dr. Abdul Hakim, for a nice introduction and also for invitation. Thank you for the scientific and organizing committee for this opportunity to speak with to you about this program. My talk will be about newborn screening for metabolic diseases now and future. Actually, I was grown with this program since it was started in the kingdom. طبعا this is the end of morning session. Assalamu alaikum, good morning. Just a smile because Rasulullah كان يبتسم دائما وهو مثقل بهموم الأمة. I know it is the last session this morning, but just try to smile. عندي كلمتين بخاطري بقولها لكم. Introduction, case findings, history, 3 years study, how it was started, and how is the program now, and what is the future. If we look for the genetic diseases and the screening, it involves mainly the single gene disorder. And if you look for these diseases, it is considered to be rare. However, if you look to the phenotype that explained by molecular basis, it is more than 7,000 diseases. And for single gene disorder, it is exceeding now 4,500 disorder. If you look to this single gene disorder, among of this group is the inherited metabolic disorder. So now it is a huge group of metabolic disorder exceeding 800 disorders. They are mostly inherited as autosomal recessive. The gene involves the protein that is related to the enzyme or transporter or cofactor synthesis. If you look for the screening, the principle of screening of metabolic disease, this is the principle, either for screening or diagnosis. So if we go from A to B and B to C, and if there is a block here in enzyme 2, this is a metabolic disease. So how you screen for these diseases? If there is a block here, B will be accumulated, A will be maybe accumulated, or D, and this is called number 1 identification of biochemical markers. The other way to screen, you go to the enzyme directly, and this is called enzyme assay or enzymology. The third way to diagnose or screen diseases, you go to the gene directly, and this is the molecular genetics diagnosis. So this is the 3 ways to diagnose or screen metabolic disorders. There are only 2 ways to diagnose this. Either you have high index of suspicion, and this is, I call it case findings, or just you have newborn screening program, because most of the symptoms and signs of these disorders and or the regular biochemical test, you cannot differentiate between is it metabolic or non-metabolic. So what is the meaning of case finding? If I stop to speak about this from now till morning, I will not finish. So, but I will give you an example. This case was referred to our colleagues in gastroenterology as liver failure. So they consult us, and we did gas chromatography. This is the normal, and there is galactose metabolites in the urine screening. It is not specific for galactosemia, because in liver failure, the kidney spill everything, even galactose. So I went back to this patient, and I examined the eye, and I found a cataract. So I know this is galactosemia. So we start galactose-free diet. This is the same patient. And the second picture after the galactose-free diet. If you don't diagnose and you start the galactose-free diet, the patient will die with complication of liver failure. الصورة اللي هناك اللي ماسك الولد عمه, his uncle. So in future, this uncle brought his child في العيادة ورماه في البيت وقال, Doctor, my child is having galactosemia, because he knows the story. It was confirmed as galactosemia. So again, we make echo. This is the liver, shows echogenic liver. After galactose-free diet, the liver goes down and the baby is normal. This is case number 1. This patient was referred to us from Eastern province with mental retardation. So the first one, the first thing is to exclude phenylketonuria. In the West, nobody will think about phenylketonuria at this age because everybody screened. So if this patient referred in the North America, nobody will diagnose her as phenylketonuria. So we did this screening. This is the normal profile. And she has ion of 222, and this is phenylalanine. So this is phenylketonuria. In the future, the mother brought this child with her, 6-year-old, to cardiac clinic. And I asked her, is she okay? She said, yes. Is there any problem in the school? She said, yes, in mathematics. So I screened this child. She has PKUs. طبعا we give counseling everything. ما شاء الله هنا عندنا تغيب المريض سنة يجيك بطفل ثاني. فجاءتني بالمولود هذه قلت لها is she okay? She said yes, and I challenge you, this is normal. However, when I screened her, she has PQ. So this is the case finding. If you don't have high index of suspicion or a program, you cannot diagnose these cases. As you know, cure is difficult. It takes time, a lot of cost. However, the most important is to prevent these diseases. If we want to speak about newborn screening as one of the preventive program, it was started actually with the story of PQ by Dr. Fallings, who diagnosed, this is the two girls who were diagnosed first with PQ, and he labeled this disease as PQ. So it was diagnosed, or this condition, by Falling in 1934. Then Dr. Bickel, he found the treatment, the phenylalanine restricted diet. And Dr. Guthrie, after that, in 1961, he established the test for newborn screening. So it was started as a screenable disease in Massachusetts in 1963. And after that, the idea of newborn screening expanded to other disease, to include congenital hypothyroidism and so on. Till 1990s, when Dr. Millington, he is pharmacologist, and he established the technique to screen, to be used in newborn screening. And after that, in 2006, the American College established or recommended uniform screening panel for 29 diseases. And in 2010, they expanded to include 35 diseases. So this is the history of how it goes from 1963 with PQ and expanded. Now it is the era of using the molecular testing, next generation sequencing, also to be used in newborn screening. So this is Dr. Guthrie, who established Robert Guthrie, who established the newborn screening in Massachusetts. The principle of this test, it is one test for one disease. So the idea of this test is microbiology. And thanks for microbiologists. It is a bacterial inhibition test. What is the idea of this test? This is agar with bacteria that inhibited in every spot. It is bacteria inhibited by antibiotic. However, if it can grow if there is phenylalanine. So you put this the patient blood, the spot in all this, and if the patient has phenylalanine, PQ, the bacteria will grow, and the test will be positive. So this is the, look, this is positive, this is positive. You can appreciate it is not sensitive or specific, but this is the test was established by Guthrie test. We used this test at King Faisal in 1980s for PQ and MSUD. So it is the same principle. For every disease, you grow bacteria that needs specific metabolites to grow. So just imagine, for every disease, you need one blood or agar for this test. So you can appreciate that it is it has narrow spectrum, a lot of low specificities, sensitivity. It takes a lot of time and so on. And it is limited for specific diseases only. Till it came the era of tandem MS in the 1990s. And of course, it is one test for many diseases. This is the Dr. Millington. He visited us actually at King Faisal during Dr. Ozand, Allah yarhamu, in early 90s. Even this test was not established in Canada at that time. There were few centers in America who used to do this test. So we are one of the country that actually used tandem MS for newborn screening. Dr. Rashid, who was here, he to make this test with the data. as maybe the first people who automated the data to be used even internationally. I don't want to speak about the technique, but if you have question, I can answer it later. And this is Dr. Millington, who is pharmacologist, and Dr. also Rashid, who is pharmacologist, both of them PhD, and they got this award in 2009 for their work. And tandem MS, of course, it has a lot of advantage. One test for many diseases. It has short time analysis with good sensitivity and specificity with minimum disadvantage, like initial cost. You have to run the test overnight and cannot separate isomers, because it is biochemical test. After that, the era of electrospectral ionization, it is new edition of tandem MS, that it can look for large molecules. So you can look for amino acid, organic acid, nucleotide, bile acid. So it is more advantage than the regular tandem MS. So to decide to screen, I don't want to go all this. You have a specific criteria. It was established by Wilson and Jingner in 1960s. He put this. It is not only for metabolic, for any health problem. And American College established this criteria also, and it was published, both of them. It is basically you look for the condition, analytical character of the test, and if there is treatment or no treatment. There is WHO criteria for screening. The most important, there should be scientific evidence of screening program effectiveness, and the overall benefits of screening should be outweigh the harm. This society is called International Society of Newborn Screening. Also, they establish criteria. It is almost the same. You look for common diseases, screenable, there is treatment, and so on. So this is the recommended uniform screening panel established by American College of Medical Genetics to include 29 conditions. It includes amino acid, fatty acid, organic acid, and other diseases like congenital hypothyroidism, cystic fibrosis, and others. So this is essential for every state in North America to have this at least 29 diseases. Of course, it is dynamic. So every time you can add or delete some of these diseases. Basically, you look to the outcome, condition, test, and treatment. And so with time, you can approve some addition of these diseases, like hearing test, like SCIDS, Pompe disease. They include mucopolysaccharidosis type 1 and X-linked adrenoleukodystrophy and so on. And they reject also other diseases because of some limitation of treatment or other issues. So the recommended uniform panel now in North America, it include 35 diseases. So they add these diseases now to be like recommended screenable test in every state in North America. So the current biochemical screening done everywhere now, there is one run of test. It is one test, one biomarker for one disease, like galactosemia. And there is at the same time multiplex test to be done by tandem MS to look for many diseases. Of course, now it is the era of molecular testing. The census now, it is not to be the first test in newborn screening. However, it can be done for diseases that there are no like biochemical markers, like SCIDS or spinomuscular atrophy. Or if you want to confirm diagnosis, like a second-tier test, like what happened in cystic fibrosis or hemoglobinopathies. Of course, the metabolic disease to be screened, it is not a test. It is not just to do blood test and you say this is positive or negative. It is a program. There is a lot of element pre-analytical, analytical, and post-analytical. And if you want your lab to be accredited by مثلا CAB, American College of Pathology or so on, they will examine your lab about all these items. So this is my philosophy. If you want to be successful, just use your resources. So either you do it or not do it. So just use your resources to start and run after that. So what happened in the kingdom? If we go to with the history here, it was started in 1980s, as I said, by bacterial inhibition test, Guthrie test for phenylketonuria and MSUD at King Faisal. Then advisory committee was established in 1989 to look to this to be a program or not. As I have said, tandem MS was established in 1990s. So by that time, we started to use tandem MS for screening. So after that, we started with this pilot study at King Faisal. So you have to convince the Ministry of Health that it is a needed program. And after that, a proposal was raised in 2001 till it was approved as a program in 2005. Really, we cannot ignore the work of other colleagues like Dr. Naeem and Dr. Jirayan, who established really or give the first idea about congenital hypothyroidism. They studied this in 500 neonates for 6 years, and they saved really, طبعا بعد توفيق الله, 500 neonates with congenital hypothyroidism. And they published this paper in 1996. At 1993, I was a fellow in the back, as you see. النص اللي في الصورة الله يرحمهم متوفين. دكتور المرزوقي الله يرحمه كان رئيس مركز الأبحاث. دكتور أوزان محمد راشد. So they look for, and this is the all group that. So after that, we did this study. I don't want to go through it. It includes 3 hospitals. Dr. Saad, he knows, King Abdulaziz University was with them, King Faisal and Prince Salman, and now it is called King Salman. So we did this study, and we found that the frequency is 1 affected newborn among 1,381 a newborn that confirmed by gas chromatography. So this is the initial test. This is the initial study. When we expanded, it was like 1 in 900. But if you compare it with other countries, it is at least, our frequency is at least 4 to 5 times commoner than the West and Australia and Japan and so on. So after this study, at that time, Dr. Rashid and me raised this proposal to Ministry of Health. Maybe most of you never heard about this. We raised this to the Minister of Health at that time, Dr. Al-Mani, and it was approved committee after committee till it was approved by royal order in 2005 to include 17 diseases, organic acidemia, amino acid disorders, congenital hypothyroidism, and so on. After that, King Salman al-Markaz al-Aaqa take over for this program. Till now, he is supervising the program in 2005. Ministry of Health, 2013, they took the program by themselves. كان رمضان 23 رمضان ليلة قد تكون ليلة القدر. أرسلوا ميمو don't send anything to King Faisal. We have our own lab. لا خلونا نصلي ولا خلونا نشتغل. المهم, they took over. I don't know what happened in Ministry of Health. Somebody can comment about this. الحرس الوطني, they were with that till 2013. Then they took they did their lab and they screened their neonates as if 14. وزارة الدفاع 2018. So they have their own lab and their neonatal tests. So what is next? There are many obstacles for this, like incomplete demographic data in the paper, early discharges of newborn, and so on, communication issue, limitation of metabolist, dietitian, and genetic counselor. So many issue needs to be solved really with the care decision maker. However, you cannot establish newborn screening program without really other preventive program. Because يعني زي ما شوف يعني you can diagnose a newborn, but you cannot prevent it. So it will be positive. You treat the patient, but they will have the disease. So basically, you have to establish another program like premarital screening, BGD, and prenatal diagnosis. So this is the idea.
2 more minutes. 2 more minutes only.
طيب البروجرام هذا you can start from here till end of life for any health disease. للأسف premarital screening program بدأ قبل newborn screening program بسنة, but still now we are screening for 2 diseases, sickle cell and thalassemia. يعني you can expand this. يعني أنا ما أذكر إنه جانا أصلاً من القصيم, مثلاً قصيم أضرب مثال, positive sickle test. طيب why you are putting all this money budget for area that they don't have the disease? من الشمال مثلا يجينا fatty acid oxidation واشياء ثانيه VLCAD and still they screening for premarital local. كل اسبوع يجينا 1 case from northern area with VLCAD deficiency. Prenatal is one choice for married people to diagnose these cases antenatally by chorionic villus sample or amniocentesis. في فتوى طبعا if the يعني fetus affected by genetic disease that lead to يعني body, mental or long term, 3 physicians should decide about termination of pregnancy before نفخ الروح اللي هو 19 أسبوع. طبعا المشايخ they cannot look for 800 disease by disease. We have to sit as a physician and decide what are the diseases that can be terminated. So يجوز إسقاط الجنين قبل نفخ الروح قبل 120 days, which is 19 weeks. You can terminate after 120 days in 2 situations. If there is health risk on the mother, or the fetus died after 19 weeks of gestation. لكن for any disease that you don't diagnose before 19 weeks, except for these 2 conditions, you cannot terminate. So you have to make your decision early. طبعا we speak, this is some lessons from the program. I know people speak about KPI. I defined KPI like keep people interested, keep people informed, keep people involved. Just putting KPI with number, everybody can put number. And I can give you example later on. Some important factors. You have to keep values for every program, for everything. نحن قبل الانتخابات العين مفتحة. After election كل واحد سكر. So you have to keep your values all the time good. Leadership is very important for any program. If you don't have good leadership, الطالب يكتب على جدار المدرسة للبيع ومعها المدير. Because he doesn't trust the leaders. حتى شوفوا الديك يعني مملكة الحيوانات عندهم leaders يعني. Put the right man for right job. This is very important. خرج الحصان للحرث وخرجت البقرة للسباق فخسرنا المحصول وخسرنا السباق. هذا ما يحصل عندما تتغير الأدوار. Teamwork is very important. Media is very important. We did write many things in journal, Arabic journal. So in conclusion, in our society, there is huge demand for preventive measures due to high incidence of genetic diseases, especially autosomal recessive. National genetic program for prevention should be priorities for the health decision makers. Genetic counseling is the key for education and facilitating the decision making. identifying the mutation are the most important step to offer preventive reproductive measures, and there will be always a challenge. So the take-home message: neonatal screening program is not a test; it is a program. You never give up. مثل هذه الضفدع يعني it will be swollen بس ماسكة في يعني حلق الطير هذا. It is like this stone, and صاحب الهدف لا يلتفت لمغريات الطريق. If you have target, you have to be patient, do your best. Somebody can work after you. This is some of academic effort I did. In this book, I talk about the newborn screening in the kingdom, and thank you very much. Just one point. Do you know what is UGA? In genetic, it is a stop codon. So if there is stop codon. So I will stop here. Thank you very much.
Thank you, Dr. Zuhair, for this nice overview and sharing your experience with us today. We will leave the question at the end of the session, and without any delay, I will call for the next presentation. Again, Dr. Ali Al-Mudir will present the experience of Ministry of Health with the universal neonatal hearing screening and the challenges and what they succeed on. Dr. Ali.
ارسلتها لك على الواتساب بس هذا حاجه بكي لازم شو يحط بيبي
Thanks again, Dr. Fahad and Dr. Qattan. So this is the second part of our newborn screening program, and I will start by what Dr. Zuhair ended. So it's not a test, it's a program. So we have a lot of steps, a lot of phases. We went through a lot of workshop, exercises, and training and challenges. So the hearing screen and cardiac screen and even metabolic screen, almost similar in some of the way and some variation. So mainly the hearing and cardiac, it's started on the same time, and always most of the time we have the same team. So probably a lot of the slides I will waive it because it's almost similar like cardiac screening. Then I will concentrate on the some of main solutions for the challenges we have it in this program. And I promise Dr. Qattan that we'll finish at 12, right? So we have 9 minutes to go. So we start by the memo by King Abdullah ibn Abdulaziz in 1435, which was through the Saudi Council to deliver this program for the screening, especially the hearing, and prevent the disability from the hearing loss. So again, the same hospital today, we have it joining this program, and the same distribution in the kingdom, and almost the same steps we have it, except that when we have a referral failure, we refer the second step to the APR centers, audiologists mainly, and then if those baby didn't pass this hearing screen, they will go to the cochlear team, and they will have their implantation and rehabilitation. So the same way pioneers, and the same way we deliver the reports. Phase 1, we have some challenges in how we have the screening and result and entering the data, the same challenges and solutions. And phase 2, we have referral if the baby or newborn didn't pass the hearing screen from the screener, he will be referred to the ABR centers, and they will receive appointment in the centers distributed in the hospitals. So the nurses will put those referral or failed test in the referral link, and we will receive it and follow it over the month. So the parent again receive another message if their baby didn't pass the initial screen. And here we have the test center 2 years back in the kingdom. We start by 15, and yearly we improve the number of audiology centers and specialists who's delivering the final or APR diagnostic test. So here how we improve over the years, over the centers, as you can see, and we reach today in 2022, 23 centers can doing the final or diagnostic test if the baby didn't pass the initial screening. So the same challenges on the phase 3 and phase 4, and this is how the phase 4 centers improve over the years to get and maintain the capacity of our babies. Because when we deliver this system, we start to see more babies need diagnostic tests, and more baby need some assessment in the cochlear program, and more cochlear implementation over the years. So this is how the numbers improve over the years to accommodate those baby. And last year, like the Ministry of Health centers did like 400 plus cases, and how this program with the whole screening and cochlear team improve their way to deliver the intervention in the targeted, and let us say before the target, but we are improving. So 5 or 6 years back, we was doing the like cochlear implementation at the average age 4, and we improve over the time by the integrating all the steps. So 2022, we could reach the average age of cochlear intervention at 1.5 years. So to make this happen, we have to extend and expand our cochlear centers in the kingdom, and that was not something easy. So when the screening program started, there was only 5 centers, and today we have 15 centers. The Ministry of Health can do those intervention and again and follow up post the intervention and rehabilitation. So again, at the end of the month, we have the same reports only for the screening, and we look at the total babies in each hospital, how many of them screened and how many of them completed and how many of them pass or refer to the second phase. So this is for the hearing screen. We have almost like 2 months back, 72 of them completed, and 99 of them passed the test, and around 1% or 0.1% referred to the other centers. So this is the report of 2021. We have 81 completed the tests, 19 unfortunate not completed because one cause of others, And again, like cardiac, we have some different variation from other centers. You can see like from Grayat, we have the higher number for the last year, who's referring cases to the second phase for diagnostic, then Asir, and Jizan, then Najran, and then the others. So this is what we have over last 1 year, 175,000 plus babies screened, and we get to referred like 3,000 plus babies to the next phase and normal APR, not echo. So we have normal 977, and we have abnormal ABR who refer to the cochlear team 2,275, and we end by having 480 require cochlear implementation, as we saw in the previous slide. So before the last slide, I would thank again my colleagues who's work with us hardly to implement this program and to maintain the program, not to maintain the test, as Dr. Zuhair said. So again, thanks to our colleagues in the ministry, thanks to the nurses who's delivering the first step of the program, and big thanks to our cochlear team who's ending or following up those program to make everything integrated and happen. Thanks for the family and Lean IT, and thank you very much for this opportunity. Thank you very much.
شكرا دكتور علي. Thank you, Dr. Zuhair. And can we join us here for questions and discussion time? Yeah, please go ahead.
Thank you very much for this interesting lecture. لكن عندي I have a question actually. Still in Saudi Arabia, there is a hospital not doing the hearing assessment, and they are not doing the critical congenital heart disease screening. So what was done with these hospitals, especially من القطاعات الأخرى يمكن غير قطاعات وزارة الصحة؟
نعم، من أول خلي علي يجاوب لأنه هذا في صلب الموضوع وبعدين نعطيك الشانس.
Thank you very much. I will get the answer with help of Dr. Fahad and others. So this work was the one done in the Ministry of Health. Although the message was delivered from the higher authority people in the kingdom and also through the Saudi Council. I believe why the other area, there is still some belief and debate in some of the screening, and some centers or some sectors, as I'm aware, they have their own pathway inside either the hospital or directorate or ministry to deliver such programs in different or similar way. So now and again, we go back to the Saudi Council, Majlis al-Sahhi Saudi, to try to implement, as you mentioned again, the whole program to the whole sectors, including the private sectors. There's a huge work now led by the minister to make this happen. It's not an easy, but I believe soon we will see different shape of this program in the whole kingdom.
If I want to add, maybe a monitoring system is soon coming from, again, it is a higher order for Lean to start monitoring the private hospitals doing this screening, and I think it is soon coming for also monitoring governmental non-MOH hospitals soon.
Other questions? Yes, Dr. Saif. وعليكم السلام ورحمة الله وبركاته.
Assalamu alaikum wa rahmatullah. Saif from National Guard Hospital. Thank you, Ali. Thank you, Dr. Zuhair, for the very nice and actually inspiring work to help our tiny babies. Screening, it's not an easy job. We have faced this challenges in National Guard, even one sector, and we consider one of the richest sector in the kingdom. We have reached challenges from point of consumables, availability of machines, availability of someone trained to do the test, someone follow up with the test, because you do the test and then the result comes out abnormal. how long it's take to get the parents or the patient to be treated in a timely manner before he comes to ER dead or la samahallah, he's in bad shape. So what you have done for these challenges in Ministry of Health or King Faisal in this regard for both metabolic diseases or critical congenital cardiac disease?
نبدأ معاك يا زهير وبعدين ننتقل للدكتور علي. لا في اليمين.
Thank you, Dr. Saif. I can talk about our hospital and what we used to do now. If there is an abnormal test, they send the email to the in-call, all group of in-call, consultant and fellows and the chairman of the department and coordinator. So 4 people involved with this. And immediately the coordinator contacted the family either to confirm the test or call them back for treatment if it is, we know this is clear. So actually within 5 days, we can solve these problems. We never, most of problem actually happen with biotinidase deficiency. If you know, biotinidase is fragile enzyme. And, most of the time it gives false positive for 2 reasons. Because if with our temperature, especially in the summer, the level will be abnormal in the card. And the other thing also, the carrier. We discovered that the carrier who carried the gene, they are not, it is homozygous disease, but if he is a carrier, it gives also false positive. So we give the benefit of doubts, actually. We treat the patient as disease till we solve the problem. For example, if he think it is abnormal biotinidase, we start biotin till we make sure that is it really biotinidase deficiency or not, even if we go to molecular testing at the end. I mean, we repeat the test, but if it still give false positive, we have to.
Okay. I think we have some comment here from.
Yeah, I will take the opportunity just to ask Dr. Zuhair, the challenge of delaying the result. Now, are we with the development of technology and the fast developing, are we about to have a machine, bedside machine, point of care testing of metabolic screening, or you don't think this is in the coming futures or coming era?
I think it can be done like this, but like this program is a national program. No country in the world they do this, because there is like quality assurance. There are governmental support for the test, for supplementation, the diet, and so on. So I don't think it will be done at the test, but I think it can be done better in our country. Now.
You mean to improve on what is going on?
يعني مثلا Ministry of Health كان عندهم 3 مختبرات، واحد في الغربية، واحد في الوسطى، وواحد في الشرقية. الآن كلهم خلوها في الوسطى. I don't know why. This is make a problem because you have to send the cards الآن. There was a delay, a lot of problem happened for this. So this is one element to solve this problem. You can solve it, but by establish مثلا reactivate the labs again. I don't know في many things in your hand to do it and you follow the standard of other countries who North America, they are doing this in excellent way they can cover.
If you allow for me to answer the second part of Dr. Saif. So I think Dr. Saif and my colleagues, it's what you saw today is just the outcome of the program. So we have a huge work. It's a lot of details, and as you mentioned, a lot of challenges and a lot of work. So we have almost like 500 to 8, probably 100 team members in the locations. So we assigned for the program a physician and nurse as a leader in every hospital. And those we link it like to the NICU as a unit inside the NICU. and they extend according to their hospital. Some hospital, they have huge number of deliveries. So you will find some hospital have like 10 members in this unit doing those huge work. So we have a protocolized system when you have a failure, either technical, how to solve it, or when you have a failure or referral from the screening, what to do to the next system. And on the other part, probably Dr. Fahad said about it, monitoring and linking everyone to other, we start networking. So we have very active communication between all the members. Daily we have like either through WhatsApp, through emails, we have frequent meetings. We share those reports monthly, and we have meeting with the areas who's having not reaching their limitation, how they. So even in our networking, we have the support, technical support from the companies, as you mentioned, the consumables sometime and troubleshooting from the machine is one of the challenges. They are with us 24 hours in the morning, in the night. If we have shortage in some area, we fix it quickly, and even we have time frame how to fix those things. And again, we are improving those programs. We start networking with the other stakeholders, cardiologists, audiologists, ENT. And once we have like any problem in some area or some cluster, we start to focus in and we help it. So a lot of technical and a lot of training, continuous training. We other challenges, we have some time turnover in the members who's delivering the test. As you know, the nurses easily they can just exit from the program, and we found new one. So even we develop new orientation booklet for the one if they want to join, how they can train when they will receive the privilege in this program. So a lot of works maintain us in an area which we can deliver it safely. Still, we have goal and aims at least to cross 90% of the completeness of this screening and following this program in the regions.
شكرا يا دكتور علي. Excellent. الله يعطيكم العافية. It's really a huge work. You are talking about a continent. Saudi Arabia is يعني, you are talking how many centers we have deliveries in the country. We have hundreds of. Yeah.
We reached last year. We reached 625,000 delivery in the kingdom.
Not only the number, but also the sites that there is deliveries and you need to screen. It's not easy. Dr. Rahbin, تفضل.
أكثر شيء يعني it make me worrying about the program. يعني program started in 2004, 5, يعني almost 17 years. As he said, the delivery per year is almost 600,000 من the government وال private almost. لو قلنا المواليد, one affected among 1,000. يعني واحد مولود من 1000 مولود مصاب. عندك 600,000 مولود. كم يطلع المصابين؟ 600 طرفين في وسطين اللي حقت الثانوي.
Make it short الكومنت حقتك يا زهير.
طيب لحظة.
تفضل عشان الوقت.
طيب نيجي ل 17 سنة لما تشوف إحصائيات خصوصا من وزارة الصحة يقول لك we screened, أنا شفت never exceed 2 مليون. مع أن المواليد 600,000 في السنة, يعني 17 سنة المفروض 800 مليون at least new. أنا ماني عارف يعني we are screening almost 25% من طبعا كل ما أسأل أحد في وزارة الصحة nobody give me answer at least يعني المصابين I ask several يعني what happened to them, what happened to these people still alive, babies, who is taking care. ما عندي answer حقيقة, ما في answer يعني يعني ما أنا ما واحد بواحد بس يقول لي مثلا
that's Zuhair can bring us to what is the role of screening and data collection, which I am sure the colleague they are working on it definitely. So we can take another 2 quick questions, short please. Ya Abbas.
Assalamu alaikum. I am really afraid that every hospital will go and do his metabolic screen by itself. Let me tell you the experience I had in the private sector. In 2011, we started the program by signing a contract with King Salman Center and they were sending the samples to King Faisal. And then suddenly they quit for some reason, I think just before Corona. And then we had to send the samples through a third party. It was taken outside to, I think, to Dubai and then to Jordan. And then our hospital started to do the testing by themselves. And we have problems. I think the results are not really accurate. When we were doing it at King Faisal, even when they the MOH started doing it, some of my colleagues, metabolic screen consultants, they used to send me the samples to send it to King Faisal to confirm the diagnosis because they were really not trusting their results. So I think having one center like before, like what we was doing.
You mean reliable testing center?
Yeah,
reliable ones.
So run the program, the whole program. It was really beautiful.
I think this is what they are working in.
I think I'll answer this, Dr. Abbas. So today, everything will go to the Saudi Council, Majlis al-Sahih al-Saudi. Any national project or programs, soon it will move to the Saudi Council just to make it, as you mentioned, unified. One pathway can fit all the people. If anyone interested from private or from other sectors, even MOH, to implement anything national, it should go through one area and one umbrella. Soon it will be implemented. And hopefully that will protect what you mentioned.
Excellent. Another quick, please, Dr. Saad.
I would like to thank our colleague regarding this session. I would like to stress on a point mentioned by Dr. Zuhair Rahbini. The ideal thing is national program. But for example, I have a disease which is more common in certain area of Saudi Arabia. And at the present time, I cannot do national program wise. We can start by region. For example, screening for G6PD. I know the ideal thing is a national screening, but at this point, we are not established it national-wise. But we know certain areas in Saudi Arabia is more common than others. So why we don't start by this? I think I stress on this point.
If you can allow me, Prof, I can answer. So another screening program coming, at least in the Ministry of Health. So for the G6PD, we did, as you mentioned, proof of concept. We did it in 3 or 4 places, and we proved that we need it. And it's the final steps just to make it happen soon, inshallah. And another 1 or 2, probably we'll talk about it later. But a lot of screening, it will be implemented together to the newborn, and it will be through the Saudi Council.
Excellent. خلاص, I think that's enough for this session. Jubara, بس يلا quick one, please, because we want to close.
Thank you very much. We know the newborn screen, congenital heart disease screen. It's really very impressive work. But one of the common problems we see it in the kingdom is the jaundice, especially with the early discharge. And I was really surprised this year. I heard a lot of cases. They referred, with the serum bilirubin of 700 and 800. So why we did not start jaundice screening as a national program? Those a normal baby, not like a metabolic or complex congenital heart disease, a normal babies who will be discharged at 6 hour or 24 hour and will be jaundice and no follow up to that, no screening to them. Can we implement or start a project about jaundice screening at the level of the,
So as I mentioned to Prof. Saidi, we just finished the protocol, everything. I'm optimistic that January 2023, it will be implemented. And inshallah, in the next annual meeting, we will talk about it.
Excellent.
Thank you.
Excellent. Thank you, Ali. Thank you, the speakers, Dr. Rahbini, Dr. Mudir. Thank you, my colleague, Dr. Fadil Agil. Thank you for the audience being patient and staying with us. Just a few quick announcements before you leave the hall. The prayer at lunchtime will end at 1:30. I think you can hear me now. Okay. Then the lunch and prayer time will end at 1:30. You come back to this room. There is two important workshop going on in the afternoon. We have BOCAS, point of care ultrasound, led by our colleague, Dr. Yasser and Sayed, and then it will be in classroom number 3. And we have skincare of premature, including the extravasation treatment. It will run in classroom number 1. This workshop, we will give the people CMA hours accreditation based on the attendance. Because yesterday, what we noticed, there is 37 registered for breastfeeding. And at the end, only 4 show up. So the others, we will not give them any CMA. So please tell them that, CMA will not be given unless you attend the activity. Number 1. Number 2, I encourage really that people to benefit from this type of occasion to have more knowledge in this matter. The main lecture hall will start also 1:30. We have 2 more sessions this afternoon. One of them, the last one, after Asr prayer, will be international speakers. We'll have Joseph and you will talk about necrotizing enterocolitis update. And we have Basco Bees from McMaster, Hamilton, Ontario, Canada. He will talk to you about RSV. And enjoy your lunch, and we'll see you, inshallah, at 1:30. عافاك الله يا ابو خالد طول لي عمرك.
نحن بأنتن بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو تحسين دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشائم بل نعمل إنك في الأمرين مخير فاسأل نفسك واطرح سين من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله
الله يسلمك. هلا عبد الرحمن، كيف الحال؟
هذا اسود.
شكله يطلع المفتاح السيارة. خلنا نطلع المفتاح.
من أجل الآتي اليوم للكل يد في التغيير.
هذا في بوينتر على فكرة.
والله بس ما اشتغل معي
ضعيف. لا ضعيف.
ما اشتغل معي.
كلنا بكبير صغير. مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر
USB. ايوه.
أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سين ما دورك في التحسين ما دورك في التحسين ما نفعله ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعا فتغير ما نفعله أننا ندعو لغد أفضل.
Inshallah, Ada. Inshallah, but how? Who? Just a little no.
بسم الله الرحمن الرحيم والصلاة والسلام على أفضل المرسلين نبينا محمد وآله وصحبه الكرام. Welcome you all to this session. I think this is the most important session of the symposium, not because I am the chairman and my friend is the co-chairman, because it's prevention better than a cure. So our speakers, all of them, they're going to talk about prevention. And the first one will be Dr. Samir Al-Abdi. It gives me a great pleasure to introduce Dr. Samir Al-Abdi to you because we had the pleasure of working together during his early years in pediatrics. And I was more delighted that he chose neonatology as a subspecialty. He also developed some interest in intraventricular hemorrhage. And he actually developed a score, it's called Al-Abdi score, for the severity of intraventricular hemorrhage. And he had a lot of publication. And today he's going to talk about how we can prevent intraventricular hemorrhage. Dr. Samir.
Okay, now. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the organizing committee and settling committee to have me here. And thank you, Dr. Majid, for this nice introduction. My talk today about prevention of intraventricular hemorrhage IVH in a preterm infant. I have nothing to disclose related to this presentation. The content will be epidemiology, timing and grading, risk factors, and I'm going to concentrate on coagulopathy and head position. And if we have time, I'm going to show you the 7 predictive scores that are available in literature. As you know, the germinal, the subependymal germinal matrix, this is the origin of IVH. And because it's very delicate, they start the bleeding there. And why the gestational age, why the older gestational age has less IVH, because this area is regressed with the time, as the slide shows. The risk of IVH worldwide between 20 to 25 in babies less than 1.500 grams, 1.5 kilograms. All of us, we know that IVH occurs in first 3 days to 5 days. But if you focus closely on that, on this time interval, it actually 50% of IVH will occur between 6 to 12 hours of age. We did meta-analysis and confirm this is confirm our perception that 50 to 48% of the IVH within 6 hours of life. The good thing, 3 studies after our publication confirm that. One of them is the PNAT trial, the preterm erythromycin neuroprotection study. They screened the babies before the enrollment in their study, and 56 of their IVH occur within 12 hours of life. So we have a good evidence that at least half of the IVH in the first 6 to 12 hours of life. What is the implication of this piece of information or piece of data? First, you need to decide when you need to screen the head ultrasound. We know European countries, they screen head ultrasound first a few hours of life, whereas in North America, they will do it late at 5 to 7 days. Now, even North America people, including Volpe, they start to move toward early screening. And because maybe the European country, the neonatologists themselves, they are doing head ultrasound, as Dr. Majid taught us when we were resident. So maybe they are more keen to do it early. The other important piece of information is appraising clinical research. If we know that most of the IVH or 50% occurs very shortly after birth, then any retrospective study looking about the risk factor of IVH, that will be not accurate because most of the factor will occur after this time period. Now, regarding the prevention, we need to prevent early IVH. So we need to start our prevention very early in the life, maybe even before deliveries. Now, the other thing, it depends on you and situation and the parent. If you are happy to keep the secret of IVH until 7 days of life, I think it's difficult sometimes to accept by parent. You are assuring the parent that everything is okay and baby is doing fine, has been extubated. Then suddenly at 7 days of life, you have something in ultrasound, grade 2 or 3, then the life will be difficult. So sometimes we find it very difficult to wait until 7 days of life, then we tell the parent about IVH. The other important issue in IVH is grading. We know the two famous grading systems, Papil and Volpe, and all of us, we know what's mean of this. But since 2003, people start to heavily criticize this scoring. And one of the problem with this scoring, they are not taking account in the bilaterality. And we know that 25 to 33% of IVH could be bilateral. And also the midline shift and extensive of IVH has been linked to the bad neurological outcome. And this score will not take account. For that reason, all the studies, they will deal with bilateral IVH or severe IVH as unilateral one. So because of this idea, we came with the idea about IVH scoring, which is very simply, we try to give any IVH event a different discriminated score. And we did that by simple mathematical things. We squared the score of Papil. For example, if the patient has IVH grade 2, we score that grade 2, it will be 4. And we added the score on the other side. And if there is extensive, we add 5 extra point. The 5, we choose it arbitrarily. You might tune that score if you would like, because another new BAT study, they use a different category of the severe IVH. Our score will extend from 0, what mean normal, to 35, the most extensive one. Luckily, this score was externally validated in Calgary. They compare between Papil and our score. The area under the curve almost the same. It really, the B value is 0.04, but is not accounting for that significant. But the good thing, we found that score 5, which mean baby has a baby with one side grade 2, another side grade 1, and 6 with what's mean baby with bilateral grade 2, the specificity of a neurological outcome is much, much better than Papil. Now, what is the importance of knowing the severity score? When you targeting to prevent IVH, you need to decrease the rate of IVH. You need also to decrease the severity. The classical teaching for pathogenesis is breakdown into 3 categories: intravascular, vascular, and extravascular. And each category has its own risk factors. If I want to enumerate risk factors, it's easy to enumerate them. Gestational age, birth weight, we know that if the baby born less than 28 weeks, the baby will be at risk more than 28 weeks. Birth weight, the same thing. Male, antenatal steroid. So there is a lot of factors we can enumerate, but the story is not that simple. The story is like this. If you, Dr. Al-Haddad recently published a paper, and he tried to link the risk factor together by using direct cyclic graph, and they built 370 relationships. So if you want to prevent IVH, it is really like this map. It's very difficult, and the factors interact with each others. Here also, they try to classify the factors according to the evidence-based, and as you see, the color all over the places. So what can we do and how can we prevent IVH? All of us, we know antenatal steroid. This is the most important factors. And we know it's recommended between 24 to 33 plus 6 days. And not considered or not recommended below that age, and maybe recommended after 34 weeks, provided the risk of delivery will be within 7 days. But recently, we have 2 studies that make our life is not easy as we thought. Before, we need only to think what the gestation age we need to give steroid. But these 2 studies showed that if we give steroid to premature babies, that is indicated to receive steroid, but the baby likely will not be delivered prematurely and deliver at term, their neurological outcome was not good as full-term baby that received no steroid. So these 2 studies raised a red flag that we need to be sure that delivery is imminent or baby will be delivered. If not, then we might jeopardize their career. The other thing, and I'm sure Dr. Muhammad Al-Hindi will explain more about this, delayed cord clamping. Delayed cord clamping in meta-analysis, we have evidence regarding IVH that can prevent IVH, but not severe IVH, only all the grade. Now, a little bit from statistics, we know before we look to the p-value only, and if it's significant, we are happy. We look to the confidence interval. If it is narrow and doesn't cross 1, we are happy. Now, the grade now, to move from that classical teaching, then they want now to present the data with the size of effect and the accuracy, and not to put much weight on the statistical significance. So if I use this, then I would say delayed cord clamping may result in little to no difference in severe IVH. And I will say delayed cord clamping reduce any grade of IVH slightly. Now, the problem with delayed cord clamp is not only the research or the statistical, the feasibility is very difficult. It's not easy. I don't remember that we have babies less than 27 weeks that we could delay cord clamping to 30 seconds because everybody rush to get the baby stabilized. And in HD data, only 30% of babies less than 28 weeks get the delayed cord clamping. Maybe Dr. Al-Hindi will help us today how to improve this, to do more delayed cord clamping in OR or in the LND. My little bit interest is a fresh fluorescent plasma to prevent FFP. If you want to be peace of mind and just relax, then the systemic review and analysis will say no evidence of beneficial effect of FFP on IVH. But I didn't think so. It is simple as this. Why they came to the conclusion? Because of 3 RCTs that I will show you in a while. And because of the famous statement, developmental homeostasis, or alternatively hemostatic immaturity, people keep away from touching coagulation profile and FFP. So what they mean by developmental hemostasis? They meant that babies, we know them prematurely, we know they have premature coagulation system, and it's okay with them. We should not touch it. I don't agree with this statement because they have immaturity when they are in utero, not after delivery. So maybe we need to tune this statement. We have also 3 non-randomized controlled trial. 2 of them showed there is beneficial if you give FFP, and 1 showed there is no difference. I will go and look a little bit deeply on what they mean by hemostatic maturity. Andrew is the first one who published the reference range for coagulation profile. And if you look here, is only between 30 to 36 weeks. And it's really quite prolonged. If you have this PT and PTT, in baby or 1-month-old boy, I don't think so. Nobody will leave him alone. Another study showed the same thing, that the PT-PTT is very prolonged, but this study looks to smaller babies. So if we applied the Andrew criteria on babies less than 28 weeks, which were not included in the Andrew, then almost 90% of babies will have a coagulopathy. Christensen, strangely, when he published his reference intervals for coagulation, it came very narrow. We don't know why, although it's a large group, although it is a premature baby, but why they have very narrow or very low reading.
And in their study didn't explain the reason. They accept only it is a normal values. A little bit our data also goes with prolonged coagulation profile and confirm that babies less than 28 weeks, their PT and PT is very prolonged. Let's move to one thing higher than PT-PTT. What's the problem of PT and PTT? One of them needs a large volume, 1 to 1.8 ml. It needs lab effort. It need time. Now, in adult medicine, and in pediatrics, especially cardiac transplant and liver transplant, they use something more than PT and PTT. They use something called thromboelastography and thromboelastometry. These two technology, they measure the clotting formation and lysis in the tube, but in the similar way that in the body. What I mean by that, when we do BT and BTT, we're just measuring coagulation. We are not measuring the interaction between coagulation factors and between the other cells, like platelets. So in this technology, they try to do it and measure it in the body. The beauty of this technology, it is a point of care machine. It can be kept in the unit and it takes 15 to 30 minutes and you have the result. What's the downgrade of this? It is just start to emerge in the neonatology. It has been shown a good result in sepsis, a good result in asphyxia, where we can really pick the babies that are at risk of bleeding. They have different modalities and different machine. We hope one time we'll find it more in the neonatology. The other point I want to address, if you are not in favor of doing coagulation profile or not in favor of giving FAB, then we need to explain why babies less than 28 weeks are at risk of bleeding. 19 to 29 babies that deliver prematurely, they have a bleeding, either from lung or from GI or from the brain. So if you think hemostatic system is not in the equation, so why these babies, they have that much of a bleeding? Back to the meta-analysis that keep the people away from FFP and coagulation is very old meta-analysis, and there is no update because there is no randomized control after that. There is only 3 trials that look to the prophylactic FFP and prevention IVH. These 3 trials old, even because before the era of surfactant. The other thing, the gestational age that we are interested nowadays on, less than 28, is only 25% of their population. That means is not well representative. The other thing, the methodology is different. The most important, I think, in my opinion, in that study, they use infusion rapidly. They use 15 ml over 15 minutes, which is per se is a risk factor for IVH. Anyway, if I will look deeply on the first plot, and I use the grade update terminology, I will say the evidence is very uncertain about effect of FB on IVH in infants less than 28 weeks. Just I would touch lightly on what we did in our unit and we published. Because IVH was very high in our unit and we did all what we think is correct and still is high, then we moved to selective SDB. SDB is a FFB, but exposed to detergent to kill all possible pathogens. So we start to screen the babies, and according to the embryo criteria, if BTT and BT is prolonged, we give FFB 15 ml over 20 hours. And likely we could decrease the IVH, but this is a retrospective study and comparing between 2 historical periods. And also we were likely to decrease not only the IVH, we decrease also the severity of IVH. I will move to second object, which is head position. Head position, we remember in pediatric, in adult, when we have patient with increase in cranial pressure because of cerebral edema, we keep the head up and raise in the bed and midline. This observation was emerged and reached the ICU. And they found that the unit, they have less IVH than the others. They use this practice. They keep the headline, midline, and lift it between 10 to 30 degrees. But unfortunately, there is no evidence to support this idea. We tried to do a randomized trial, but we failed twice because of recruitment issues. The meta-analysis of all the trials published, 2 from Saudi Arabia and 1 from, I think, from States, sorry, they failed to show any evidence. But the meta-analysis it was surprisingly, when you look to the IVH, there was no much association with head position. The head position cannot prevent IVH. But it showed us something that we were not aware when we do our analysis, which is the mortality. So head position, it may reduce the mortality. Maybe because reduce the infection, because maybe reduce the other thing, but it has been shown it might reduce the mortality. That's why after this meta-analysis, people start to do more head position in midline and raising them from 10 to 30 degrees. Let's move to something is hot debate between neonatologists, which is indomethacin ibuprofen prophylaxis. I remember when the TIB study published that time, we were discussing, we were resident, and the consultant at that time were saying, shall we stop prophylaxis? And I remember Dr. Majid said that time, no, I couldn't do that because maybe everybody will read the paper differently. And he was correct. Until now, every neonatologist will read the TIB study and interpret the TIB study differently. So what the meta-analysis showed, I'm going to concentrate on ibuprofen because indomethacin nowadays is not that available in our country. If you use different technique, different statistical model, you will get different result. For example, also when you use fixed effect meta-analysis, they conclude there is a marginally statistical significant reduction of the IVH. Now, the other group, when they use network meta-analysis, if they use the statistical significant, they will end up with saying maybe it will reduce. But when they use, when they use the statistical, it will not reduce. When they use the grid approach, they end up saying probably reduce severe IVH slightly. The importance of this meta-analysis is, I don't have the pointer, is the one, I want to show you. Oh, sorry. What the most important in meta-analysis is there is no statistical significant reduction in severe IVH in babies less than 28 weeks, which is what we hope. So if you are hoping to reduce IVH in 28 weeks and use ibuprofen, you might not get it. We hope paracetamol will come and solve this problem. Now, my last part is prediction of severe IVH. As I presented now, is we don't have much evidence about head position. We don't have much evidence about FFB and also in ibuprofen. But still, there is hope. So the people, what they try to do, try to select the most sick babies that they are at the highest risk of IVH. So they try to build a model. There is 7 models presented in the literature. The model shared one thing. All of them built based on logistic regression. And if it was built on logistic regression analysis, then automatically it will inherit the limitation of logistic regression. And one of the limitation is collinearity. And what I mean by this, they used 2 variables that very strongly related to each other. They use gestational age and birth weight. If they use two variables that very strong related, then maybe a good variable was kicked out from the regression model, and we should not kick it out. So there is one model here published from Vermont, Oxford, which is included the variable that you can see, but was not externally validated until Barbara Smith did post hoc analysis of her TB trial, hoping that this score will work better. So what they did, they applied their score in their cohort study, and they want to see if the babies at a group 4, that means at highest risk of IVH, if we use indomethacin, their neurological outcome will be better. Unfortunately, the result showed there is no difference. So even if you use this score, you will not get what you hope. But they compare one thing. If you use this score, you are going to harm less babies, and you are going to increase your number to treat. As you can see here, if you use only for the severe score, then you will treat only 11. Okay. The other score I want to show you is from South American. The same problem inherited like font. They have same variable that with collinearity, but the interpretation here is based on wagon nomogram. The other score I want to discuss with you today is the one from Turkish, since I don't have time. The beauty of Turkish is they include blood diathesis. Before I move to this slide, I want to alert you that All this score is retrospective. That's mean a lot of variable, we don't have it. So what can we do? The unit now start to do the bundle, IVH prevention bundle. And they include this 9 element in this bundle. They include thermoregulation, that you mean to keep the patient between 36.5 to 37.5, minimal handling. They need first golden hour. You need to finish, and you finish all your procedure within an hour. Avoid lumbar puncture, standardization of your care, respiratory as well as inotrope, and reduce the inotrope use. Noise and light, decrease it as much as you can, and in ICU characteristic. One of the good things, Dr. Saif is safe. He published a study that showed that if you put the plan for the ICU, and if you the neonatologists do 24-hour on call, they were able to decrease the IVH significantly. Now, one of the things that was not mentioned clearly in most of the bundles is breastfeeding, and I think breast milk should be addressed very well. We know now there is a data emerging that even buccal and oral care with colostrum before feed increase prevent the neurodevelopmental delay, and even giving breast milk through the nose prevent the cerebral palsy in premature baby. So what is the key message I will deliver today? We need to have IVH prevention bundle that address the 9 points that I mentioned, and put the policy for urinate. You need to consider the timing and IVH score to prevent the severe score. You need to consider the midline head position, although there is no evidence, but at least there is no harm. You need also to use, maybe you need to use IVH predictive model. If you are more active, you might do a study and validate that model. You need to study FFB, and I think we should need to consider that. Before I present my last slide, I want to show you this slide, which I like to show you. This is Dr. Majid. He's my great teacher that I learned a lot from him, and I would like to thank him. Next to him with Thob is Dr. Al-Kharfi, Allah yahfadha. I learned a lot from him too. Dr. Fawz Al-Khashlan and Dr. Tierney. The one with the blue skirt, Dr. Zakaria, unfortunately, he couldn't attend the conference because he had a car accident 1 month ago, but he's doing great recovery. Thank you so much, and thank you for our great team.
Thank you for showing me so young. Thank you for this very comprehensive review, and hopefully that the bundle get spread in all units, and so that the IVH rate will become less.
Okay, thank you very much, Dr. Abdi. It's my pleasure to introduce our Prof. Sajjad Al-Rahman, consultant neonatologist at Al Habib in Al Qasim area at the moment. He's going to talk to us about neuroprotection bundle for the hypoxic ischemic encephalopathies. Please, Dr. Sajjad, the floor is yours.
Can you put the laptop on? Oh, sorry. Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much, Chairman, for giving me the opportunity to give an update about the neuroprotective bundles in hypoxic ischemic encephalopathy. So what we're going to review in another 20-25 minutes is what is already established in the management of hypoxic ischemic encephalopathy, and what are the recent advances which we are going to follow probably the next few years, and what neuroprotective bundles we have proposed so far, and where is the future research on the subject. So what is already established? I think there is only one thing which is established, and that is the therapeutic hypothermia. And we have gone through a long period, so more than 25 years of research on therapeutic hypothermia, starting in mid-1990s from animal studies, followed by single human studies, followed by MRCTs, and then followed by the meta-analysis. This is the last meta-analysis on this subject, which was published in 2013 by Cochrane. And since then, there have been no other meta-analysis. The subject was closed because by that time, therapeutic hypothermia became a standard of care in all NICUs worldwide. Now, this is what the last meta-analysis said, that whether you cool the baby by selective head cooling or by whole body cooling, it reduces death and disability. And similarly is for the death alone. So mortality is reduced and morbidity is reduced. So the conclusion of all these studies and the last meta-analysis was that therapeutic hypothermia is beneficial in term and late preterm newborns who have got hypoxic ischemic encephalopathy. And then it went all throughout the world and we adopted it as a standard thing. The established protocol which came out of all these studies is universally the same. We cool only term and near-term babies. Near-term is more than 35 weeks. And only those who have moderate to severe hypoxic ischemic encephalopathy. There is no consensus on mild encephalopathy. And we all follow the same criteria. Criteria A, criteria at birth, and criteria B, which is the bedside examination in the NICU, one from criteria A, one from criteria B, and both are essential. The criteria C, use of cerebral function monitor, is optional. And this is the protocol of cooling, which all have been following. Cool the baby to between 33 and 34 degrees centigrade, cool them for 72 hours from the time of starting the cooling. And then we rewarm them slowly over a period of 8 hours with the rate of rise of temperature not more than 0.5 degrees centigrade. And based on the physiology that all these 72 hours or 80 hours of period covers the primary and secondary energy failure, which is about the first 3 days of life. And we're going to go into a bit of detail later on. So with all this research and practice, we have learned 2 things about the hypoxic ischemic encephalopathy. So the first thing which became established is that it is possible to reduce disability after hypoxic ischemic encephalopathy, both mortality and morbidity. But we also learned that though we are using therapeutic hypothermia, it is not a 100% prescription of a good outcome. It reduces the mortality and morbidity, and the efficacy is only 45 to 50% to maximum. So it is not the whole answer, it is a partial answer. So then what next we are going to do? And that is which has going on in the research for almost last 10 years. So therefore, we are now trying to find out some concurrent therapies which can help and support therapeutic hypothermia in increasing the number of survivals without any morbidity. And whether they can be used with therapeutic hypothermia or without therapeutic hypothermia is also a question. And then we are now assembling interventions, which we call the neurodevelopmental bundle, neuroprotective bundles. And together, all these may help in improving the mortality and morbidity because of hypoxic ischemic encephalopathy. So what are the recent findings? With all this research, we have also got a newer insight into the pathophysiology of hypoxic ischemic encephalopathy. The 2 important aspects which we know now is, the first thing is that the brain injury which happens after hypoxic ischemic insult, it is a dynamic process. It is a process which continues for a long period of time. We did not have this perception in the beginning. We thought it was only at birth, whatever neurons were damaged, and then later on, nothing could be done. But now with the more insight into physiology, we know that this is a dynamic process, and which evolves and continues not only for hours and days, as we initially thought that probably 72 hours was enough. Now we know, no, this process continues not only for days, it continues for weeks and months and probably for years. So we have got a lot of time, and now we have been able to define each stage separately. And now we can say there are multiple interventions which we can do at various stages, and we're going to go through it very shortly. The other important thing which we have learned is that it is not only the death of neurons which is important. It is the death of non-neuronal cells which is equally important. And non-neuronal cells form the major mass of the brain. Neurons are a lesser part of the brain, and damage and dysfunction of the non-neuronal cells, whether these are astrocytes or glial cells or oligodendrocytes, contribute significantly towards the adverse outcome in babies who survive from hypoxic ischemic encephalopathy. So previously we thought that there was a primary phase and there was a secondary phase. The primary phase, which in the first 6 hours and which includes the period of transient recovery. And then we thought there was a secondary period of deterioration, which we wanted to cover by therapeutic hypothermia, because we thought this secondary phase was due to release of chemical mediators produced during the cell damage in primary phase. That was correct in itself. But we also said that there's a tertiary phase, and this is a very long phase, and this is a phase of remodeling and recovery. This was from the studies of physiology, which was a very nice presentation. And here we can see that there is a first period from 1 to 6 hours with the latent period, that's the primary energy failure. Then there is a second period, 6 to 72 hours, and then there's a third period from 72 hours for a long period of time, spending up to months and years. And we can see the red line, it indicates the injurious mechanisms, which are very high in the very beginning. But as the time passes on, within 72 hours, they come to the lowest. And then there is a process of inflammation and repair, which starts immediately after the insert, the green line. And as we go on, it increases and more repair is done. But the question is, does the repair go in the right way, or does the repair go in the wrong way? If the repair goes in the right way, will survive without any disability. But if the repair process goes in the wrong way, the child will survive, but without any good neurological outcomes. So primary phase, what happens during primary phase, which is in the first 6 hours of life maximum, this is a phase in which there is primary cell death. That is the hallmark of this phase. The cells which are affected during hypoxia ischemia during this period, they die, and there are various mechanisms involved in this one. And this is what we have shown over here in the between the red and green line. You can see the mechanisms. Then the secondary phase, which lasts between 6 to 72 hours. This is a phase which is different from the first phase. Here, the cell death is what we call the programmed cell death. So the cells die in a very specific way. And the two specific ways are, one is the necrotic cell death, and the second one is the apoptotic cell death. In the upper part, I have shown that how these mitochondrial collapse, cell swelling, seizures, and inflammation lead to the programmed cell death. And then below is the mechanism of these two cell death modalities. And this is shown over here in the second phase. And you can see our hypothermia in the bottom of the slide is shown. Hypothermia covers only up to 72 hours. So it is covering only between the time of the insult and the 72 hours from the time of starting of the hypothermia therapy. So what after that, we yet do not have any answer to that. There are a lot of trials going on, and I'm just going to give you a bit of highlight about that. What else we can do after this period? Now, the third period, which you call the tertiary phase, is the phase of remodeling and recovery. And during this period, there is impaired connectivity. At the time of birth, the newborn brain has as many number of neurons as the adult brain. So there are no neurons formed. And the problem with the neurons is that they are highly differentiated cells. Once the neurons die, they are not replaced by another neuron. They are replaced by connective tissue, which in the brain we call the glial tissue. So this is one important issue. The second thing is, after birth, what happens in the newborn brain is most of it is the development of myelination and the connectivity. And that is what leads to progressive development of the brain and the neurological function. Well, a newborn baby cannot sit, he cannot stand, but at 6 months he starts sitting, at 1 year he starts standing, and then starts walking. This is all a progression of myelination. And myelination always progresses cephalocaudally from head to toe. That's why the babies first start holding head, then they start sitting, then they start standing, then they start walking. If a child does not hold his head, he will never stand and he will never walk. These are very simple principles of neurodevelopmental follow-up. So what happens during this period is that all those non-neuronal cells which are involved in the development of the brain, which are involved in the development of the functions, they do not get up to that level because they have been damaged by hypoxia and ischemia. And this is the most recent diagram published 3 months ago in August 2022, and I like it. It's a very important one. And it gives everything very nicely. It gives the same three phases: primary energy failure with latent phase. I'm talking about the middle of the slide. Then there is a secondary energy failure, and then there is a tertiary failure. The upper part gives us the mechanisms which are involved in the damage of neuronal tissue, both neurons as well as non-neuronal ones, and how it works during each phase. And the lower part gives us the therapies which we can potentially start in each phase. And you know, the blue line is the therapeutic hypothermia. This is the only established thing we have got so far. The second thing is control of seizures, which is very important. If seizures are not controlled, they lead to secondary neuronal damage. And this can happen both during secondary as well as the tertiary phase. Then now we have developed neuroprotective bundles, and there are two types of neuroprotective bundles. The first one, which I have shown you, which works in this first 72 hours, is what we call the acute injury prevention bundle. And I'm just going to tell you what actually it includes. And the second bundle, which includes, is called the neuroplasticity bundle. It's in the tertiary phase. It's the other end of the same bundle line, the red line. So we have got two types of bundles which can possibly help us in protecting the neurons. And then the people are adding more neuropharmacologic agents to, sorry. And some people are trying to use the melatonin in the first primary and secondary phase, erythropoietin in various doses, and of course, the new thing coming is the stem cell therapy. So the neuroprotective bundles, which we have so far tried to put it together and see how they work. One is the acute brain injury prevention bundle, which, as I have said, is in the primary and secondary phase. And the second is the neuroplasticity bundle, which is in the tertiary phase. So acute brain injury prevention bundle, it includes early identification and referral of the patient who has suffered from hypoxic ischemic encephalopathy. Most of the problems happens when there is delayed referral and we cannot cool the patient. So that's one important thing. Second is preventing fluctuations in physiologic parameters. When the baby is entered, we should look for all these things, maintain normal carbon dioxide level, maintain normal glucose, blood pressure, and temperature levels. Minimal handling is very important. Pain management is very important. The diagnosis and seizure and control and management of seizure is very important. Seizures, as I said, can lead to secondary neuronal damage because of the episodes of hypoxia which happen with it. Then early nutrition, fluid, and electrolyte balance are very important. And within this period, primary and secondary, for 72 hours, we have got some protective interventions. The well-known, as I said, is therapeutic hypothermia, but the others which are being worked on is erythropoietin and melatonin. And there are a number of other candidate pharmacologic agents which can potentially help in protecting the neurons or the neuronal tissue in this one. Could be magnesium sulfate, xenon, allopurinol. And there is a long list of these agents, and the agents are increasing in number every day. But there is no yet proven study which can say that they are definitely helping. The neuroplasticity bundle, which we start off with these first 72 hours in the tertiary phase. These bundles target potential brain injury and growth well beyond the first few days of birth and after discharge at home. So the management is actually a very long-term management. We need to follow them and make sure that all these things happen. And the elements which have been put into the neuroplasticity bundle include the empowering families through family integrated care. So the parents need to understand that what exactly has gone wrong with their child and what exactly they should be doing, and they should be prepared for and willing to do that. Then optimizing nutrition, developmental care, skin to. Sorry, something gone wrong. Sorry. So skin to skin care and the massage therapy, which obviously is the function of the physiotherapist. Positive stimulation by various kinds of sounds is being used, and encouraging positive social interaction, which can lead to better neurodevelopmental outcomes. Though we have put all these things in one bundle, and there are other potential pharmacologic agents like long-term use of erythropoietin, not only in the first 3 days, but for a few weeks and probably for a few months in a higher dose as a neuroprotective agent. And the last one, which is coming up with a lot of publications, but still very uncontrolled, is the stem cell therapy. Stem cell therapy is basically a replacement therapy. It brings new cells into the neurons, which potentially have the ability to become converted into neurons or other neurological cells and help replace those neurons which might have died. But again, there is no evidence and no meta-analysis to show that these are really effective. So this, yeah, just one more.
5 minutes, sir.
1 minute, just 3-4 slides down. So neuroplasticity bundle. So there is limited evidence that neuroplasticity interventions can improve long-term cognitive and motor outcomes. So we need a lot of trials and research into this. It's open for work. So again, I'm showing the same slide. It's one of the most important slides, and I like it very much because it bundles up every single thing which I have set into one very good diagram. It's easy to understand for those who want to do the clinical practice as well as those who want to do research in this field. So the future research, that's the last thing I wanted to mention. So we need to understand the safety, efficacy, and long-term outcomes of neuroprotective therapies, whether they are used with therapeutic hypothermia or without therapeutic hypothermia. So we need to understand what is their role. And this is what is going on. And in next few years, we might be able to have more evidence and more meta-analysis, and we come to some kind of combined therapies. Then the bundles which we are proposing for the protection of neurons and neuronal tissues, what is the outcome of that? Do they really help? Do they really reduce the neurodisability? We yet don't know. So a lot of trials are needed over there as well. And stem cell therapy, and what is the outcome of stem cell therapy? This is a practice which is going uncontrolled in many parts of the world, including China and India and the Far East. And a lot of people are getting the ideas from the internet and they're going. But nobody knows what actually is being done. There's no controlled trial and there's no regulation of this stem cell therapy. So it's a random thing going on, but hopefully we'll one day have some proper trials and find the outcomes. So the future is we have to put the things together. A lot of therapies together, maybe therapeutic hypothermia, some pharmacologic agents, and some non-pharmacologic interventions, all put together to reduce the mortality and morbidity from hypoxic ischemic encephalopathy. That's what I call the cocktail therapy. Thank you very much. Appreciate it.
Thank you very much for your time. Yeah, thanks.
Our next speaker is Dr. Saif. We're going to tackle another important problem in the NICU, which is chronic lung disease. And Dr. Saif is a consultant neonatologist and a chairman of neonatal intensive care unit. He has contributed a lot to the teaching and dissemination of neonatal care in the kingdom over the years. So I consider him one of the pioneers and senior neonatologists in the kingdom. Today is going to talk about how we can prevent bronchopulmonary dysplasia. Dr. Saif.
Assalamu alaikum.
Assalamu alaikum wa rahmatullah. Good afternoon, ladies and gentlemen. Can I see the slide, please? Thank you. I'd like to thank the scientific committee for choosing me to be one of the speakers actually in this annual Saudi Neonatal Society conference. It's my pleasure to be here with you. I was asked to talk to you about prevention of bronchopulmonary dysplasia. I wish I was here yesterday. I was busy trying to finalize the plan for Women's Hospital, which is going to open maybe next month. It's going to be a big unit, 96-bed unit, fourth tower of Children's Hospital. So today I will talk about mainly about prevention. I will have some introduction. And we'll start with the sad story. In 1963, the President of the United States had a second son, was delivered by cesarean section at 35 weeks. And unfortunately, he died after 39 hours of suffering from severe HMD. This actually severe tragedy, it's provide a spotlight on how big deficit in healthcare system at that time. This helped in spur the advancement of medical technology and researches and development of neonatal medicine. So a few years later, in 1967, after invention and after babies become on mechanical ventilation and survived, they start to develop bronchopulmonary dysplasia. And the first one described this disease is this gentleman called Northway. Actually, he's not a neonatologist. I was surprised that he's a radiologist. And he was just describing the disease for those babies survived after severe HMD. Those babies actually delivered at the end of saccular stage and the alveolar stage. They born usually after 30 weeks gestation, but with severe HMD. And since that day in 1963, 67 till today, more than 55 years, we're still talking about BBD. Why? Because it's very common neonatal problem for premature infants, 30 to 60% of extreme low birth weight infants. It's very difficult to prevent. It actually have a risk of mortality and high risk of morbidities, including neurodevelopmental outcome. It's actually have a length of stay in the hospital, increase separation of the parents from the babies, and also increase the cost. So his description was only describing the lungs, that it's hyperinflated, atelectatic, etc. And this is all before and pre the era of antenatal steroid and before the era of surfactant. Then we did not finish after we start surfactant. We start to give antenatal steroid. We have some new BBD, which babies born at the middle of canalicular stage to the middle of saccular stage between less than 28 weeks. And they have homogeneous lung opacity with simplification of the alveolar with less septation. And the first one described this disease is Alan Job in 1999. And affect babies less than 28 weeks with the era of surfactant and antenatal steroid. This BBD have many definitions, as Dr. New yesterday was saying. If you have a disease with too many definitions, that means it's not a good definition. And the most common definition used in the literature is NIH definition in 2001, when they say if the baby does not need oxygen more than 28 days, that doesn't have BBD. However, if he needs oxygen for more than or equal 28 days and at 36 weeks post-menstrual age in room air, he have mild BBD. If he need oxygen at 36 weeks post-menstrual age, less than 30%, moderate BBD. And then if he need mechanical ventilation or invasive ventilation or non-invasive or more than 30% oxygen at 36 weeks post-menstrual age, means he has a moderate, severe BBD. Then the last definition, which just published by Jennison et al., and he make it very simple, straightforward, on babies less than 32 weeks, any respiratory support at 36 weeks or discharge, irrespective to the prior duration of current level of oxygen. If they are nasal cannula, less than 2 liters, they have grade 1 BBD. If they need nasal cannula more than 2 liters or non-invasive ventilation, grade 2. If they are in invasive ventilation, that means they have grade 3 BBD. Bronchopulmonary dysplasia, it's become more when the baby is smaller. If you look at the black dots in the bars, so more than 50% of babies born at 22 weeks, 23 weeks, they will die before reach 36 weeks post-menstrual age. If you look at the green part of the bars, that means the baby have no BBD. 23, 24 weeker and 22 weeker have, most of them, they have BBD. However, babies 29 week, maybe 20% to 30%, they will have BBD. So how to prevent the disease? We need to start before actually baby delivered. Antenatal, there's antenatal factors. We cannot do nothing for this one. There is genetics makeup, epigenetics, or fetal programming. Babies IUGR, mother have problem with nutrition, placental insufficiency, or maternal illnesses, or too many antenatal steroids can affect the lung growth and alveolization. So IUGR in preterm infants is independently associated with risk of BBD due to decrease of lung growth. Protein deprivation during pregnancy impair alveolization in animal models. High fat diet during pregnancy is also associated with wheezing and asthma in the offspring. In utero smoking, smoke exposure modalities can modify, methylation and specific gene to increase the risk of BBD. So postnatal factors, pre-disease, baby immature lung, then we give oxygen, ventilation, oxidative injury, volutrauma, apnea, hypoxic event, poor nutrition for those babies. It may increase the risk of BBD, so we need to tackle these ones. Or the lung disease itself, because of too many steroids, may be alter the alveolization and those infants. So today I will talk to you about established approach in prevention BBD. I will not talk about pending trials. So I will start with you when the baby born prematurely. So first of all, when the baby in labor and delivery covered with the plastic bag, we start CPAP immediately. It's shown in many meta-analysis, this one published in 2013, that avoiding mechanical ventilation will decrease the composite outcome death or BBD. Another recent trial actually found it's mostly affecting babies less than 28 weeks if you avoid mechanical ventilation. However, does not affect babies more than 28 weeks. However, the total overall, it will decrease the risk of BBD and death if you avoid mechanical ventilation for those tiny babies. Then in 2010, 2015, there was a popular talk about psi or sustained inflation. And it's most commonly in Europe because there is many animal trials showed using psi. That means it's a pressure of 15 to 20 for 10 to 15 seconds. It may improve the lung inflation and decrease the risk of BBD and decrease the risk of intubation. However, this maneuver was questioned because there is many studies, it's not consistent. Many studies, it doesn't have the same protocol. So in JAMA 2019, there is a randomized control trial trying to test this hypothesis. So they tested babies on CPAP to give him 2 puffs of 15 seconds of positive inspiratory pressure, 20, about less than 20 pressure for two puffs, two psi. And what they found actually it was randomized control trial, more than 9 countries. Their target was 600 babies. However, because of increased death during the study, within the first 22 days, they terminated the trial after 426 infants, and they found 16 babies died in the sustained inflation maneuver compared to use standard resuscitation. So it's not recommended to use psi anymore. Then do we use CPAP or use nasal intermittent positive pressure ventilation? Doesn't make a difference in regard to chronic lung disease. So it's the same. However, over the last many years now, everybody trying to avoid mechanical ventilation, using non-invasive ventilation. There is almost 3 very big retrospective cohort trials, and this is one of those, trying to report the change in pattern using respiratory support for preterm infants. So over 7 years period and 56,000 babies in England and Wales, they found the non-invasive ventilation primary support increased both CPAP and high flow nasal cannula. However, the high flow nasal cannula was increased dramatically, almost 7-fold. 14% it was in the past, and then over the last 7 years was 68%. The survival rate increased. However, there's increase in mortality and morbidity, including BBD. And it's astonishing when you see the result in this trial. They found the high flow is less mortality, but if you looked at the BBD, bronchopulmonary dysplasia, in the high flow, 47% versus CPAP group, 17% only. And goes on with the death and BBD, late onset sepsis, neck needs surgery, and BD, all of them, they are very high in high flow compared to CPAP. So we try to avoid using high flow as a primary support for those babies. So another trial in USA, they have 40,000 babies, and they found the use of mechanical ventilation decreased by 15 to 20%, but the BBD rate did not change. Another one in Spain, 18,000 babies, they found decrease of using mechanical ventilation, but again, the BBD rate did not change. So why? Is less really more? Is less using invasive ventilation, it's more beneficial for babies? That does not show this in the literature. So maybe non-invasive support modality carry potential risks such as atelectotrauma, increased intermittent hypoxia, or hypoxemia, longer exposure of supplemental oxygen or support. This may be negate or contradict the benefit of granted by a reduction of mechanical ventilation. Now the babies on CPAP going to NICU, we are giving oxygen. Do we resuscitate this baby using 30% oxygen or 60% oxygen? This is the meta-analysis of 8 randomized control trial. They do not show a difference using 30 versus 60% oxygen. So we use less oxygen to avoid oxidant injury for those babies. Surfactant, then we decided to give surfactant because the baby need high oxygen and severely retracting. So is it better to intubate, give prophylactic surfactant, or manage them on CPAP? Actually, there was many big trials like Cohen support trial and others concluded that better to start with CPAP support in the delivery room if possible, then intubate and administer surfactant only if the infant with severe RDS. So maybe surfactant alone does not prevent or improve the BBD rates. Maybe if we add steroid to the surfactant, it will help. Actually, this recent meta-analysis showed inconsistent results in this regard. Only et al., which published in 2016, showed a significant decrease in the rate of BBD, but still is not clear in the literature. So what we are waiting for now, we are waiting for a plus trial, preventing lung disease using surfactant and steroid. This is a phase 3 and international multi-center prospective blinded randomized trial to be conducted in NICU Australia, New Zealand, Canada, and Singapore. We'll see the results, what we'll come up with. So prophylactic surfactant with Ensure, maybe intubating the baby, giving surfactant, it affects the lung damage even with few puffs. Maybe if we just give the surfactant and remove the tube, or give only CPAP. So several studies did not find benefit of prophylactic surfactant with Ensure over CPAP. And this is what showed in meta-analysis. So the American Academy of Pediatrics European guidelines on surfactant administration advised stabilization of preterm infant on CPAP, and if necessary, the administration of surfactant as early as rescue therapy, preferred within 2 to 3 hours after birth. So maybe when we give the surfactant, we are not inflating and recruiting the lungs. So there is another study published last year called Enric-Sure versus Ensure. Enric-Sure means intubate, recruit the lung by using high frequency, give surfactant, extubate. This is trial unblinded trial compared with surfactant administration after alveoli recruitment using high frequency or Ensure for 30 minutes. It's more than 500 babies between 24 to 28 weeks. did not show a difference in incidence of moderate to severe BBD, but there is a reduction in mechanical ventilation used in the first 72 hours in Rockshore group. So maybe using mechanical ventilation will affect the lung. Maybe if you use it, use minimal invasive surfactant therapy without intubating the baby, it will help those babies by using CPAP and giving the surfactant through LISA or Take Care, mist, or Calmist with combination of LISA and mist. The meta-analysis showed there is a superiority and there is a benefit of using LISA versus mechanical ventilation and decrease the risk of bronchopulmonary dysplasia. But again, there is another randomized controlled trial published in 2001 in JAMA by Dargaville, the Optimist trial, collaborative paired trial investigating minimally invasive surfactant therapy. It's a randomized controlled trial between 25 and 28 weeks gestation. They recruit 485 babies in 33 centers in Europe and giving surfactant through LISA protocol versus CPAP. So they found the BBD rate decreases, BDA and medically treatment decrease risk of intubation within 72 hours and decrease risk of intubation during NICU stay. So now we give the surfactant, the baby extubated, but need caffeine to make him breathe and avoid re-intubation again. We cannot talk about caffeine without talking about CAP trial published by Barbara Schmidt in 2006. She found caffeine significantly reduced the frequency of BBD, 36% versus 46%, earlier successful extubation, earlier discontinuation of BBD, positive pressure ventilation, and earlier wean to room air. So do we give it early or late? Davis in 2010 have a post hoc analysis of CAP trial. So follow up, what he found a great reduction in the duration of respiratory support among infants who received caffeine within the first 3 days. Very interesting finding. They found less death and major disability with early caffeine, less cerebral palsy, less BBD, and less PDA ligation. However, in a big number of babies in United States, multi-center observation cohort study in 366 in ICU in USA, more than 10,000 babies did not show a difference between mortality, BBD, and other comorbidity, giving caffeine in the first day or give it later. So, however, they found that caffeine even is not associated with decreased risk of CPAP failure in the first week of life for very low birth weight infants. More astonishing result by Amaro in 2018, published in Journal of Pediatrics. It's early versus late caffeine, double-blinded RCT trial found no difference in successful extubation between early versus late caffeine, and this trial was terminated due to unexpected trend of mortality in early caffeine. So we have to be careful. We are using now caffeine all the time, even baby ventilated in high frequency, and we're not planning to extubate for another week or two, still the baby taking caffeine. However, the right answer, hopefully, it will come from the RCT was conducted and completed by July 2022, and we are waiting for the result to see if giving caffeine in the first 2 hours is beneficial or not, or safe. Oxygen saturation, again, we have
5 minutes more. 5 minutes remaining.
Okay. Association between high saturation versus low saturation, or using 91 to 95 versus 85 to 89. It's a new PROM trial, more than 5,000 baby, more than 5 trials, did not show a difference in the outcome. So, however, Askin et al. Recommended using saturation of 90 to 95 in those babies, maybe it's safe, and European census recommendation in 90 to 94% will be safe for those babies and improve the outcome. Maybe using high frequency will improve the outcome. However, in the literature, there is a meta-analysis in 2005 with a different outcome. And so it was better in the early 90s, but in the late 90s and early 2000 did not show a difference in the incidence of BBD or death. So their conclusions was optimizing CMV strategy appeared to be as effective as using high frequency in improving pulmonary outcome in preterm infants. Another meta-analysis actually did not, or maybe showed a little bit of small inconsistent reduction in BBD using high frequency as first initiation trial. So maybe using conventional ventilation with volume target will improve the outcome, and this is what showed in more than one meta-analysis by decreasing BBD rate in those infants. So maybe using volume target ventilation will be the way to go on those tiny infants. BDA is maybe a contributing factor for BBD. So if you close it will make a difference. This was tested by Kleiman in 2019, and his study called PDA Tolerate, to leave it alone or respond and treat early trial. Actually did not show any improvement in BBD rate in babies less than 26 weeks. Or more than 26 weeks. However, for baby more than 26 weeks, they found higher rate of death due to late onset sepsis in the treatment group for PDA. Then Kleiman again, he followed up with those babies and tried to find the relationship between PDA and exposure to mechanical ventilation. He found if the babies ventilated more than 10 days, the risk of grade 2 to grade 3 of BBD will be higher, and also the exposure of moderate to severe BBD, as it's longer, it will be higher for BBD rate in those infants. Steroid antenatal does not help in decreasing BBD rate. However, if you give it less than 7 days, it will decrease the rate of BBD, but increase the risk of cerebral palsy. And if you give it more than 7 days, it will decrease the rate of BBD, and does not change or does not affect cerebral palsy. So unless you give it a high dose or longer period of time. Then maybe using hydrocortisone will have less side effects than dexamethasone. Multi-center trial, double-blinded, randomized control trial, found no actually different in the outcome by using hydrocortisone versus placebo. So maybe if we give the steroid by inhalation, which called the study published in 2018 called Neurosis, Neonatal European Study of Inhaled Steroid, it may be improve the outcome. It does decrease the BBD rate, but increase the mortality rate in the intervention group. So it's not recommended to use inhaled steroid for those babies. American Academy of Pediatrics just published in June 2020 a postnatal steroid statement, and summarize it. Use routine use of steroids is not recommended. If you want to use it, you need to speak to the family and take the consent and document in the chart. Low dose of dexamethasone less than 2 milligram and less than 14 days, maybe it's okay, recommended. However, high dose of dexamethasone more than 2 milligram is not recommended. Less than or equal 7 days of age, using hydrocortisone to prevent BBD or death. For babies less than 1 kilogram, mainly if exposed to choriamnitis will be beneficial. Don't use steroid and indomethacin. Vitamin A is being used and shows some benefit, but is a problem with availability, problem with giving babies 3 injections intramuscularly 3 times a week for 4 weeks. Nutrition, we cannot speak about BBD without talking about breast milk. Breast milk decreases the BBD rate, and infection increased the BBD rate. Nosocomial infection decreased from 24% to 15%. It decreases the rate of BBD by 8%. Using of antibiotics more than 4 to 7 days is associated with increased risk of BBD. Additional day of antibiotics in the first 2 weeks of age significantly increase the risk of severe BBD. So we conclude strategy that theoretically effective to prevent BBD have failed to translate into clinical setting. BBD multifactorial is highly unlikely that single therapeutic intervention will have significant effect on outcome. And I like this statement from Greenoff. What did she say in her commentary on hydrocortisone study? We should stop looking at the silver bullet and move toward assessing the combination of intervention. And lastly, Eric Jennison, I like his statement proposing a new paradigm in neonatal respiratory care that target improvement of postnatal lung growth to achieve substantial gain in BBD prevention. By this, I'd like to thank you all. And sorry for the wait.
Thank you very much, Dr. Sheikh, for this comprehensive review with a lot of questions to come up.
It's my pleasure to introduce Dr. Muhammad Al-Hindi. He's consultant neonatologist at King Abdulaziz Medical City in Jeddah. He's a clinical assistant professor of pediatrics, joint appointment in College of Medicine, King Saud University for Health Science. And this is a certified trainer in postgraduate medical education, Department of Pediatrics in the ICU section, King Abdulaziz Medical City in Jeddah. He's going to talk to us about the deferred umbilical cord clamping as quality initiative. Welcome, Dr. Hani.
Okay. Thank you very much. I would like to thank the scientific committee for giving me this opportunity to talk about the topic. بعدما ذهب العظام بالمسائل الكبار وجلوه جالي الدكتور سعد وقال لي هذا حبل علمني متى نربطه. For technical reason, I don't see the title appearing here. However, the cord clamping at the beginning, at the time of human beings, as we know, there was pregnancy and there was birth and there was cord clamping. We don't have a report when used to before the date of the first literature when the cord was usually clamped. If you go to our ancestor or you are going to our grandmothers, they will even actually say, why you are in a hurry? You know, it's a baby, he has the placenta and the cord to connect to it, and we'll clamp it anytime. So by natural, actually we should, in our literature, we should say the intervention is early cord clamping. Is it beneficial or not? And the control or the standard approach is the deferred or the delayed cord clamping or the usual or cord clamping. So when I looked into literature back, even as early 50s, the early clamping started to trickle and appear after they started doing some physiologic studies on mammals. And they actually calculated the amount of blood in each pulse in the cord, eventually saying by 1 minute you will receive around 80 to 100 ml of blood, and by 3 minutes and 5 minutes you are already late, khalas. So they define it by 1 minute and late clamping at 1 minute. Then there was a gap where there was nothing, there was no trials, there was no specific recommendations, and ultimately the cord clamping became shorter and shorter. Why? Because more advanced care, now we're saving more preterm babies, and the obstetrician want to go to يلا give the baby اعطيه للنيوناتولوجيست خلينا نخلص تمام. So eventually ended up by immediate cord clamping, and usually done within 15 to 20 seconds. And even I remember the days, so بسرعة. Okay. Nowadays, a great author said, after coming a full circle, the ancient practice of deferred or delayed cord clamping is popular again. But some people will say, what do you want to say, delayed or deferred? I would refer, you will see in the literature, this word terminology is being used interchangeably. I would prefer deferred. However, now it's becoming popular again. So the last 2 decades, many trials were done. And not only that, many systematic reviews were done. And not only that, there's a systematic review of a systematic review even done. So I was swamped with literature, what to do, what to say, However, the professional organization now recommends the deferred cord clamping in term and preterm infants. In summary, for example, the WHO, since 2012, they recommended more than at least 1 minute of deferred cord clamping after birth in term and preterm infants who do not require PPV. The NRP guidelines by the American Academy of Pediatrics also
they suggest 30 to 60 seconds. The Royal College Obstetrics and Gynecology also, they recommend for at least 2 minutes, and for the American Society for Nursing and Midwifery, also they recommend 2 to 5 minutes, so they're more liberal. Now, these recommendations actually were based on many reviews done and many trials, and they are all both, we're talking about both term and preterm infants. And of course, when I say the deferred cord clamping, you have concerns. Concerns start to appear. So one of the concerns that you might delay the resuscitation effort if you need, especially in preterm infants. Now the trials actually are talking about intervening on while the baby is still on the mother's lap or below the mother's pelvis. And it's been shown at many occasions or many trials that being the placenta still attached and the baby still attached to the cord, you'll actually get a benefit from the blood flow coming from the placenta. How about the potential for excessive placental transfusion? It's been established in many trials that it only shows a mild increase in neonatal jaundice. That if you have a reasonable program, you might notice a little bit of increase in phototherapy. However, no kernicterus were reported. How about deferred cord clamping and IVH? Actually, it's not in deferred cord clamping, it's in the umbilical cord milking. So another practice, if you obstetrician previously used to do, is that if they think the baby needs immediate resuscitation, they will just bring the baby out, start squeezing the cord, and do what we call the umbilical cord milking. And so many trials done on that, and in 2019, a study that was halted early with 447 infants enrolled, and it was because the extreme preterm infants in the umbilical cord milking was more often to develop IVH compared to those similar with just deferred cord clamping. So hence the recommendation below 28 week, do not do, be careful or don't do the umbilical cord milking. However, anything above 28 week, there is no evidence to support or refute doing umbilical cord milking. But here, still the standard practice is to do umbilical cord, deferred cord clamping. So what are the obstacles? Now, it is simple and inexpensive practice. And most of the units, when you go to them, they will say, okay, no problem. We can implement the deferred cord clamping in term infants who are vigorous, no problem. We can do that easily. They'll just issue a memo and they will do it. However, the challenge comes later on in the preterm infants or infant who require gestation or in the multiple gestation. There should be a setup for and a very clear pathway of how to implement such deferred cord clamping. So whenever you do a quality initiative process, you'll have a persistence of cost. هذا ما وجدنا عليه آباءنا. So you'll find that. And also lack of awareness and the confidence level of how the baby, how stable is the baby. And of course, you might see conflicting over guidelines. Even with all the society's recommendation, a study in California showed that only 42% of preterm infants less than 32 weeks did not receive the deferred cord clamping. In Canada, 40% of preterm infants, 53% of extreme preterm infants in 2018 did not receive cord clamp. Remember, these are 4 or 5 years ago studies. Nowadays, most probably these practices actually might increase. How about deferred cord clamping in Saudi Arabia? I tried to search any published literature. I found a very nice article about the current delayed cord clamping practices and attitude among obstetrician midwives toward delayed cord clamping in Saudi Arabia. So the objective of the study was to investigate the current practices of healthcare professionals and the timing of the umbilical cord clamping in Saudi Arabia, and it was a cross-sectional survey. It included 5 tertiary centers in Riyadh, and it was done from May to October 2016. And it included obstetrician midwives and completed via questionnaires. And their outcome was the current umbilical cord clamp practices and attitude of obstetrician midwives towards the deferred cord clamping. So it included 157 respondents, and most of them, and of course, from our sister hospitals in Riyadh. If you are in Riyadh, you know the abbreviations: King Fahd Medical City, King Faisal Specialist Hospital, King Abdulaziz Medical City, and King Salman Military Hospital or Medical Complex, and of course, National Guard. And of course, mostly were female, and mostly were equally between obstetrician and midwives, and the higher education level, and of course, they had the excellent degrees, and they had a very reasonable experience while working as in the obstetric field. So the results at that time, if the question asked, do you have an existing guideline of umbilical cord care, just umbilical cord clamping time? And you will notice that 40% of them, or more than 50% of them, said no. And if you have a setup time, so do you have if you have a guideline, you have a setup time like 1 minute, 30 seconds, 1 minute, etc. And more than 50, almost 60% of them said no. And you will notice that practices of doing the umbilical cord clamp varied between just doing it for no reason, according to unit protocol, or to prevent polycythemia, hyperbilirubinemia, or minority, they say, we're not worried, I will not clamp it until the baby is, I'm not worried at all. Some actually had some interesting thoughts, like wait until the pulsation have ceased to optimize blood supply, and etc. Now, if you ask these personnel when you are going to close or you clamp the cord early, majority agreed that if the baby had a low Apgar score, meaning that the baby is requiring active resuscitation. And this is actually not different from the literature. So, and also if there's a short umbilical cord, and if they are worried about knuckle cord and worried about a lot of vaginal, maternal concern or vaginal. However, 33% they answered, I always do umbilical cord clamping immediately. So that was the practice that time. So when the question asked, when is the occasion for doing later umbilical cord without timing? Okay, the answer was 45% they don't do, so the late clamping. Also, some answers you will see that while the umbilical cord is still pulsatile, and then once this pulse ceases, then they will start clamping. And if the placenta is still attached, and if the mother is breastfeed, they can delay the cord clamp, and etc. So these are some cognitive questions if asked for these healthcare providers. So do you have setup time? The reasons for umbilical cord in preterm infants. So setup time, they didn't know anything about setup time at that time, 65%. And majority also, the reasons for delaying not doing the delayed cord clamping in preterm infants, the majority said they're worried about the condition of the child. And what about elective C-section? Also, they said we don't have time, they will do it as soon as possible, most of the at the time of C-section. And if there is sorry, the oh yes, so the elective C-section and emergency C-section. So this, whether you're C-section, whether vaginal delivery, it didn't matter. So they will, majority will not do it. So going to the cognitive part, if you ask the question, delayed cord clamping is good for preterm infant, not requiring PPV, majority, they said yes, agree. So they are in depth their knowledge, they know it's beneficial. It's good for baby not requiring PPV, the majority said yes, and or correct answer. And even for babies who's requiring PPV, majority also, they answered well. The least favorable answer was if the delayed cord clamping is not applicable for babies delivered by C-section. So they answered wrongly most in this case. Okay, so this is the situation in Saudi Arabia. What happens then? This is, and this will be my cumulative slide of, because I will not take a long time here, cumulative slide of guidelines on deferred cord clamping and cord milking, which was a systematic review of major recommendations or summary of recommendation on deferred cord clamping and cord milking. And if you see this one, if you this sign, it indicates the deferred cord clamp, and this one, sorry, this is the deferred cord clamp, and this is the umbilical cord milking. And they found almost 44 statements from variety of, from the WHO, ACOG, Royal College, and 69 recommendation on the delayed cord clamping. And for the preterm infants, they found almost 36% recommended 30 to 60 seconds, up to duration 30 to 180 seconds. For term infants, also the same. They recommended 30 to 60 seconds when cord pulsation ceases after delivery. So the usual recommendation is 30 to 60 seconds. However, some recommends also until the cease of the pulsation, cord pulsation. If you combine both, either to preterm or term, they might recommend more than or less than 30 seconds if the cord pulsation ceases. So the common contraindication, so when is not to do cord clamping, of course, if the need for early support, heart rate less than 60 per minute, fetal anomalies, and for maternal reasons, of course, if she's unstable, bleeding, or she has placental problem. For the umbilical cord milking, almost 23 recommendations, and 65% of them suggest umbilical cord milking when the deferred cord clamping is not feasible, is only half. So when you suggest, either it is because the deferred cord clamping is not feasible, or if the early neonatal support is needed, then 47% they recommended using the umbilical cord milking. However, be warned, less than 28 weeker is still under study, so do not do it. I would like to, okay, all these sessions before, they were about the quality, so quality initiative. So you are in a unit and you want to do a quality improvement project to improve your delayed cord clamping. And as our great author before, you don't try not to do it alone. Now, even the literature now, current literature we found is the delayed cord clamping was considered as a bundle of neuroprotection, as a bundle to improve neonatal care. So it's not being treated alone. I'll just do cord clamp والبقية ما حسب لها شيء. It is part of the bundle. So it includes the preventing hypothermia, early surfactant, and delayed cord clamp, etc., etc. So
it's more.
Okay. So basically, you establish your literature review, convince your administration that it is needed, check your local rates, and compare them to benchmark locally and internationally how many deferred cord clamping you're doing, and involve the stakeholders, patients and their parents. And of course, if you're an obstetrician, the mothers and the husband, and of course, organizational head of departments, and if you have any networks, and assign team leaders. Most of the quality improvement projects, I found that they are successful if you assign the leaders from nursing or from midwives. So assign appropriate team, motivated team leaders, and check the measures that you need to check for it. Initial data collection should be looked at practices prior to the deferred cord clamping, and to identify the barriers, and do the series of PDCA cycle to evaluate the implementation guidelines in the unit. And suggest various strategies, do a brainstorm session, and do suggest various strategies. For example, observation of practice at another tertiary center with higher rate of deferred cord clamping. There are trolleys now. I will try to find, I'll show you the video for that. Life Start, it's called Life Start trolleys, where actually there is a mannequin and the multidisciplinary team approach, where the neonatologist, respiratory therapist, obstetrician, or sorry, the midwives or the neonatal nurse come and resuscitate a preterm baby in this trolley while the mannequin of the mother is still there, and they try to apply the elastic wrapping and the delayed cord clamping and the nasal CPAP. And of course, do regular multidisciplinary stimulation training for familiarity and troubleshooting, and put posters in L&D and OR to remind the staff about deferred cord clamping. With multiple PDSA cycles, on a unit in UK, and of course UK, they keep publishing on each unit keep publishing their outcomes, and you can see once a unit starts implementing the cord clamp, you'll see initial resistance and then a fluctuation, and this drop was basically due to a strike or something like that, and then at that point you will reach to your highest level of delayed cord clamping or deferred cord clamping more than 1 minute. And your immediate cord clamping rates actually drops with time, and keep doing this cycle until you have a persistent rates. And of course, if I talk here theoretically, initially, when I thought of this one, I thought it's already khalas, it's already been studied, it's already been implemented. But by time we'll see, it's really, if it's not documented, it's not there. And also in preterm infants, it's a challenge. It's a challenge and it needs expertise more. By this, I would like to conclude. Thank you very much. And this is the YouTube link to show you this the baby trolley life. Okay. Thank you very much.
Thank you. Thank you, Dr. Hundi, for being in time. I call all the speakers to come to the stage for the questions, inshallah. Any question or comment? Yes, Dr. Sameh. The one in the mid, down. Yes.
Assalamu alaikum. Good afternoon. Thank you very much for our distinguished speakers. My question here is addressed to Dr. Saif. Currently, what's your current practice, Dr. Saif, in minimizing or trying to minimize the risk of BBD in your institution? Currently, are you doing anything different to try to minimize out of the recommendations that you mentioned to us?
When I present my presentation, I thought, and I found myself that we are not using a lot of preventive measures for our babies. Example, Lisa, we don't start using Lisa yet. So maybe we are thinking together in the unit to start using Lisa. It may be helpful. We are using hydrocortisone for sometimes for babies in general, mainly for small, tiny babies. We are not using it for a bigger baby, which shows the evidence that decrease the BBD, especially if the mother exposed to chorioamnionitis. And most of the preterm infants, they deliver early because of infection, prom, etc., etc. In regard to high frequency, it depends on the babies. We are not using it as a prophylactic, but if the baby is sick, we use it. Our rate of BBD, before I wish I have the slide, but I do not have it. It's comparable with which was in the literature. Maybe 28 weeker it reached 33%. For 23 weeker, it's really high. Maybe it's 95% of the babies they develop BBD. It's in research, in process for publication of BBD in our unit.
I think, Dr. Steph, this is a national problem in all tertiary care centers within the kingdom. I think if we can take this opportunity from the SNS and have adapted a project to minimize the BBD across the kingdom by establishing clear guidelines that we can all participate, I think this will be a great idea, because I think all hospitals, what I know, and according to the best of my knowledge, all provinces, we have the same problem. So I think, and as you said, Dr. Said correctly, most of us will not apply what we think might help as to minimize the risk of BBD. Thank you.
Yes, Dr. Amran. Please go ahead.
Assalamu alaikum. Thanks for the speak. Question to Dr. Mohammed Al-Hindi. Deferred umbilical clamp is not our problem, right? It's the problem with the obstetrician. I twice approached the head of department in 2 different occasions, and I gave him recommendations and the guidelines. But it seems for some reason which we don't understand, there is no motivation on their part. We are convinced, in this lecture, we are convinced of all the information you are giving. How to convince the other side of the equation?
Thank you very much for this question. I usually take it as if you are from a different department, you're going to a head of another department and you're telling them something they practice it. Of course they will fight back. I think the best way is to formulate a team with the stakeholder, like the midwives, the obstetrician. They should be taking the lead and just throw the information to them as a question. So, what about this? I heard something like this. Put it as a query for question for them to initiate, actually. And the other thing is the Saudi Obstetric and Gynecology Society. Where are they? I don't know. I couldn't find any recommendation from their side also. If it's their higher authority or a recommendation comes from their society, might be much more palatable for them. In such unit, I try to spread a culture. I tried to spread question. I said, there is something called clamp, deferred cord clamp, or some, at least to be aware. Maybe a mini project, like a small awareness project, a small video, a small webinar, hours, a small, and things will take months, years until it's established. So even if you go to our center, if you ask the obstetrician, oh yes, we had a memo before 5 years.
This is all the design Baba Adam.
Don't recall where is it now. And then they looked into the policy, the National Guard policies and guidelines, and they found one. Mashallah, it was in the Eastern Province. And I think definitely there's so, these collaboration stuff, especially with medical complexes, because they are considered as a standard. You can tell them, oh, look, they are standard this and this. So actually we should go ahead and so setting standards, setting benchmark, publication. Of course, this is the only publication I found about cord clamping in Saudi Arabia. And eventually take it as a full bundle. Don't take just cord clamping, protection, and etc. etc.
Yeah, just may I the last 2 months, our Medina National Guard, we are applying DCC. We make a CPG and then awareness for our colleagues and obstetric. Alhamdulillah, for the last 2 months, they are cooperating with us so far. So hopefully, inshallah, we'll complete the study with them. Yeah, any more, please. Yeah, please.
Can I ask Professor Sajjad Abdurrahman? The program cell death in hypoxia, is it altered or changed by the hypoxia itself or other factors that death bring the cell death right away from 70 years into 70 hours or 70
Yeah, I think the cell death is a combined effect of hypoxia and ischemia. So they both contribute to it. What we have learned is that the death is not instantaneous in most of the neuronal cells. The instantaneous death which occurs contributes a very small part to the neurodisability later on, or even to the death during the period. The major part of neuronal damage, including neurons and non-neuronal cells, it happens afterward.
Sure.
And that is where we as neonatologists are now working to say what opportunities we have once the baby is in the NICU. Then there is a lot of opportunity to save as much neurons as possible. And there's a famous article by Professor Marian Thoyson, Time is Brain. It's talking about the newborn baby. So the earlier you start, the better it is. The more you delay, the more is neuronal cell damage. Neurons as well as non-neurons. So these mechanisms are actually secondary and tertiary mechanisms, not the primary one. Primary, what we say is the hypoxia ischemia. It does damage, but that is not a big part of the whole picture.
But if it is started, if the program gets triggered by hypoxia, ischemia, or other factors, you cannot stop it after that, right?
No, that's what we think. Hypothermia actually stops that. The whole theory behind using hypothermia for 72 hours is that most of the secondary mechanisms which come into play after the first necrotic death of a few cells, these necrotic death cells release biochemical mediators. And these mediators then cause the cell death. So if we can stop the release of these mediators by giving hypothermia, then we prevent a lot of secondary damage. And that's where we think it is neuroprotective.
I think by this, thank you very much for all the speakers. Thank you very much for all the audience. We are going to now speak.
We are booked for the international speaker at 4 o'clock. And we have one lecture before that by Dr. Mansour Al-Qurashi. So please come back to the hall in 3:40 exactly, please. 3:40. So the next session will start at 3:40. And that will be the last session. So we'll take you another 1.5 hours, and that's it. Thank you. Enjoy your coffee and come back soon, huh? We don't need to go back after you.
Doctor, Bosco piece is already online. Okay, okay.
بشر تلك طبيعتنا أخطاء ستعلمنا لنحسن ما هو فاسأل نفسك واطرح سي ما دورك في التحسين ما دورك في التحسين فاسأل نفسك واطرح سي ما دورك في التحسين ما دورك في التحسين ليس بحلم أو تنظير انظر حولك فالتغيير أصبح واقعنا فتغير ما نفعله أننا ندعو لغد أفضل ألا نتشاء في الأمرين مخير فاسأل نفسك واطرح فيه ما دام من أجل الآتي اليوم للكل يد في التغيير نحن بأنتن وأنتم نحن بأنتن وأنتم كلنا بكبير وصغير مجهودات تتوالى مشوار سهل لا 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 لن يخلو من عثرات بشر
who has paid from the same email ID we gave, so that the money will go back to the credit card. Yeah, the same email, the same transaction. Okay, just send it to me with the name and the email. I will put for the will apply for the refund, so the money will come back to your account. So not your personal. The registered email name is registered and paid. Okay. Send it. WhatsApp. Okay, send it to me. I will apply for the fund refund. So you will get the refund. Not immediately, you'll get, but I will just do it. When we apply for the refund, I'll show you some document so that we.
Ahmad, please, laptop.
Okay, so we will search that on this.
Stand by that laptop. Yeah. No, laptop.
I will put also here the pens. Yes, I will take one. This one. I'm giving it here. I take it later. This also keep it inside. I'm going now. Yes. See you tomorrow. Yes, see you. See you. Bye. See you. Bye.
Hello.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه. It's a great pleasure and honor to start the last session today. It's about miscellaneous, and I would like to introduce my co-chairman, Dr. Sami Abu Zaid. He's a consultant neonatologist and head of the department, neonatal intensive care unit at King Fahd Medical City, to introduce the first speaker. Dr. Sami.
Assalamu alaikum. Good afternoon. طبعا it's our great pleasure to introduce Dr. Mansour Al-Qurashi. Mansour Al-Qurashi is an associate professor of pediatrics and neonatology College of Medicine in Jeddah King Saud bin Abdulaziz University for Health Science. He's the head of the Division of Neonatology at King Abdulaziz Medical City, and he's the Dean of the College of Medicine, and his interest in respiratory support to newborn infants. So you're most welcome, Dr. Mansour.
I'm supposed to press. السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد. First, I would like to thank the organizing and scientific committee to invite me to be among the distinguished speakers and moderators, and I'm very happy to share this presentation with our participants. I will talk about today a new modality. It's not a new modality, but it's a new era in using high-frequency oscillatory ventilation with volume target. I have to disclose I have no actual or potential conflict of interest in this presentation. I will go through some introduction slides, goals of respiratory support in newborn infants. I would like to just have two slides about ventilation-induced lung injury, linking it to the new modality we are proposing. And I will show you the benefits of controlling tidal volume during respiratory support for newborn infants.
One of the secretary was
we all use for the last decades. I will show you the effectiveness of the use of high frequency for acute pulmonary dysfunction in preterm infant. There is an evidence. I will show you the current studies about using volume to guarantee in high frequency, its concept and potential benefits. I will try to suggest some practical guidelines for its use and take-home messages. The goal of care in the care of preterm infant in the 80s and 90s was to improve survival. However, in the last 3 decades, the shift was moved from improving survival, because survival, especially in developed country, had leveled off. Now we emphasis more shifted toward improving functional outcome and intact survival. As Dr. Saif had mentioned to you earlier, that the incidence of PPD subsequent to ventilation has not improved significantly since the introduction of exogenous surfactants in the early 90s. And that's why there is a shift looking for other things, especially ventilation, and why and how to ventilate neonates, to how best to do it without major sequelae of the ventilator device. What ignited that is the Columbia approach, and the Columbia approach being for more than 3 decades. However, it became more adopted for the last maybe 15 years, not to intubate, trying not to intubate, and only provide respiratory support with CPAP. And that ignited the interest in non-invasive respiratory support. We have to remember that, as Dr. Saif had mentioned and show you the slide about lung growth, that when you're ventilating a newborn infant at different gestational age, we are dealing with a very developing lung at different stages. And imagine these developing lung units would be very much affected, adversely affected, if you are causing any harm to it. The classic mechanics for ventilation-induced lung injury is barotrauma, volutrauma, atelected trauma, biotrauma, and exotrauma. However, the emphasis is much more in the last probably 15 years on volume, and there is enough body of evidence that volume is probably the culprit to lead to lung damage, and I will show you some of the slide related to that. This is a very important slide. This is an injury zone in lung. As you know, we like to maintain an optimal lung volume. So when we, how can I use them? Sorry. You know, as we'd like to ventilate newborn infant in the middle zone, where when we inflate the lung to high volume, that will lead to high volume injury zone, as well as when we collapse the lung, that will lead to another cascade of low volume injury zone. So our aim is to try to ventilate newborn infants, either premature or adult, in the middle area with optimal lung volume. The concept of high frequency, as all of you know, that it uses supra physiologic rate, meaning that typically the rate above 180 per minute, and that's equate to 3 hertz. A use of a constant distended pressure, we call it MAP, above the functional residual capacity, and we use oscillatory pressure, we call it amplitude or delta P, around the MAP, and that to produce a small tidal volume, hopefully smaller than the dead space. This is the famous sensor-medic. I'm sure all of us have it still in our unit. And the interesting thing did not change. The same ventilator device from the early 90s. I hope the company will change the look of it so people buy it. It seems to be the same machine, still in use in many units, but this is the machine we all use. We used to call it in the early 90s. I remember Dr. Saleh Al-Ayyan and Dr. Abdahin Gattan used to come to National Guard as locum in the mid 90s. And we tend to put them in the babies on high frequency very late. And we changed the name of the ventilator to be a terminator, because we use it too late and babies is dying, and then we put him in a oscillator and he died. So we shifted the name from oscillator to a terminator because we use it too late. So the potential benefit of using high frequency is use a small tidal volume, less than the anatomical dead space, and that may reduce risk of volutrauma. We use a lower peak distal alveolar airway pressure to facilitate gas reduction, and that reduce the risk of barotrauma and eventually volutrauma. We use MAP or descending pressure, and that enhance maintenance of optimal lung volume. This is just a diagram to show you that. Do you have a pointer here? Okay, yeah. Is it working or no? Not working? The computer? Okay. Okay, so this is here, as you know, when during high frequency, we inflate the lung to midway between PEEP and PIP, we call it MAP. And then we put frequency, and this slide is 3 frequencies or 3 cycle, and we have the amplitude. Amplitude is the volume of the breath oscillation around the MAP. So you inflate the lung to MAP, you oscillate around the MAP, and you call this oscillation power or oscillation pressure, you call it delta P, and the frequency is the rate or the frequency. But very interesting, I have this very important slide. As you see in high frequency, though we apply delta P or amplitude at the, let's say 25 or 30, what the alveoli see is far lower. So you see there is a dampening of oscillatory pressure or delta P when the cycle goes down to the trachea and then later to alveolus. That means if we put delta P of something, that delta P is not transmitted to the distal alveoli. It's very much dampened. And this is the concept of using high frequency, because you dampen the pressure, which is an advantage. This slide is a bit complicated, but I'll try to. Here you have on the 2 kind of high frequency in the blue and conventional in the black. As you can see, in the airway opening, the wave for conventional did not change. So whatever the lung will see, the pressure you are giving at the airway opening, while in high frequency, as you can see, there is a dampening. So the pressure waves actually goes down. So what the alveoli see is much lower delta P fluctuation at the alveolar level. The more interesting in this slide that when you have a normal compliant lung, less diseased lung, the alveoli will see much less of this pressure. So it's probably more protective if you have improved lung than with the delta P. What the alveoli see is much less than if you have non-compliant lung. Classically, as we know, when we improve oxygenation, we have to increase FiO2 or increase MAP. This is the usual way of improving oxygenation in the past. With CO2 elimination, we used to change two things, either amplitude or frequency. And classically, when we increase delta P, that will improve ventilation and CO2 elimination. However, the frequency, increasing frequency in the classic conventional high frequency will lead to lower tidal volume. So increasing frequency will increase CO2 retention. And that's why in the past, when we have high CO2, we actually reduce the frequency. And the reason, because tidal volume fall when the frequency increase due to shortening of the absolute I time and less time for tidal volume delivery. So, but there is a significant challenge, and all of us, we see it. We, especially the sensormetric tidal volume, is not measured nor controlled. So we don't know how much volume the baby is getting from whatever parameter we are giving. The probability of hyperventilation and driving CO2 low is much higher with convention. And this is the problem when the past, when you put patient high frequency, you found the CO2 goes down quickly. The other major problem is higher frequency, which is the concept of high frequency. When we increase it, adversely shorten or reduce the tidal volume delivery, and I mentioned that, and that will reduce CO2 elimination. And this slide is very important slide. Classically, in high frequency, when we increase frequency, let's say from 5 Hertz to 15 Hertz, you see there is a significant reduction of tidal volume. So every time you reduce the frequency, you reduce tidal volume, and that happens all the time. And why is that? Because you are giving very short I time. When you reduce frequency, when you increase frequency, you shorten the I time, so the time of the pressure to reach the alveoli is much less, and that will affect adversely the tidal volume. Maybe Dr. Saif had mentioned that this Cochrane review looking at volume targeted conventional ventilation in relation to conventional. And this is a summary of this meta-analysis, which was published almost 5 years ago, that volume targeted conventional ventilation has less PBD at 36 weeks, less death, less pneumothorax, less IVH, grade 3 and 4, less BVL, and less hypocapnia. There was no difference in survival, no difference in all IVH, and no difference in severe disability. Is that the same concept? Is high frequency is compared to conventional has a better outcome? This is a Cochrane review published almost 7 years ago, trying to evaluate the elective, not the rescue. The elective means you start with it. High frequency versus conventional for acute pulmonary dysfunction. It was published 2015. They included 19 randomized controlled trial, and they included 4,096 preterm infant, including this review. And the primary outcome of this meta-analysis to determine whether the effect of elective versus conventional on mortality, on chronic lung disease, and other prematurity complication. It didn't show a difference in death. So the death at 28 days, 29 days, not similar, not statistically significant. Death at post-menstrual age of 36, not different. There was slight reduction in chronic lung disease. I can see that there is the relative risk was 0.86 and did not cross 1. So there was slight reduction in chronic lung disease in high frequency. But very interesting, when you look at the studies looking at the conventional, the earlier study, because they didn't use volume targeted, it did show a superiority of high frequency. But if you look at the later study, because of the use of volume targeted, the benefit of high frequency was much less compared to the earlier study. So, but in this slide, tell you that slight reduction in chronic lung disease and slight reduction in death or chronic lung disease at 36 and 37 weeks compared to conventional. Air leak was slightly higher in high frequency, but not statistically significant. Grade 3 and 4 IVH was slightly higher on high frequency, but not statistically significant. ROP, the slide actually, sorry for that, it's the flip-flop, the high frequency, the second one, and conventional, the first one. So in this slide, the ROP was slightly lower in infant who had high frequency compared to conventional with relative risk of 0.81, but it was marginal, risk estimation. So this review tell you that there's no difference in survival at 28, 29, 30 weeks, at 28, 30 days, nor at 36, 37 weeks. No difference in severe IVH between conventional versus high frequency, and no difference in cross-air-leak syndrome. There was some reduction in chronic lung disease, small reduction in ROP stage 2 or greater. However, it was not consistent finding the reduction in high frequency, no effect on mortality. There was trends toward higher IVH grade 3 and 4 and BVL in high frequency, but the same. It was not statistically significant, it was not consistent finding. So now I'm trying just to explain to you how the new mode would probably, hopefully, modify these outcomes. As I mentioned to you in the past, the regular high frequency would not measure nor control tidal volume. Now we measure tidal volume. Not only we measure it, we control tidal volume by adjusting the amplitude or the pressure around the map. We are able to use high frequency and with lower tidal volume to maintain adequate minute ventilation. This is the concept here. As you can see here, this is a conventional ventilation with volume targeted. So we set the PIP usually 20% above the measured PIP, and you can see that we have a constant tidal volume. However, the pressure, the PIP will be fluctuating to achieve the the desired or the target tidal volume. So, and this is a self-weaning. When we combine volume guarantee with high frequency, we do the same. We actually now the variable will be the delta P. So the delta P or amplitude of each breath will be depend on the lung complaints and the disease. So when the baby require his diseased lung, he would require higher delta P. When he improve, you find the delta P weaning it goes down to achieve a stable tidal volume. This is a concept very important, especially with the new era of high frequency with volume target. As we CO2 elimination, as we know, depends mainly on amplitude and respiratory time. There's something called diffusion coefficient of CO2, and this is it's equal somehow minute ventilation in conventional ventilation, and this CO2 is equal to the square of tidal volume multiplied by frequency. So if you can see here in the equation, to increase DCO2 and to increase CO2 elimination, you either increase tidal volume or increase frequency. In the classic conventional high frequency, when we increase tidal volume, the effect on minute ventilation or CO2 emission will be significant because it's squared. So any change in tidal volume is 0.2 will be 0.4 because you are increasing it. Frequency, as I mentioned earlier, because when you increase frequency, you lower the respiratory time, so you would adversely lower the tidal volume. So you gain some frequency here, but you lose it by more drop in tidal volume. This is why DCO2 will go lower if you increase frequency in conventional ventilation. However, when you combine a volume guarantee with high frequency, you see here, you remember the initial slide I showed you, the same slide. When increasing frequency, you drop your tidal volume. Now, when we fix the tidal volume, you find the tidal volume became constant. So the effect will be positive in CO2 elimination. So any increase in frequency will ultimately increase DCO2 because there will be no drop. You fix the tidal volume. So the effect on DCO2 and CO2 elimination will be probably the same. If there is any data behind it, I'll show you some data. I have many other data, but I will, for the sake of the time, I will only present few. This is animal experimental data. They had 20 picklets, and they induced RDS in them, and they were wanted to do the old. And they actually used two strategy: high tidal volume, and frequency of 10, and lower tidal volume with the frequency of 20. So high frequency, lower frequency, and high tidal volume, whatever. And they ventilate them for 20 hours, and they have a comparable CO2 level in both groups. The piglets' lungs, which were exposed to low frequency and higher tidal volume, had more severe histological lesion and infiltrate and hemorrhage in the alveoli compared to the piglets who were ventilated using lower tidal volume and higher frequency. So that may indicate or may propose that there is a potential less lung injury with a low tidal volume and high frequency in the studied animal group. This is the slide just show you that in the AB are the lower frequency, higher tidal volume, and in the BC, CD are the the higher frequency and lower tidal volume. And you can appreciate there is less infiltrate, less damage to the lung when you give them higher frequency and lower tidal volume. The same group had actually aerial study 22 newborn infant with volume guarantee, and whether did they actually reduce tidal volume while they increase frequency to achieve a constant CO2 elimination, and they found that increasing frequency while reducing tidal volume maintained a similar CO2 elimination, and tidal volume was significantly lower. It was 1.59 in the higher frequency compared to 0.2 with acceptable CO2 elimination. So this strategy may potentially reduce lung injury.
Sorry, Dr. Mansour, 5 minutes.
Sure. This is the same data as I show you that in the initial they had the frequency was 10 increased to 16. The tidal volume subsequently was reduced from 2.2 to 1.5. So you use you choose higher frequency with lower tidal volume, and surprisingly you see that the FI2 there was significant reduction in FI2, significant improvement in saturation, and significant improvement in CO2 elimination. This is another trial where it's a randomized crossover. So they have 22 infants less than 1.5 required invasive mechanical ventilation. They randomize them to high frequency with VG or high frequency alone, and they cross to the other mode after initial stabilization. And the conclusion of this study that high frequency with VG is feasible, provide more constant ventilation and gas exchange. However, the recommendation by the group that further randomized control trial with larger sample size is needed. This is the data. As you can see here, this is the high frequency group, and you can see that the infants who were ventilated with conventional ventilation, conventional high frequency, they stayed only 35% at the target tidal volume, while infants who were being on the volume guarantee, they stayed 80% in the tidal volume. And you can see also the lower tidal volume was much less. So you have more consistent tidal volume in those infants where you control tidal volume for them. The result of this study that DCO2 and mean tidal volume was significantly higher in the high frequency with VG compared to high frequency alone. Hypocarbia and hypercarbia were lower in the volume guarantee mode, and this strategy may potentially reduce lung injury. This is not a neonatal study, but it's a cardiac study. They had it was done in China. They had 58 infants who underwent cardiac surgery for congenital heart disease. They were infants, and they have 29 in each group. And what they did, they tried to measure interleukin 1, 6, 8, and alpha 1, tumor necrosis alpha F1 alpha, and they analyzed the tracheal aspirate on day 1, 2, 3. So the group who were post-surgery, they put them in high frequency alone or high frequency volume guarantee, and then I tried to measure those cytokines. And they found that there is increasing trend of interleukin 6, 8 tumor factor on day 2 on the high frequency group compared to the volume guarantee group, and there was significant increase on day 3 after 3 days of ventilation with the high frequency without volume guarantee, and the p-value was significant. They also found that the low CO2 and high CO2 was much less in infant on the high frequency group with volume guarantee. So this study is published a few months ago, and they say that high frequency oscillative ventilation with VG compared to high frequency post cardiac surgery with cardiac congenital heart disease reduce post-inflammatory systemic reaction and have less PCO2, high or low PCO2. So I would like to share you what I suggest from going through the topic, that in our unit, we use it as a rescue. So we are very much CPAP, non-invasive ventilation, but when we intubate them, we put them in a volume targeted conventional ventilation. But with the baby, and there is specific guidelines we have for putting them in high frequency. So I recommend to you that we used as a rescue respiratory support for newborn infant with respiratory insufficiency who fail non-invasive and volume targeted conventional ventilation. Setting the map is similar to the conventional. It's 2 to 3 centimeter above the closing pressure after lung recruitment.
Sorry, Dr. Mansour, last minute, please.
Finish 2 slides only. Start with tidal volume of 1.5 per kg and titrate according. So you see that now there is a trend. Actually, some data supporting using 1 ml per kg. But I don't think you need to that extreme. I would suggest you start with 1.5 ml per kg, titrate accordingly, and look at your blood gas, look at DC2 level and value. Start frequency 10 to 15 to maintain acceptable CO2. And I think the most experts recommend higher frequency now. Use I time 1 to 2 when using volume guarantee. I'll conclude by saying volume targeted high frequency is promising respiratory support modality for treating newborn infant with respiratory failure when non-invasive or volume target conventional ventilation fail. High frequency oscillative ventilation volume guarantee modality allowed to use a lower tidal volume than the dead space by using higher frequency to maintain acceptable CO2 elimination. Further larger study are needed to evaluate its comparability, superiority over the conventional high frequency and applicability to various respiratory conditions with heterogeneity of etiology and underlying pathophysiology. Thank you.
Thank you, Dr. Mansour. Dr. Khalid.
Thank you, Dr. Mansour, for this enlightening talk. Now I would like to introduce the second speaker on an online presentation, Professor Oscar Bays. He is a graduate from 1972 MBBS. Then he got his MD from McMaster University, Canada. Then he had his fellowship from Trinity College, Dublin, Ireland. Then he did McMaster University, Canada, also fellowship. He is currently retired neonatologist since 2009. For the last 3 years, he has been the chair of advisory board for RSV prophylaxis for the Ontario of Health and Long-Term Ministry of Health and Long-Term Care. He's going to talk to us about the burden of RSV on young infants.
Good afternoon, everyone. I hope you can hear me and can see my slides. Can I confirm that you can see my slides?
No, not yet.
Oh, okay, because I've started my screen share. Ooh, okay. Can you see them now? Hello? Hello?
Yes, Dr.
Can you see my slides now?
No.
Okay, I don't know why I'm having a problem because I'm doing the screen share and the screen share says that it's up. And can you see them now?
Sorry, not yet.
Okay, you know what? I'm just having difficulty. I don't see why, because I'm screen sharing and it's working from my end, saying that I'm screen sharing. So maybe you could probably ask Dr. New whether he'd be willing to present next, and I'll see what I can do. Or shall I try again?
Can you hear us?
Yes, I can hear you. Can you hear me?
Yeah, we can hear you clearly, but we can't see your slide.
Slides. Oh, and I'm screen sharing. I've tried stop sharing and then going to screen share again, but obviously it's not coming up. Can you see them now? Can you see them now?
And not yet, but the technician with us, so we will see from our side if we can do anything.
Okay.
Yes, now we can see.
You can see them now?
Yes,
Yes,
you can see
please.
it.
Okay. Okay, so obviously there was some difficulty. Okay, are we ready to go then?
Yes, please.
Okay, super. Thanks ever so much. I would like to thank the chair for that kind introduction, and I would also like to thank the organizing committee for inviting me to participate and present in the symposium. The topic for today is burden of RSV in young infants. Here are my disclosures. I have a research grant from AstraZeneca to study the use of a risk scoring tool in moderate to late preterm infants to target infants at risk for RSV hospitalization. So the objectives of my talk are threefold today: to review the burden of RSV infection in preterm infants, discuss the short and long-term impact of RSV infection, and address costs associated with RSV illness. So the first slide shows you the burden of RSV globally in terms of hospitalization and mortality. And the estimate is that 31% of all lower respiratory tract infections are due to RSV, which amounts to just over 33.8 million RSV episodes worldwide. Out of that, 3.1 million children tend to be hospitalized with RSV. And the most important message from this slide is that 79% of the hospitalized children are healthy. In fact, a recent publication just out in Lancet Respiratory Medicine, conducted by the rescue investigators across Europe, show that 1 in 56 healthy term newborns are admitted with RSV. Overall, globally, majority of RSV hospitalizations tend to occur in children less than 2 months, and approximately 0.5% of children aged less than 2 years get hospitalized. When we turn our attention to mortality, the global estimate is somewhere between 66,000 and 100,000 deaths in children aged less than 5 years. And the highest mortality is in the HIV group, followed by the very low birth weight infants and those who are immunocompromised. If you look at the mortality burden, 99% of all deaths occur in low middle income countries. And where do these deaths occur? 20 to 50% occur in hospital in children aged 2 to 4 months, and 50 to 80% occur in the community in children aged 1.5 months. Overall, in the US, the cost of RSV hospitalization amount to just over $3 billion direct medical costs. So we look at the risk factors for RSV hospitalization in children aged less than 5 years. And this was a meta-analysis conducted of 20 studies by Ting Shi from the University of Edinburgh. And what you see here are the odds ratios on the y-axis and the risk factors on the x-axis. As you can see, predominantly non-breastfed infants are at greatest risk in terms of odds ratio for RSV hospitalization. And all these other risk factors are well-established risk factors right down to male gender, in which the odds ratio is 1.2 for RSV hospitalization. In the COREST study in Canada, which was the Canadian Registry for Children who received Synagis between 2005 and 2017, in which we enrolled just over 25,000 children, we found that the same risk factors seem to pertain: siblings in daycare, family history of atopy, smoking in the household, greater than 5 individuals in the house, and daycare attendance. And having these 5 risk factors increase the hazard, as you can see in this graph, of RSV positive hospitalization by 9-fold. So taking you back to an original study conducted by Tom Boyce in Medicaid in the US, you can see on the x-axis the chronological age of the infants who are hospitalized, and on the y-axis the RSV hospitalization rate per 100 child years. Overall, predominantly, the highest incidence is in children less than 6 months of age. And it's important to recognize that, in fact, in infants between 29 and 35 weeks, the incidence of RSV hospitalization is not that indifferent. But in fact, the incidence tends to gradually decline up to 2 years of age. Overall, RSV hospitalization in preterm infants without prophylaxis is 2 to 3-fold higher than the term infants up to 2 years of age. The next study I want to show you was a well-conducted population-based study by Caroline Breeze Hall from Rochester, who studied the incidence of RSV hospitalization in preterm infants in Nashville, Tennessee, Rochester, New York, and in Cincinnati, Ohio. You can see in the second column, or third column, the RSV hospitalization rate per 1,000 children. And what we find is that overall, as you can see, that the highest rates of hospitalization are for those less than 29 weeks gestation. And what I wanted to point out is that the difference in hospitalization rates between 29 weeks and 35 weeks is not that dissimilar. How does this compare to viral hospitalizations, for example, with influenza versus RSV? This was a study conducted by the Public Health Agency in Ottawa in Canada by Dina Shanza. And you can see overall for children less than 2 years of age, the incidence of RSV hospitalization per 100,000 of the population is 12.9-fold higher than influenza. Let's turn our attention to the medical burden of RSV illness, the morbidity and mortality. So the first study I want to show you is from the Public Health Agency from Valencia in Spain, looking at RSV hospitalization rates in 100,000 children by chronological age and time between 2014 and 2018. Again, you can see predominantly the highest rates of hospitalization are for children less than 3 months. And by 6 months of age, in fact, the hospitalization rates tend to steadily decline. If you look at when these hospitalizations occur in the temperate zones, majority of them occur between November and March of each year. Of course, all of this has changed relative to COVID. And I just want to show you quickly the data from Canada, from Ontario, showing you that the time of presentation with COVID has now altered, with predominantly the hospitalizations in blue for RSV occurring between September. And in fact, by the end of February, there is a complete decline to a very low level. This is a study conducted by Rachel Reeves from the Usher Research Center in Edinburgh, looking at the burden of RSV in 7 European countries. In the top half, you can see the RSV-coded admissions for less than 1 year, and in the lower half, between 1 to 4 years. What you can see overall, that for infants less than 1 year of age in Scotland, Finland, Norway, and Denmark, the rates are 18-fold higher than those between 1 to 4 years. And in the UK, Netherlands, and Italy, in fact, the rates are almost 40-fold higher in infants less than a year of age. This is in Wang, also from the Usher Research Institute in Edinburgh, looking at the RSV hospitalization length of stay. Overall, in the 7 European countries, the RSV hospitalization episodes accounted for 9 to 21 bed days, majority of them in children less than 5 years annually. The median length of stay ranged from 2 to 4 days between the countries, and the largest number of bed days as a percentage were for infants, not surprisingly, who were less than 1 year. And overall, when they looked at RSV compared to the other pathogens, in fact, the bed days were much higher for RSV for infants less than 1 year, especially in those less than 6 months of age. This is a study conducted by Teresa Ochoa from Peru, showing you, not surprisingly, that RSV hospitalization in preterms less than 1,500 grams in Peru. You can see in the second column those less than 1,000 and those 1,000 to 500 grams. And you can see that the overall burden of illness in those less than 1,000 grams was much higher than those between 1,000 to 1,500 grams. And I want to show you the RSV hospitalization burden in moderate to late preterms in a study that we conducted, which amassed 7 studies globally. And you can see the countries displayed here in the second column. Just to draw to your attention, the PONY study that we included the Middle East, and you can see the countries outlined in the Middle East. The total number in terms of the sample size was just over 14,000. When we look at the RSV hospitalization incidence by gestational age, you can see that for the overall incidence across the gestational age categories was not different. But when we looked at the RSV hospitalization per 100 patient seasons, we saw a difference, the highest, not surprisingly, being for infants in the lower gestational age groups. When we looked at the health resource use between 32 weeks and 35 weeks, you can see the highest percentage was for children who received oxygen. And when we looked at the overall need for oxygen respiratory support in these group of infants, they amount to just over 82%. When we looked to see if there were any differences between oxygen support, non-invasive support, mechanical ventilation, and ICU admission across the gestational age categories, we found no statistical differences. The overall length of stay relative to the resources utilized are shown in this slide. And you can see, and not surprising, the largest lengths of stay were for children who received mechanical ventilation and those admitted to the ICU. The overall hospital length of stay was 5 days. This is Eric Samois's data from the US, looking at the burden of illness after RSV hospitalization in the first year of life. And what they looked at was all-cause hospitalizations compared to controls. And not surprisingly, again, they found that the hospitalizations per 100 patient years were highest in the early preterm population, followed by the late preterm, then infants between 29 to 34 weeks, and infants greater than 37 weeks. The greatest burden was physician visits and ER visits, which were much higher in the RSV exposed infants, and mostly this occurred in the first year of life. Let's now look at the long-term impact of RSV on lung function. The first study I want to show you is a meta-analysis, albeit it is old, conducted by Sarah and Salish Koteka from Cardiff. And what is the bottom line in this study? The bottom line is that preterm infants less than 37 weeks without chronic lung disease or bronchopulmonary dysplasia have moderate deficits of FEV1 compared to term infants. When you looked at this in comparison to the infants with BPD, the deficits were much larger, as you can see, almost twofold higher, between 16.2 and 18.9%. Fast forward to a study conducted by Yang from Auckland in 226 very low birth weight infants who had spirometry and lung function assessed between 26 to 30 years, exactly the same results, showing that preterm infants had a reduction in terms of all the lung function parameters, and this was much higher in terms of the deficit in infants with BPD. When we look at a long-term study in infants who are hospitalized with RSV in early infancy, conducted by Nelly Stigert from Sweden, you can see that in the RSV group, all of the lung function parameters were much lower than the control group, showing you that the persistence of deterioration in lung function goes on not only in childhood, but including adolescents and older kids. And this is a very interesting study conducted by Fernanda Martinez group from Tucson in Arizona, looking at children who had received at least 2 spirometries between 11 and 32 years. And you see 2 lung function trajectories, a lower one versus the normal lung function trajectory. When they traced these children back and looked at their maximal expiratory flow at functional residual capacity in infancy, lo and behold, those who had persistently low lung function had a lower Vmax FRC in infancy. And when they traced this back further into early infancy, they found that the lower lung function trajectory, in fact, was associated with infants who had RSV, low respiratory tract infection. So they postulated the hypothesis as to whether lower respiratory tract RSV infection sets the stage for chronic obstructive pulmonary disease in adulthood. Don't forget about the impact of RSV on families. And this is a study conducted in Canada by Ian Mitchell in Calgary. And what you see here is for children who get hospitalized with RSV, the average length of time both parents spent in the hospital was 7 days, with the mean out-of-pocket expenses, as you can see, just over $700. When they looked at the impact on families, absenteeism from work, presenteeism when they went to work and were not functioning on par, the overall work impairment and the activity impairment, working fathers were more impaired than working mothers. When they looked at the parental stressor scales, not surprisingly, working mothers were more stressed than working fathers. And when they examined the state anxiety and the trait anxiety in this cohort of parents, they found again that working mothers were more affected than working fathers. What about, in fact, the age-specific mortalities? This was a study conducted by Hansen in the US. And you can see when you compare RSV versus influenza in the first year of life, the RSV death rate was 4-fold higher than influenza. But by the time you got to the older age group, in fact, it was much higher for children with, for adults with influenza as compared to RSV. Don't forget that RSV and its mortality is equally higher in adults greater than 65 years of age, and in fact bears a very close resemblance to the mortality in infants less than 1 year of age. So what are the predictors of poor outcome? Back to Ting Shi, again, as part of the Global Health Initiative, who looked at this from the Usher Medical Research Center in Edinburgh. And he looked at 27 studies and looked at poor outcome defined by the need for prolonged length of stay, oxygen, mechanical ventilation, or ICU. And not surprisingly, infants less than 3 months of age, followed by those with congenital heart disease, with any comorbidity, preterm infants less than 32 weeks, those less than 6 months, and overall infants less than 37 weeks gestational age had a higher odds ratios of a poor outcome. We all know the impact study, and this shows you on the x-axis the use of palivizumab in the study, showing that there was a corresponding drop in RSV hospitalization if palivizumab was administered to all preterm infants less than 35 weeks gestation. What happened after the AAP guidance in 2014? What we see here is if you look at in fact, the change in guidelines versus post, there was an acute drop in the use of palivizumab, and this was accompanied by hospitalization risk, which was increased by 55% between the two cohorts. When you looked at the morbidities incurred in ICU and IMV use, and the highest morbidity was in infants less than 6 months. Again, to point out, the morbidities were not indifferent for infants between 32 to 35 weeks gestation across the board. And this was a study conducted by Evan Anderson for Emory. When you look at the comparison of our study conducted in the Northern Hemisphere versus the Sentinel study that I've just shown you, you can see that in the Sentinel study, the ICU hospitalization rates for children who did not receive palivizumab were much higher, but that's not surprising because they were of a lower gestational age compared to our Northern Hemisphere study, as was the use of mechanical ventilation.
Excuse
me,
you have 5 minutes.
Sure, absolutely. When you look at the cost of RSV infections across 10 databases by Diana Bowser from Massachusetts, and this is divided between the Medicaid group, which is the low-income group, versus the commercially insured group of infants, you can see that the costs correspondingly climb quite significantly in the extremely preterm infant, irrespective of whether they received care through Medicaid or commercially. Victor Shirikoff looked at the 5-year difference in the all-cost burden between RSV-infected infants and controls, and you can see the cost in US dollars, and across the x-axis, the gestational age categories again. And again, not surprisingly, the highest costs were in the lowest gestational age categories between 24 to 28 weeks, and then the cost correspondingly dropped into the term population. Majority of the costs were associated with physician and emergency room visits, which were highest in the first year of life, and majority were for asthma and wheezing, which constituted 10 to 18% of the total 5-year GP visits. So this is my second last slide to just bring you straight into the strategies on the horizon to prevent RSV infection. So the first and most important is to consider maternal immunization with an RSV vaccine. And you all know that the initial interim analysis of the pre-fusion F protein, which was published by Eric Samois from Denver in Colorado, shows that immunizing moms, in fact, provides good antibody transfer to their baby in terms of protection against medically attended RSV illness and RSV hospitalization. In early childhood, we have the extended half-life monoclonal antibodies, which are on the horizon and which will quickly come into play, perhaps to replace palivizumab. And then the live attenuated vaccine that we can give to young infants between 4 months to 7 months. This is still on the horizon and will probably take another 2 to 3 years to arrive to us. So my take-home messages are that all infants, especially those who are preterm, are extremely high risk for RSV hospitalization and do incur substantial morbidity, as I've shown you, with concomitant healthcare costs. Don't forget about the socioeconomic burden and the family stress, which we tend to forget, which is associated with RSV hospitalization, and it is truly significant. Monoclonal antibodies with a prolonged half-life and RSV vaccines offer potential to treat all infants, irrespective of their risk, and reduce the short and long-term burden of RSV illness if the new products and the vaccine are considered cost-effective. Thank you, and that was my last slide.
Thank you very much, Prof, for this excellent presentation. We'll leave the question to the end of the session.
Okay.
Now I will present the last speaker, Professor who had been yesterday with us, Professor Joseph New, Professor of Pediatrics and Department of Pediatrics, Division of Neonatology, University of Florida, College of Medicine. He's going to talk to us about the prevention of necrotizing enterocolitis.
Okay, can you see my screen?
Yes.
Okay. So, yeah, the title of my talk is actually a little bit different. I'm not going to talk so much about the prevention of necrotizing enterocolitis. I'm going to give you a little update on necrotizing enterocolitis. And my goal of this lecture is to make you really think whether this is a distinct disease or not, and that also for you to understand that the way we have been approaching this problem that we call necrotizing enterocolitis may be a little bit off base, and we need to change some of our strategies for looking at this. Let's look. Yes, can you see
me?
Yes.
Can you see slideshow? You're doing it on presenter show.
Okay, slideshow. I have a, can you see this? Yeah, please.
Joseph, if we just click on the large bar that I'm showing you here, it should come as a slide presenter show.
The large one?
Yeah, click on that.
I am ticking on that, and then I go over here. That doesn't do it, huh?
Yeah, that does it.
Yes.
That does it.
Yes.
Okay. You saw the you see the covers of the two books.
Yes.
Okay. So again, I want to thank you for inviting me to do this, and at the end of this lecture, I want you to be very skeptical about what we are calling necrotizing enterocolitis. So let's go back in history a little bit. In the mid-1960s is when neonatal intensive care really started to become entity of its own. And on the left here, we see the cover of Alexander Schaefer's textbook, Diseases of the Newborn. And if you look closely into that textbook, you see nothing about necrotizing enterocolitis. 6 years later, in the Diseases of the Newborn by Schaefer and Avery, you see a few sentences, maybe close to a paragraph, about this entity that they are calling necrotizing enterocolitis. So this is actually something that is a relatively new diagnosis. And if you look at the literature, just a couple of years ago in pediatric research, there was this article about defining necrotizing enterocolitis, current difficulties and future opportunities. And here I have highlighted, in this review, we summarize 8 current definitions of NEC and explore similarities and differences in clinical signs and radiographic features included within these definitions, as well as their limitations. Now, I think we need to consider this, because if there have to be 8 different definitions for a certain, what we are calling an entity or a disease, we have a real problem. And if we want to actually be able to prevent and treat this problem, we have to have a more discrete idea of what is going on. And so we have to be able to define this much more readily than what we are doing right now. But trying to define NEC might be futile. And is what we call NEC a distinct disease or just a diagnosis? Now, we have several problems that I would consider to be, quote, imposters of necrotizing enterocolitis. And when we try to define necrotizing enterocolitis using the Bell's staging criteria, stage 1, 2, and 3 necrotizing enterocolitis, we run into many problems. For example, what is stage 1 necrotizing enterocolitis? Now in 2022, we are saving many babies that are less than 25, 26 weeks gestation. And most of these babies have some abdominal distension, some feeding intolerance, some apnea and bradycardia, some instabilities. And all of these babies would fit into what Bell called stage 1 necrotizing enterocolitis. But there is no necrosis of the intestine in these babies. Stage 2 also is highly problematic because it relies on radiographic techniques primarily, and this does not necessarily give us high sensitivity and specificity for diagnosis of intestinal necrosis. Stage 3 is also problematic because oftentimes what we see is a radiographic finding of pneumoperitoneum, and that suggests that there has been a catastrophic event in the intestine, but we cannot separate spontaneous intestinal perforation from necrotizing enterocolitis until we actually take a look at the intestine. And so these staging criteria, I think, are now an anachronism. We also have babies with hypoplastic left ventricle, interrupted aortic arch, that do not provide, where not enough blood flow is provided to the gastrointestinal tract. And this should not be called necrotizing enterocolitis. This should actually be given a totally different name, something along the line of cardiogenic ischemia of the bowel. Then we are beginning to recognize that there are variants of food protein-induced enterocolitis syndrome that appear to play a role here. Then we have congenital bowel anomalies that seem to be involved. For example, in the past month in our own neonatal intensive care unit, we had 3 premature babies that had signs of pneumatosis intestinalis, significant abdominal distension, that we put on bowel rest, gave antibiotics, that ended up having Hirschsprung's disease. And so there are many mimickers of and imposters of this umbrella term that we are calling necrotizing enterocolitis. And here I'm just going to give you some additional examples. This is a radiograph that was taken not because the baby was having bowel issues, but because the baby was having some respiratory issues, and the radiologist looked at this x-ray and said, here in the right upper quadrant, there's a bubbly appearance, cannot rule out pneumatosis intestinalis. We as neonatologists, when we see a report like that, get very concerned. We frequently will put the baby NPO for 7 to 10 days, suction, antibiotics, treating the baby for what we consider to be necrosis of the intestine. because we are afraid that this may be the case. In this particular baby, what we did was we re-examined the baby, and the abdomen was soft, repeated the x-ray a few hours later, and that was all gone. And this was probably stool in the lumen of the bowel, sometimes referred to as pupatosis. Here we have a radiograph that obviously shows something abnormal. This is a 25-week preterm, 5-day-old infant who was on prednisone, had hypotension, and developed this very distended abdomen. The baby was taken to surgery, and at surgery, this was found. There's no necrosis of the bowel, but in the distal ileum, there's a small perforation. This is something called spontaneous intestinal perforation. Again, no necrosis of the bowel. But many of these babies get diagnosed as having necrotizing enterocolitis, and frequently surgeons do not even take a look at the bowel. What they do is they place a drain in the abdominal cavity, and these babies get diagnosed as having necrotizing enterocolitis. There is no specific ICD-10 code for spontaneous intestinal perforation in the preterm infant. So this is problematic. We also have babies who respond to certain food proteins in an abnormal way. And this is from a review article that we wrote in Journal of Pediatrics, where we found 5 babies who had some abdominal distension, bloody stools, that were initially thought to have necrotizing enterocolitis. But these babies resolved fairly quickly by providing them with highly hydrolyzed formula feedings. This is an entity that is called food protein-induced enterocolitis syndrome. The problem with FPIES, or food protein-induced enterocolitis syndrome, is that we do not have a good biomarker that separates this from other forms of intestinal injury. So this is problematic. Now, in 2011, Dr. Alan Walker and I wrote this review article on necrotizing enterocolitis in the New England Journal of Medicine. And here we see a picture of a baby with what we called classic necrotizing enterocolitis at that time. This was 11 years ago. This is a baby who has a distended abdomen, some periumbilical erythema. On X-ray, if you look closely by this arrow, you see some gas in the bowel wall. And in this arrow, with this arrow, you see some gas in the liver. This is vascular gas in the liver. And this baby continued to do worse and worse and was taken to surgery. And this baby did have a piece of necrotic bowel. And at that time, we considered this to be classic necrotizing enterocolitis. Now in 2022, I'm beginning to wonder if there is such a thing as classic necrotizing enterocolitis, because there is such a heterogeneity of intestinal dysfunctions that we are calling necrotizing enterocolitis. So when we want to provide the information about the pathophysiology of necrotizing enterocolitis, we have major problems because we do not have a good definition of the disease. So when we talk about current concepts of pathophysiology, diagnosis, and treatment, we are in trouble with necrotizing enterocolitis. But what I'm going to do over the next couple of minutes, I'm going to give you a little bit of information about some of the studies that have been done over the last 10 or so years that give us some idea of what is going on with some of these intestinal with some of the intestinal pathologies that we are calling necrotizing enterocolitis. We think that genetics plays a role in some of these intestinal dysfunctions. Certainly immaturity of the bowel with immaturity of the vasculature, motility, barrier dysfunction, innate immunity plays a role, and also microbial dysbiosis. And I'll just talk about some of these very briefly. But here's an interesting question. Where is hypoxia, ischemia in feeding? In the past, in the 1980s, 1990s, early 2000s, and even now, we think that hypoxia ischemia plays a major role in the formation of classic necrotizing enterocolitis. But we are beginning to recognize more and more that this probably does not play a role. And feeding by itself does not play a role. Probably the lack of feeding plays more of a role than actually feeding the baby. Now, what about this hypoxia ischemia? In the late 1970s, it was thought that hypoxia ischemia played a major role in the development of intestinal necrosis. And because of this, an animal model was developed at Columbia University by Doctors Pitt and Barlow. And what this animal model involves is asphyxiating baby rodents for a period of time and subjecting them to major stress to develop necrosis of the intestine. And so here's just a picture of what is done with this model. The baby animals are placed in this plastic bag for 7 to 8 minutes until they turn blue and they're gasping. They're almost dead. You take them out and you put them into a refrigerator and you subject them to cold stress. You take them out of the refrigerator, you feed them with a feeding tube with something totally different than what they would be getting from their mothers. And guess what? They do develop intestinal necrosis with this high level of stress. But this is not anywhere near what we see in our preterm babies with what we are calling necrotizing enterocolitis. And this is highly problematic because we have so many studies. There are at least 250 studies in PubMed using this model or some adaptation of this model for studying the pathophysiology of necrotizing enterocolitis. And I think that this is leading us astray. Why? Well, one of the findings over the last several years is that the corrected gestational age seems to be important in terms of the timing of necrotizing enterocolitis. Similar to retinopathy of prematurity, we rarely see retinopathy of prematurity prior to 30 weeks corrected gestational age. And here is the peak timing of necrotizing enterocolitis in our preterm babies, between around 29 to about 31 weeks. And what is happening at this time? Well, there are microvascular changes. Just as in the eye, there are microvascular changes in the gut that are occurring at this period of time. The intestinal barrier is still immature, with tight junctions between epithelial cells not very tight, and allowing antigenic material through to allow for an inflammatory response. We have a high level of toll-like receptor 4s in the last part of the second trimester of pregnancy. And we have microbiota changes that occur during that period of time, which leads to a perfect storm for intestinal inflammation. So here's just a little bit of information on this. Here's a term baby, and here's a very preterm baby. And we have major differences in the intestine, with differences in the mucus layer, with the types of cells, with the junctional epithelium being closed, very tightly closed in the term baby versus not closed in the preterm baby. The types of microbes that develop are very different. And one of the reasons for the difference in microbial development is our major use of antibiotics in our preterm babies. There's also lack of feeding in these babies over prolonged periods of time. And this leads to a dysbiotic microbiome, as I was talking to you about yesterday. And here's just a picture from studies that were where we took the DNA profile, the microbiome profile from 8 different neonatal intensive care units, and looked at the microbiome profile from 24 weeks to 38 to 36 weeks gestation in control babies. And these are babies who subsequently developed what was diagnosed as necrotizing enterocolitis. And here you see this blue increases in the necrotizing enterocolitis babies, but it doesn't increase here. The gold green decreases. So you have major microbial shifts. And these microbial shifts are toward what are called the proteobacteria, which are largely gram-negative and have large quantities of LPS or lipopolysaccharide in their cell wall. And as you probably recall, lipopolysaccharide stimulates toll-like receptor 4, and toll-like receptor 4 stimulates an inflammatory response. Again, perfect microbial storm for the development of intestinal inflammation in these babies, especially those babies who get high amounts of antibiotics. And so what are some of the common neonatal practices that may actually lead to more intestinal inflammation? I don't have enough time to get into all of these, but I'm going to just talk about a couple of them that cause dysbiosis that predisposes to intestinal inflammatory responses. And one of the major ones is our use of antibiotics. And in babies less than 33 weeks gestation, almost all of them get at least 2 days of antibiotics. And the most commonly used drugs, antibiotics in the United States, are ampicillin and gentamicin. And this is potentially problematic because it causes what I talked about yesterday, a dysbiosis. And only 2 days of ampicillin and gentamicin can increase the proteobacteria in the babies. Here are treated babies. Yellow is the proteobacteria, and here are the controls. Many more proteobacteria in those treated than in the controls at 4 weeks and also at 8 weeks after birth. And this is considered to be a dysbiosis, which leads to a greater inflammatory response in these babies. So what have we seen in terms of retrospective observational studies? The longer these babies are on antibiotics, the greater the odds ratio for the development of necrotizing enterocolitis. So 5 to 7 days of antibiotics increases the odds ratio for the development of necrotizing enterocolitis by 50%.
Excuse me, you have 5 minutes.
Okay, yes. And so here's the scheme that shows the intestinal inflammatory responses that are predisposed by the altered microbiota that we think are caused by antibiotics. But the problem here is that we are talking about associations and not causality. And this is something that we have to begin to address in the future, is getting away from associations and getting more toward causality. And how can we do this in babies with these intestinal problems? Well, one way is to use multiomics. I talked to you before about use of the microbiome, and we see associations of different microbes with the development of intestinal necrosis. But this may not be enough, because all that does is give us an association. And here's a little parable that I like to use. It's a Hindi parable about the 6 blind men of Hindustan. And each one of these blind men was asked to feel a part of this structure. They did not know what this structure was, but one went to the side of the structure and said, this feels like a wall. The other went to the back and said, this feels like a rope. The other went to the front and said, this feels like a spear. They got together, they argued, and they could not determine that this was an elephant, because they were so stuck in their own little niche of what they were evaluating. Well, we do have this new field called multiomics, where you can take the genomics, epigenomics, the proteome, put these together and integrate them using artificial intelligence techniques and get mechanistic schemes from putting these together. And I think that this is where we will be going in the future with many of our problems that we see in neonatology, as well as many other fields of medicine. And here's just an example with inflammatory bowel disease. And this is a study that was reported in 2017 in Nature. And with each one of these omic layers, the exposome, genome, microbiome, you get secondary mechanisms or associations. So these are each one of the blind men, but here are the blind men talking to each other, or the integrating these different omics. And with the integration and actually talking to one another and developing the mechanistic schemes, we will have a much better idea of primary mechanisms, molecular classifications that will lead to personalized therapy. And we need to have a similar study for intestinal dysfunctions in neonates. So I'd like to stop here and give you some idea of where we might be going in the future with this. But we have to really begin to consider forgetting about the term necrotizing enterocolitis completely. We have to make believe that the term necrotizing enterocolitis never existed for neonates. So we go back to the late 1960s, retrospectively evaluate a large data set of preterm infants with various forms of feeding intolerance, putative intestinal problems, and then cluster these different phenotypes using artificial intelligence techniques. And then once we have these clustered, we can then look at their pathophysiology of each individual cluster and develop biomarkers that better differentiate these more discrete clusters. And then we can study the pathophysiology of each one of these to develop preventative and therapeutic measures. I want to thank you for your attention.
Thank you, Professor Neo. I would like to ask Dr. Mansour Qarashi, please, Professor Bosco and Professor Neo to join us for the discussion for the final session for today. Is there any question? Is there any question from the audience or any comments? Dr. Bosco, can I ask you a question? Meanwhile, my colleagues prepare their questions if they have any. Regarding the RSV criteria, you know, it was too liberal, and in the 2014, the AAP established a new, very limited criteria. So do you think it's the time now to revise it, or what, and which criteria you are using? Thank you.
Thank you very much. That's a great question. Absolutely, I would fully agree with you. It's time to take another look, and based on the more recent evidence that has emerged after the new guidelines were implemented, and the tremendous increase in both morbidity and health resource use and costs in infants who failed to receive prophylaxis between 29 and 35 weeks gestation, tells us that it's time for change. And in fact, apart from the study that I showed you, which was the Sentinel study conducted by Evan N. Anderson from Emory University, similar studies were conducted across the world. Certainly a good example of that was Italy, where in fact they saw a dramatic change after they stopped using prophylaxis in the cohort. And in fact, they approached the Ministry of Health and Long-Term Care in Italy and said the morbidity had increased, the costs had increased. And in Italy, they reversed their guidelines fairly quickly thereafter to accommodate prophylaxis for infants up to 35 weeks gestation. We did a similar study also in Quebec in Canada. And what's more, we showed that the burden of illness correspondingly increased after palivizumab was stopped. And more importantly, when they looked at cost, it was actually cost dominant to prophylax these infants between 32 to 35 weeks gestation. So I think we've got sufficient evidence from after the guidelines were implemented that the burden of illness, the associated costs have increased quite significantly. And I think it's time for change. Absolutely. And of course, must always take into account the cost of palivizumab, right? Because the current cost of palivizumab, we do appreciate is substantial. And that is why we have developed risk scoring tools, both locally applicable in Canada and more recently an international risk scoring tool that can be applied to various populations across the world, which will target RSV prophylaxis in a moderate to high-risk infants who are between 32 to 35 weeks gestation. So based on country available budgets, you can negotiate to target specific infants in that cohort that have the highest risk for RSV hospitalization. Great question.
Thank you, Dr. Bosco. Dr. Khalid, you have a question?
Yes, thank you. I would like to thank all the speakers for the excellent presentation. My question addressed to Dr. Joseph New. I'd like your presentation, it was intriguing, but what is the point now? What we call baby with abdominal distension and feeding intolerance, under what title we call them?
Abdominal distension and feeding intolerance. I think that if you begin to call this necrotizing enterocolitis, it's a misnomer. It's a misdiagnosis because there is no necrosis of the intestine, and I don't think that we are being accurate. So we need to, rather than dig deeper in this hole, we need to begin to work our way out of it and begin to think more toward a newer paradigm. And I'm sorry, but you know, this is I think that this is a fact of life. We have to be adjusting and changing with our new information.
Thank you,
Dr. New, if you allow me, just as a neonatologist, we usually are a little bit proactive, and we are ahead of the babies before he got sicker and sicker. So we've just call it feeding intolerance or abdominal distension. So we will know that he has NIC after already is perforated or it's too late. And we cannot tell they have necrotizing enterocolitis by just looking at the baby, but maybe we become more conservative. So if you think that we will not call it NIC, that means we have to change our management in those babies. So what to do with those babies that they have vomiting?
I disagree. I disagree. I don't think you have to change your management. I think that if you have a baby who is having signs of feeding intolerance and the baby is getting worse, you don't have to call it NEC or pre-NEC. You have to adjust to say that the baby is having feeding intolerance and that you pull back on your feeding at that time, and you may want to just monitor that baby more closely with several different technologies that are available now.
Thank you, Dr. Steph, Dr. Joseph. Is there any? We will take one last question before we go for. Yes, Doctor, please.
Thank you, Marshall. I just want, this is again a question, RSV burden. Concerning the risk, Canadian risk, scoring risk for RSV, is atopy, is the atopy in the family, gives a positive score or negative score. This is one thing. And the other thing, why these babies in the group 32 weeks to 35 weeks plus 6 days are more liable for infection than, say, 30 and 31 weeks or so. These are two questions I just want for further clarifications.
Is the question clear, Dr. Bosco?
Absolutely. Thanks very much for those questions, which are very important to consider. So certainly when we did our risk scoring tool, you are correct. We were astounded to find that, in fact, having atopy within the family was protective against RSV. And we found it difficult to explain it. But at the same time, in fact, Jonathan Mansbach from the US looked at risk factors for RSV hospitalization in this cohort of infants who were attending the ER, and similarly found that, in fact, atopy was protective. So we decided to think about this a little bit further, and we felt perhaps it's the immunogenetic profile in these particular families who have atopy that offers some sort of protection. The other hypothesis that we came up to was perhaps the parents of these kids with atopy, in fact, afford some sort of protection. And very quickly, actually, after our publication, there was a very nice study conducted in the US looking at behavioral aspects of parents who had children with atopy and showed very nicely that, in fact, These children are semi-protected against the environment. And in fact, these parents don't allow them to go out to play with other kids. They, in fact, protect them from going to the malls. They tend to keep them in their household. They tend to have single caregivers for them. So we think that it is multifactorial. However, when we re-examined the same thing in the COREST study in children who had received palivizumab, we found that atopy was a risk factor as compared to the risk scoring tool. So I think that's an important question to be raised. And we still, in fact, when you look at our risk scoring tool, for the factor for atopy has a relatively low number of points. So I think that's important. And your second question was in relation to RSV hospitalization in these various subgroups of infants. So when we looked in the our risk scoring tool as it was developed, children who were low risk, who had a score of 0 to 48 in our risk scoring tool, the risk of RSV hospitalization was 1.7%. When the score climbed to 49, between 49 and 64, the incidence of RSV hospitalization climbed to 7.1%. And when we got to a risk score of 65 to 100, the risks for RSV hospitalization climbed to 18.7%. So you can see it doesn't make sense in this cohort of 32 to 35 weeks infants to perhaps offer prophylaxis to all given the cost of palivizumab. It may be more important, as we do in Canada, to target the moderate and high risk group for RSV prophylaxis. So that's a great second question.
Okay, thank you, Dr. Wasco. I think we should conclude today's session and the second day of our conference. And I wish you all the best. And thank you, Dr. Mansour, Dr. Bosco, and Dr. Neo. Thank you very much.
Thanks a lot.
Thank you, Dr. Neo. Thank you, Dr. Bosco.
An announcement.
For you, the attendees here, I want just to do a quick announcement. Number one, thank you for staying with us till late today. I promise you tomorrow it will be less compressed. You will have only 3 sessions tomorrow. We'll try to make you go home early. Hopefully by 3 p.m. you will be finishing, all the program. Tonight we have appreciation dinner at 7:30 in the hotel. So those of you who want to join us, they are welcome. All of you, because you stay that late, you should maybe have the dinner, then you go home. So then you have your dinner and stay with us. Thank you for all. See you tomorrow, inshallah. La, only the dinner. Welcome all.